Funny things, you gotta tell me, how do we get out of this?
How do we get out of
Crazy crap that's going on.
the thing is, some of the pressure I think that we're doing in the town hall meetings all over, 8 to 10 Republicans wrote a letter to their leadership that they couldn't go along with the Medicaid.
Oh, really? They did?
That they supposedly were making any sense. Yeah. It was in Brandon should be able to get it for you.
Yeah.
So I'm hoping, but they said that they just couldn't go along with it like they are. So I'm hoping that, we only need 4 to agree. But of course, it's coming out of my committee, healthcare. So I don't know. I have to see how many of them are on that committee. That's what people have to realize their power. Hey, how are you?
Okay.
Good morning. Good morning. Good morning. As we start with prayer this morning, let's bow our heads for a word of prayer. Thank you, Lord. We have to start by saying thank you. You've been so good to all of us. And Lord, you've been so kind and gracious and merciful, and we say thank you, God. Thank you, God, because we have a task before us to spread health care throughout this country. We need your help, we need your strength, and we need your power. We need commitment, we need consistency, but most importantly, Lord, we need compassion. So strengthen us on the day, God, as we come together from the north, the east, the west, and the south. We need you, God, to continue to favor us, God, continue to favor our leadership, continue to favor us in so many areas, not just with what we do as collectively, but what we also do individually. For we all have issues going on in our life, God, and we thank you for it, God. So, Lord, let the day come, God, where health care is everywhere. Let the day come, God, where we have so many resources that we're looking for other opportunities to help others, God. And the more people we help, we need you to help us. So, Lord, continue to enlarge our coasts. Keep your hand on us. Keep us from evil. Allow us not to cause any grief or pain. It's in Jesus' name that we pray, and we all say amen.
Good morning.
Good morning.
I remind myself that I've done this now 25 times. Each time we assemble, I feel as if we have made some progress. And this morning, I'm really pleased to say that in the midst of the storm, I see opportunity. My attention, and I'm encouraging your attention, to be focused on 2050. Because by 2050, we need to have a healthcare system that has the capacity to take care of every American. And as I look at our legacy healthcare system, and I remind you, my degree's in history, right? So I tend to look at these things historically. And the legacy healthcare system was built in a period when inequalities were acceptable, when segregation was acceptable, when differential healthcare was acceptable. And it is embedded in the system that we have today. And so going forward, we have to reimagine. And so part of what I hope you take away today is we are giving ourselves collective permission to think about the future, to think about a healthcare system in 2050. And what we've done here down the hallways is introduce you to some of what Nmqf has been about. Nmqf is built around 6 centers. And each one of those centers has a booth. We have a Center for Health Information. We've collected over 5 billion patient records. We collect data on about 160 million lives a year, covering well over 100,000 different conditions. And we've introduced AI into that. And so I invite you to take a look at that booth. It's the early stages of AI, but nonetheless, you'll get a sense of where we're going. We have a Center for Public Policy and have worked very well with Congresswoman Kelly and her staff and members of Congress and state legislators. And I encourage you to have a conversation with them, because one of the things I've learned is that if you ain't advocating, you ain't getting it. And healthcare is a part of medicine. It is a branch of medicine now. And so if we want a healthcare system that works for everyone, then we have to advocate. And so I encourage you to speak with them. We have a Center for Sustainable Healthcare Quality and Equity. And I use the word equity, excuse me. I know in polite society, you're not supposed to do that anymore, but I still use it. That's our church network and our barbershops and beauty salons, because we want to be hyper-local. We want to be in community. And you'll see the programs that we've done in communities across the country. And so I invite you to go and speak with them. We have a Center for Communications and Public Affairs. We do 8 billion media impressions a year. We are the largest deliverer of healthcare information to minority communities, except for the federal government. So I invite you to speak with them. Lots of partnerships and opportunities, because one of the things that I've learned about social media is that you have to create that echo chamber. And you guys are working on stuff, and we're working on stuff, and to get those trusted voices out in community, we have to collaborate. And so we're looking for those kinds of deep collaborations to move that along. We have a Center for Clinical and Social Research. We actually do clinical trials. We have launched a site in Houston, Texas for our Cancer Stage Shifting Initiative, and I invite you to find out a little bit more about that. It is work that we're soon going to be doing in Flint, Michigan, and Cancer Alley in Louisiana, and Rubbertown in Kentucky, and with the Lumber Tribe in North Carolina, because at the end of the day, you have to have good science. Healthcare is about good science. And unfortunately, in our legacy healthcare system, they haven't studied what they call marginalized and underserved communities. And so we are building the scientific base, but we're not, as you can tell, armchair scholars. We take that information and we repurpose it through our church network and through our social media and through our Center for Public Policy. We have a Center for Professional Services. We work with clinicians in specialties, the Association of Black Cardiologists. We've started a nephrology group and looking shortly to launch one in oncology. So what you should understand is that is one Nmqf. They operate individually, but we also bring them together to work collectively, because our eyes are on 2050. Whatever's going on today has nothing to do with where we're going, right? Has nothing to do with where we're going. And I'll leave you with this final thought. I can say honestly, I don't know what the journey end looks like, but I do know the path to that endpoint. And that's the path that we are following here. We are following the path that the science tells us. We're taking that science and we're bringing it into community, because at the end of the day, there is no escape from good science and its application at the community level. And we have to help the American public understand that their health is associated with good science and its implementation. So I said all this to you this morning because we need your help and collaboration. Nmqf can't do this on its own. What we can do is reach out and say, let us work together. I believe that we can do really big things together. I think we can do really, really, really big things together. And so NMQF is absolutely committed to that. One of the great partnerships that we've had is with Congresswoman Kelly. It has been a fantastic partnership with her staff, with her, and her commitment to the communities that we care about. And every year I get to celebrate that partnership. And so it is really with a tremendous honor that I invite Congresswoman Kelly to come speak to us. Thank you.
I just want us to give Dr. Puckrin 25 years a round of applause. Good morning, everyone. He talked about the storm. Well, I'm in the storm, and beside being the member of Congress, I serve on Energy and Commerce and the Health Subcommittee, so we will be battling about Medicaid very, very soon. But thank you for joining us for this year's National Minority Equality Forum Leadership Summit on Health Disparities. As chair of the Congressional Black Caucus Health Brain Trust, I want to remind everyone how crucial these important conversations and forums are to ensure that our healthcare system is equipped with the tools and resources to take care of everyone in need of services. Now more than ever, it is so important that our healthcare system is backed by evidence-informed solutions that serve as catalysts for change, delivering medical breakthroughs that truly serve everyone. I want to acknowledge this year's theme, From Data to Action, Uniting to Advance Evidence-Informed Solutions for Medically Underserved Communities. One of the most important and challenging issues that families face is access to affordable and high-quality health care. My district is urban, suburban, and rural. I see the problem, urban, suburban, and rural. We see maternal health deserts. I have hospitals closing, urban, suburban, and rural, or decreasing their care in certain areas. Now more than ever, providers and policymakers are recognizing the need to remake our healthcare system so that the most vulnerable among us don't fall through the cracks. I am grateful for the work you all do to ensure that racial and ethnically diverse communities have access to the quality of healthcare they deserve. I couldn't do my work without you guys coming to my office, telling me what's needed, and informing, our staff, even though I have a very wonderful staff. I will be joining you for several events throughout the summit, and I look forward to sharing more about my work in Congress to address health inequities in our communities, reduce barriers to accessing health, and protect Medicare and Medicaid for future generations. Thank you again for your hard work. I look forward to learning more from all of you and the experts that we have assimilated. Your voices really, really matter. I want to say that again. Your voices really, really matter, and we need everyone off the sidelines now to be successful and to bring a little sunshine and get rid of the storm. So I know with all of us working together, we can get to health care for all. Thank you.
So I tell you, we have lots of partners, and I want to introduce you to some of our partners. First, Dr. Alexander Ding from the American Medical Association, member of the Board of Trustees.
Good morning, everyone. As Gary mentioned, I'm Dr. Alex Ding. I'm a board member of the American Medical Association, and it is truly an honor to join you today at the NMQF's Leadership Summit on Health Disparities. On behalf of the American Medical Association, I want to first thank the NMQF staff, but then also all of you here for your tireless commitment to tackling health disparities. The AMA is really proud to support this summit. Our partnership with the NMQF reflects our shared belief that achieving health equity is not optional. It is not a buzzword, but that it is foundational to achieving better health for all, and that everyone deserves to achieve their best health. We're really committed to advancing equity-centered care by advocating for access, promoting equitable research and data collection, growing a diverse clinician workforce, and educating both practicing and future physicians to better meet the needs of the communities that they serve. We recognize, of course, that no single organization can solve these challenges alone. That's why partnerships like ours are so important, bringing together leaders from healthcare, research, policy, advocacy, medicine, so critical and so essential. Over the past year, the AMA has really doubled down and strengthened its commitment to our work by publishing another iteration of our strategic plan on advancing health equity. Now, we know that the work ahead is not easy, that the path toward a truly equitable health system is long, and at times, it's uphill. But gatherings like this remind us that we are not alone in this journey, that by standing together, sharing knowledge, building partnerships, and putting our collective expertise into action, that we will advance the change that our communities all deserve. So I want to just welcome you, a big welcome to all of you this morning, and wish you all a fun, a productive, and an impactful summit. Thank you all so much.
I next want to invite Roger Mitchell, who's president-elect of the National Medical Association and president of Howard Hospital. Please.
Good morning, everyone. Good morning. Good morning. For those of you that are not from Washington, D.C., welcome to our fine city here in Washington, D.C. We're excited to have you here. When you leave the Conrad, make sure that you buy something from our local economy. It's an honor to be here as president-elect of the National Medical Association as well as president of Howard University. Our NMA serves as the foundational membership organization for Black physicians in this country. We are the oldest and largest group of Black physicians in this country, starting in 1895, and so excited to continue the work surrounding health equity. And so let me begin by thanking Gary and Brandon and the Nmqf and this ecosystem of individuals that are challenged surrounding the future of health equity. We are convening at a defining moment. Across this country, health equity is being tested, and in some cases, undermined. The headlines are sobering: rollbacks of Medicaid coverage, assaults on diversity in medical education, and policies to silence public health and public health communication, all of which affects the communities that we serve. So let's be clear. These are not abstract policy debates. They're decisions that determine whether a mother can access prenatal care, whether a child receives asthma treatment, or whether an elder must choose between medication and food. And so health equity is not a buzzword, it's a foundation of a just and humane health care system. And right now, that foundation is under pressure. But I stand before you not with despair, but with conviction, because I know this, that the NMA and Nmqf will never back down from a challenge, that we, together with all of you, convening, are the conscience of the healthcare system, and we are more vital than ever today. Together, our advocacy, our research, and our voices shape policy, they reframe narratives, and they protect lives. So we must defend the programs that keep our communities healthy. We must demand that clinical research includes those that are left behind, that are disenfranchised, that are disinherited. And we must ensure that the next generation of physicians reflects the full richness of our nation. And so, the work together that we have is urgent. But we're not alone in this room. All of you are thinkers and doers. You are those that will carry the torch towards health equity. And so we're going to seize the moment. We're going to develop the solutions. We're going to work hard together. We're going to collaborate. We're going to strategize. And so over the next couple days, you'll have the opportunity to do it, to put your minds in action, to do the things that are necessary. So this is not a time for us to shrink. This is a time for us to grow. It's a time for us to come together, lock arms, and know that the work that we're doing together is the work for a community and a healthier nation. So on behalf of the National Medical Association, I want to say welcome to this phenomenal gathering that you'll learn and collaborate together. And we will continue to be partners with you, not only over the next 2 days, but from the years to come. Thank you so much.
Thank you. I now want to invite Raphael Saenz from the National Hispanic Medical Association. Come and bring greetings. Thank you.
Good morning. My name is Raphael Saenz. I am the newly appointed Executive Director for the National Hispanic Medical Association. 2 months on the job. Thank you very much. It is an incredible honor to join NMQF today. And I'd like to thank Dr. Gary Puckering and his amazing staff for this conference. It is truly phenomenal. When you look at and you read the theme of this meeting, it is so vital that we start looking at how data can be turned into action, because the data are uncontrovertible, right? So it is very clear minority populations suffer from a lack of access, right? We suffer from lack of being able to be insured or access to affordable health care. And so now is the time to act, right? And I'd like to thank NMQF for putting together this forum that allows us all to come together and talk about how we can produce action on the data that we are seeing and how it's affecting our communities. So at NHMA, our mission is to empower Hispanic physicians and healthcare providers to lead efforts that improve the health of Hispanic and underserved populations. But we know that this doesn't happen alone. Like, we can't do this by ourselves. We need to come together. And so over the next few days, as you all convene, I encourage you to be bold. Talk about these big ideas that we can produce together, all of us, and produce better outcomes for our communities. Okay? It is important that we take this opportunity to share and to collaborate. And I want to let NMQF know, Dr. Puckering, NHMA stands ready to partner with you and make sure that your goals are successful, because if you're successful, we'll be successful. So again, thank you very much for having me here. I appreciate it. And if NHMA can be of service to any of you, please feel free to reach out. Thank you.
Well, I just want to conclude by just saying, and I think you've heard it from each one of the speakers, this is a moment of collaboration. We have to work together. So I encourage you during the course of this meeting to reach out, to think with us about how we collaborate and how we build logistical systems that we can take into communities that have been underserved and transform them. I think that's the work at hand, and NMQF stands ready to partner and work with each and every one of you. So have a good conference, and looking forward to the conversation. Thank you.
With over 300,000 annual births, our work in the maternal child health space clearly impacts our members. Interventions are so critical, knowing that mom is in a very vulnerable state once pregnant. Then, of course, that infant needs to get the best start possible to ensure a healthy adolescence and on to adulthood. If we can successfully reduce the barriers, both clinical and those barriers that stem from health-related social needs that are contributing to poor birth outcomes, we give our moms and the birthing family and that infant a chance at a healthy beginning. The work definitely impacts me personally. My nephew was born at a very low birth weight, suffered a stroke, and is now living with cerebral palsy. So much of what we do has impacts on individuals that we'll never meet, but will be certainly impacted, ideally in the most positive ways, by the interventions, by the program. I'm just hoping that once it's said and done, I did my part.
Oh, that's great.
Good morning, everyone. I know that the coffee is still settling, but we are going to go ahead and get started with the open plenary session of the National Minority Equality Forum. My name is Marvin Figueroa. I am a senior lecturer, visiting professor at Meharry Medical College, and I have the distinct honor of moderating today's conversation. And let me tell you that today's conversation couldn't be more timely. Across the country, state houses right now are debating the future of Medicaid, whether or not it's responsive to the needs of their population, and equally important, whether or not it's sustainable. Here in Washington, D.C., we have in this thing called budget reconciliation, which I say is a budget fight about our morals and who do we care for and who do we care about in this country. That conversation is unsettling for many because a lot is at stake in terms of Medicaid and its ability to take care of the least amongst us, but also a lot more than that, right? That's a big misunderstanding about Medicaid that we'll correct today. We're also going to talk about the marketplace. Another challenge is looming. Unless Congress acts, the enhanced tax credits that have made ACA coverage affordable may go away. Without action, premiums could spike, putting coverage out of the reach of many working families. In this moment, engagement is critical. And we're here not only to describe the landscape, but our goal is to also provide the information that allows you all to shape it. So here's a couple of things we're going to accomplish this morning. We're going to talk about Medicaid in the marketplace. Where is it? What are the challenges? And what can we do to make sure that we are active? We will talk about misunderstandings that we need to clarify so that we have the most accurate information when we're advocating. And we're also, more importantly, going to ensure that you all have what you need so that policy decisions don't widen the gap in coverage, but help folks cut that disparity in access and care. To answer these questions, I am joined by an incredible group of panelists. We have Lauren Aronson, is the Executive Director of the Keeps America Covered Coalition, where she champions efforts to protect and expand coverage through Medicaid and the ACA marketplace. We have Dr. Carrie Cochran McLean, Chief Policy Officer at the National Rural Health Association. She brings expertise on how Medicaid and marketplace impact our rural communities, and what it means for patients on the ground. We have Craig Kennedy. He serves as the CEO of Medicaid Health Plans of America, representing health plans that serve Medicaid beneficiaries across the country. And we have Dr. Perinda Khatri, CEO of Cherokee Health Systems. She leads one of the nation's most innovative integrated healthcare models, particularly focused on reaching the underserved populations. Folks, help me welcome our distinguished panelists. I should have had y'all wave so people know who's who, but we'll figure that out. We know who Craig is, huh? Craig, we're going to start off with you. Okay. One of the things that I wanted to make sure that happened in this conversation is that people had a sense of what is Medicaid. I know that Medicaid touches lives very differently, and folks know what Medicaid is generally. But tell us, what is Medicaid? Who does it cover? And any interesting facts that people should know as they think about Medicaid and put that in their brain.
Well, first of all, good morning. I know. Kind of expected like those blinds to come down, like the sun to come in instead of these bright lights, but that would be awesome. So anyway, I'm Craig Kennedy. I'm with the Medicaid Health Plans of America. I've been here about 5 years. Before that, with Clinicians for the Underserved, and before that with community health centers. And so along history of working with Nmqf, as a matter of fact. Where did Dr. Puckrin go? Anyway, so thank you very much. I really appreciate being here and appreciate the question. So let's just start with Medicaid. So I know you guys are all familiar with the concept of Medicaid, but it's extremely expansive. It's not one thing. It's not, oh, Medicaid populations in this country. It's not the one thing. It's not one thing. You can't talk about it and just say, oh, Medicaid. It is 40%, we cover 40% of all births in this country. We cover 60% of all nursing home care. One side of life, the other side of life. We cover 60% of Medicaid population, 80 million people, 79 and change. 80 million people are on Medicaid today, are insured through the Medicaid program. About 80 million people. So a big swath of America, about 1 in 5 people, are insured through the Medicaid program today. So 80 million people, about half of all births, about half of all nursing home care in this country. We also cover, we're the largest payer for substance use, mental health care in the country, cover foster children, cover justice-involved populations. So a diversity of people are insured through Medicaid. Age, blind, disabled is the traditional populations that people think of where Medicaid started, age, blind, disabled. But it's so much more than that. It's such a wide range of folks across the country. And so it's a diverse population. And so that's Medicaid in a nutshell.
Yep.
I can go into kind of the structure if you.
I was in Connecticut a couple of days ago, and they had Husky Care. And when I used to work for California, it was Medi-Cal.
Medi-Cal, exactly.
What's the difference?
So every single state runs it differently. So Medicaid is a federal-state partnership. So you heard even from this morning about the federal role within the Medicaid program, which is most of it. The federal government mostly funds the Medicaid program. They are the largest funder of the Medicaid program. But states also put in a portion. They have a matching percentage. Every state is different, but it has a matching percentage of their Medicaid program. So, and every single state is empowered to run their program differently. So the federal government mostly funds it, but the states run it. So all of the states have a different Medicaid program and run it differently. Most states, 43 now, Idaho just came into the fold, most states run it through managed care companies, my members. So the members of MHPA, Medicaid Health Plans of America, the health plans that are members of ours, run the programs in conjunction with the state. The state contracts, 43 different states, contract with private plans, and those can be for-profit, nonprofit, single state, multi-state. They can be a whole range of things. The state gets to determine how they're going to do it. But they're run, every single state is differently. You mentioned California. Digress. California is practically run at the county level. It's not just run at the state level. So you have to go all the way down to the county level in California to determine what your Medi-Cal plan is named within California. So they name them different, they run them different, but it's mostly funded by the federal government, but run by the states.
Great, thank you for that. Lauren, I'm going to turn to you for the marketplace. It sounds very abstract. And I think as part of the Affordable Care Act, it used to be called Obamacare until it started working. Can you give us a sense of what the marketplace is, what trends are we noticing and seeing, and what are the challenges ahead?
Great, thank you. Thanks for the question, Marvin, and thank you for having me. I'm very honored to be on this panel and in front of all of you this morning, and I'm glad everybody is caffeinated. So I'll just do quick 30 seconds about our coalition. So Keep Americans Covered is a coalition of patients, consumers, hospitals, physicians, rural healthcare, really just working to ensure that the marketplace can continue to thrive and grow for the 24 million people who rely on it. So as Marvin noted, people can call it many different things. Obamacare, the Affordable Care Act marketplace, and traditionally known as the individual health insurance marketplace. So people purchase their coverage in different ways. And through the Affordable Care Act, millions of Americans get a tax credit to purchase coverage. And so if you are in a situation where your employer does not offer coverage, you're not eligible for Medicare or for Medicaid or for CHIP, the ACA provide a marketplace where anyone can go and get individual health insurance coverage. And if you're at a certain income level, you get a tax credit to help you make your premiums and out-of-pocket costs more affordable. And so what we've seen over the last 10 years or so is an increase of enrollment in the ACA marketplace. Specifically, since about 2022, marketplace enrollment has increased from 12 million individuals to 24 million. And the reason why 24 million people are now covered in the marketplace is because of the enhanced premium tax credits. So when Congress did the ACA, it was the tax credit itself. But during the pandemic, President Biden and Democrats in Congress worked together to make that tax credit more generous and also expanded eligibility for the tax credits. And so what we've seen here is that that was a real game changer for millions of Americans. And so now we have 24 million people who are getting coverage, and almost all of them are getting that enhanced tax credits. The challenge we're facing, as Marvin noted, is that that individual, that enhanced portion of the tax credit that has helped so many millions of Americans, that portion is time limited and will go away at the end of the year unless Congress acts. So as we're thinking about what's at stake here, as Marvin noted, we're gonna have premiums that are gonna skyrocket. Families will, on average, see a premium increase around $10,000 per year. That is astronomical when you think about what is happening in our country right now from an economic perspective, cost and security. For a couple who is around age 60, their premium increase could be around $17,000, and it will vary state by state, but these are really significant numbers. And most notable, I think, is potential coverage loss. So estimates have ranged from 4 to 5 million individuals who will lose coverage, and particularly for communities of color, our estimates are at 3.7 million individuals will lose coverage. It will simply become unaffordable. So as we're thinking about all of the challenges that we're facing and we're going to discuss today, ensuring that the tax credit's able to get extended is absolutely critical for our nation.
Great, thank you. And Dr. Cochran-McLean, comment was made about potential loss of coverage. Rural communities face unique challenges to begin with. Can you talk about what those challenges are? And then what does it mean for coverage to go away in these places?
Absolutely. Thanks, Marvin. And you can call me Carrie. So hi, everybody. It's great to be with you this morning. Again, I'm from the National Rural Health Association, and our organization really tries to be a voice for rural healthcare at the national level, representing patients, providers, community-based organizations, academic organizations. Anyone who has an interest in rural health has a home at NRHA. And you're right, Marvin, we in rural America, individuals have much more reliance on public payers, so Medicare, Medicaid, marketplaces. And as we think about these pending cuts to these programs, there will be a disproportionate impact on our rural communities, the individuals who live there and the providers who care for them. So if we think about just breaking down those numbers a little bit, Craig talked a little bit about some of the percentages with Medicaid. We've got about 40% of the kids in rural parts of this country are covered by Medicaid. 50% of the births in rural areas are Medicaid, and about 20% of adults. So it is a significant source of care and coverage. We also, in the marketplace, see similar numbers. For lots of reasons, health insurance costs more in rural communities, and so our populations have really benefited from not only the marketplace, but the enhanced subsidies. And if you look at numbers, we've got about 28% higher percentage of folks in rural areas who are having increased savings to their premiums and their coverage thanks to the marketplace. So it plays a really important role. And part of that is because if you think about our rural communities, we have fewer job opportunities. There tends to be folks with lower incomes and more self-employed or smaller businesses that may not have the opportunity to offer employer-sponsored insurance in the same way. And so when you think about what Medicaid and what EPTCs or the premium tax credits have brought, they really allow rural populations to have savings on premiums and more kind of zero premium plans. And this is all really important when we think about rural communities, because in addition to kind of having, unfortunately, some of those lower incomes, fewer job opportunities, we have a tough population to serve as healthcare providers. We see more preventable premature deaths in our rural communities. And that, I think one statistic that always kind of floors me when I think about this is in 1999, our mortality rates or death rates in rural areas was 7% higher in urban. You fast forward to 2019 and it was 20% higher. So our populations who live in our rural communities, just, you know, if anything, we should be investing more, not thinking about how we cut their access. And when you think about that coverage piece, and I promise I'm almost done, I could go on all day here, but when you think about that coverage piece, the other part of this that I don't know that everyone connects the dot is that, you know, you have an individual who's got, you know, let's say a coverage through the marketplace, or you've got coverage through Medicaid. These are your neighbors, the folks you run into at the grocery store, the folks you go to church with. The providers in those communities are going to continue to see those individuals when they lose their coverage and they're paying out of pocket and they're doing the best they can to pay their provider at the end of the day. And so that impact of losing coverage, you know, we think about the individual, but it has such a rippling effect across the entire rural healthcare infrastructure. And that infrastructure cannot stand further strain. I can spend a lot of time talking about that too, but we've had 190 hospitals close or discontinue inpatient services, meaning they're not providing care like you think of a hospital, since 2010, in the last 15 years. And the financial status does not look good there. And so cuts, again, will not only disproportionately impact those individuals who are covered by Medicaid and Marketplace, but the providers and everyone else who goes to seek care from those providers.
Great, thank you for that. That's a good segue. Dr. Katri, you're on the front lines of delivering care.
Yes.
What does it look like when Marketplace and Medicaid instability shows up in a patient's life?
Yeah, so thank you, and I'm honored to be here. I am representing a community health center, FQHC, for those of you who are more familiar with the 330 statute. But so community health centers really were started as part of the civil rights movement. And they had a very clear charge to provide care to everyone, regardless of ability to pay. That's our mission, that is our charge. So you're absolutely right, Carrie. We see everybody. We are also patient run. So by statute, 51% or more of our board members have to be our patients. I tell our patients, you're my boss. You own this organization. And so for us in Tennessee, we have really a broad reach of 25 counties we serve. Most of our sites are in rural areas, but we also have sites in inner city, Chattanooga, and in Knoxville. We have 21 brick and mortar clinics, 2 mobile clinics, and 25 plus telehealth sites. So for us, Tennessee did not expand Medicaid. I tell this to everybody, and they're like, what does that mean? Okay, let me tell you what this means. Right now, if I look back at 2024, 25% of our patients have no insurance. 25%. At the height of the pandemic, it was 30%. And I have a distinct memory of the first wave of layoffs. If you remember in the beginning of the pandemic, all these people got laid off from their jobs. They lost their health insurance. All their practices that they were going to literally had on their website, go to Cherokee Health Systems, or that was part of, if you've lost your health insurance. So, you know, just here's where you go, here's the number. I have a memory looking out my window and seeing a line of people. This was people who worked at coffee shops, at the grocery stores, people who worked at every sector showed up and they say, I can't, I'm gonna die if I don't get my insulin, if I don't get my medicine, etc. So 25% of our patients are uninsured, 40% have Medicaid, which is in 10 care. Every state has their own name, it's our 10 care. And then 22% are commercial. The vast majority of those 22% are the marketplace plans. So from our perspective as a provider, yes, we have a charge to see everyone, but they're regardless of ability to pay. But it is not sustainable or scalable for us to continue with this 25%. And I'm gonna tell you this, if these marketplace credits go away, if there is further contraction in coverage, a lot of people not only will lose their health insurance, they will not be able to work, they'll not be able to get the access they need to care, to medications. We have many people, the reason they're able to be productive and do things that they enjoy and engage in activities is because they have the care that they need. So for us, here's the issue. Yes, and I've heard people say in the room with me, yeah, we know you're gonna see them anyway, what's the big deal? Listen, there is not some, magic fairy dust or fairy godmother sitting behind me saying, well, when one thing goes away, here's all this extra resources. We have community health centers and practices across the country that are one payroll from going under. One payroll. When there was a brief period of time where the payment management system for grant funding through HHS was frozen for a week, and we were fortunate, we've got some savings, but I talked to CEOs at 3 community health centers in Tennessee who said we have one payroll left. And there were community health centers who let people go. So the damage is much more dramatic and much more multifactorial than you can imagine. So the second point is you're gonna have more people who are uninsured, and here are the ripple effects. People will go without care. We ask people who come to us, we have walk-in clinics, what would you do if you hadn't come here today? 70% of them say, I would have gone to the ER, or I would have not gone care, and when it got really bad, I would have gone to the ER. So the health issues, the other concerns are not gonna just go away. The final point I will make is, for many of us who are community safety net providers, we don't just provide care. Every one of our sites has a food pantry. In the clinic in which I work, I still see patients. We give away 13,000 pounds of food a month. 40% of those recipients are kids under age 17. We provide transportation. We provide vocational rehab, career support for people who want to go back to work, particularly if they've had chronic mental health issues. We are a learning organization. We train physicians, psychologists, clinical social workers, nutritionists, pharmacists, nurses, nurse practitioners. We do that because we have built an infrastructure. So the impact is not just in one area. The impact is going to be at a much broader scale and a much deeper scale. So for us, this is a game-changing make or break time, and it's absolutely critical that we take action.
Thank you for that. And Craig, Dr. Khatri mentioned expansion. So there are a couple of states that have not expanded Medicaid, including Tennessee, but also Florida and Texas, that I read somewhere that if they expand, it will significantly reduce health disparities. Can you talk a little bit about expansion and what does it mean for racial disparities persisting and being removed?
Well, wow, a whole 20, another 45 minutes. Yes,
you have 3 seconds.
3 seconds. See me after. So the way the Affordable Care Act worked was They expanded Medicaid. The federal government said, we're going to encourage states, actually they thought they were mandating it, but they said we're going to encourage states to expand Medicaid up to this level, and we're going to pay 90% of the cost to make sure every state does it. And then the tax credits kick in, and the marketplace kicks in with subsidies from there. So we could have coverage across the spectrum.
It's like a layer cake.
Like a layer cake. And so, so the Medicaid portion was the base. But then the Supreme Court came back and said, it's kind of optional. And a lot of states said, we're not doing it. It's called Obamacare. We're not doing it. And what that ended up doing is it ends up leaving, I think it's about 4.5 million people without insurance that should be on Medicaid within the states that chose not to expand Medicaid. Less than 10 states, just happen to be a couple of them here. So just less than 10 states. But those states, and you mentioned 2, Florida and Texas. Of the 4.5 million, half of the uninsured that would be insured through a Medicaid expansion are in those 2 states. Wow. And so you have 2 states that would have millions more people insured through Medicaid. They can't qualify for the subsidies. They don't qualify for the exchange because Congress had assumed they would be on Medicaid. So there's really a hole. There's this hole where people are uninsured. Mention that. So, and what happens is, and I just want to make this real clear for folks, when you're uninsured, there is an operational side to it, but there's a personal side to being uninsured. And what that means in this country is that, I'm just going to give you a statistic here, the #1 cause of personal bankruptcy in this country remains healthcare. Medical debt, the #1 cause. There is a direct correlation between Medicaid expansion and personal bankruptcies in this country. That's fascinating to me. It says you are forcing people into bankruptcy, is what that means. She spoke about the choice of, can I wait until I go to the emergency room? What happens is you become bankrupt in this country if you don't have coverage. That's what it means. And it's a direct correlation. You can look at the map of the country, you can look at Medicaid expansion, and you can map it to personal bankruptcies in this country. It's fascinating.
Carrie, you mentioned the unique challenges of living in rural America. Can I get you to zoom in a little bit? Living in rural America and being Black.
Yeah. Can I just add on to Craig's point real quick? Of that population that is in the unexpanded states, 2/3 of the rural population are in unexpanded states. So again, you've got a disproportionate impact. And if you think about the map, and I'm terrible with geography, so I can't do like the hands to make the United States play.
Like
but
Michigan.
If you think about the map, where we have significant numbers of folks who are in non-expansion states, where we have our hospitals and other rural healthcare providers that are struggling the most, either financially vulnerable or have closed, it is in the south and southeast parts of this country. So there is, again, a disproportionate impact on certain populations. And there is a definite intersection between race, geography, and income in certain parts of our country. I think when people think rural America, a lot of folks think like the image that comes to mind is like a white male farmer, right? But it's so much more diverse than that. A quarter of our populations living in rural are racial or ethnic minority. So we have a very diverse population. We've got, of that kind of 24%, 9% are Hispanic, about 8% are Black, and about 2.5% are Alaska Native or American Indian. And when we look at kind of these issues of how the data spreads out across the country, it's not equal, right? We have so many of our rural providers who are in counties where 80-90% of who they are caring for are on Medicaid. And again, there are disproportionate impacts on certain populations as we think about these policy cuts that are being debated in Congress.
And Lauren, the debate in Congress on enhanced tax credits. Where is it going right now? What's the status of it?
It's a great question. So one of the challenges we're facing right now, and I feel like this is the understatement of the year, is that it's a little bit hard to break through. As you can imagine, there's so much happening. And when Congress is focusing on tax cuts and unfortunately cuts to Medicaid, the enhanced tax credit piece is getting a little bit of attention, but not as much as it needs to. And I think one of the challenges we're facing right now is that as Congress is moving forward on their reconciliation package and all of the changes they are making, and unfortunately potential cuts to Medicaid, those are proactive things that Congress will be doing. Whereas on the tax credits, unless Congress acts, the tax credits go away. And so it's a little bit of, you don't want Congress to act on Medicaid cuts, but at the same time, we need them to act to extend the tax credits. And so that's one of the challenges we're facing. But I will say we have phenomenal champions in Congress. We have Senator Shaheen and Senator Murkowski, who's Republican from Alaska, in the Senate, who are championing this issue in the Senate. And in the House, we have Congresswoman Lauren Underwood, who is fantastic. And so she is championing this issue in the House. And so what we've seen, though, is that on the Senate, there is a little bit more of a bipartisan discussion happening. I think that there's a recognition of what's at stake for patients if the tax credits go away. The challenge right now really is the timing. Because yes, the tax credits are in place through the end of the year, but the reality is that as open enrollment approaches in the fall, if Congress does not extend the tax credits until the end of the year, we're already past open enrollment. And so people's premiums will already be skyrocketing. And so when they're going to purchase coverage in October and November, it's going to be sticker shock. And so that is one of the challenges we're facing, is getting Congress to act fast enough so that way the reductions can be put in place as bids are being put together and plans are putting together their options for plan year 2026.
So consumer goes into the marketplace, sees that there's higher premiums. What does that consumer usually do, or likely to do?
They're likely to forego coverage, which is a really big challenge. I mean, we've talked about just what's happening right now in health equity and just the consequences of inaction, particularly from a cost perspective. And so people are going to look at their premiums and what is being offered and say, I can't do this. And that's going to leave them uninsured and going back to FQHCs, which is really just not a great place to be at all for anyone.
So person doesn't have coverage, needs care, goes to FQHC. Can you say no?
Well, we will do our best not to say no, but the reality is that you can't make something that's not there. Health centers closed during that one period of time where they could not access their grant funding. So there is no limitless pot of resources for FQHCs. The other thing I just want to point out is community health centers offer incredible care. FQHCs have the highest standards of care. If you look at the research, we save the healthcare system $24 billion a year, and because we keep people out of the hospital, we keep people off expensive meds. We report about 60 clinical quality metrics. Most private practices don't do that, but you can go online and look at every community health center and see what's our percentage of patients who manage hypertension? What's our percentage of patients who are well controlled for diabetes? And for us, I have to say, we've worked hard. At Cherokee Health Systems, we have for like 7 years in a row, been a national quality leader, which means we're either in the top 10% or top quartile. And that's a pretty big deal, particularly when you haven't expanded Medicaid. The reason I say this is we have a charge to serve everyone. But when we're looking at different people who have Medicare, particularly in rural communities, we're in communities where there is no provider. No one's going to go to White Pine, I know, because the mayor comes to us and said, we have an entire community here, 1,100 seniors. There's nowhere for them to go within 20 minutes. They're going to have to go 2 hours to get care. Can you open up a clinic? When we are stretched thin and thin and thin, right now I can say yes, but there will be a time potentially where I'll say, I'm really sorry. We can't do it. We cannot open in White Pine. We cannot open in Greenback, which is another place where we're looking. 1,100 people in this entire community. They're all spread out. And more and more, those are becoming manufacturing areas. So we are in rural areas, they're building manufacturing factories that they're not offering healthcare coverage. They need us to come in and provide urgent care. But the reality is that we have to say no because we don't have it. And it's not just saying no to uninsured. This means people with Medicare, people with commercial, people with Medicaid, across the board, there's going to be contraction in our ability to offer care. And you're not just pulling away just, a safety net clinic, you're pulling away some of the best health care that is out there. And that's what everyone in our community deserves. High quality, safe, equitable health care.
And if I could just add one point, I think the other thing here that's really critical is people are going to forgo their preventative screenings. They're going to forgo going to see the doctor. They're going to forgo going to see the dentist. And so all of these issues are going to compound the community, and we're going to have a sicker population. We actually announced our second ad this morning where we have a patient named Kenny who has a blood disease, and he's on the ACA marketplace in North Carolina, and he has enhanced tax credit. And he, in our advertising, really talks about from a patient perspective, what the tax credit means. And at the end, when we interviewed him, Kenny stood up and he said, the tax credit makes life possible, and health insurance makes life possible. And that's really what's at stake for patients across the country for all of these issues.
Great. Yeah. Thank you for that story.
If I could build off of that too, I mean, I think the other part that's so frustrating about this conversation, if you're listening to folks talk on the Hill about the Medicaid cuts, is, there is a line that you'll hear that says, protect our traditional Medicaid population, which is code for non-expansion and who knows whatever else. I try to be a little bit nonpartisan in my comments, but I think what is so hard about that is when these providers, and I'm going to talk about in rural communities, when they start to feel the financial strain, they have to make really tough choices. And one of the really, I will say, epidemics that we are seeing, or crises that we are seeing across rural America right now, is the closure of obstetric care. Yep. We have over 60% of our rural areas in this country no longer offer obstetric services. Obstetric services, believe it or not, are optional services to hospitals. They are loss leaders kind of across the board. And Medicaid, close your ears, Craig, Medicaid tends to pay half or less of what commercial payers pay for births. But we have at least half of our births in most rural areas are Medicaid. So when you start doing the math at the end of the day, and you have a service that is a loss leader, and you start to lose financial resource other places, you have to make tough choices, and obstetric care is one of those places. And if you're a woman with means in a rural community, you can go outside of your community for labor and delivery, for prenatal and postpartum care. But if you don't have those resources, if you are a working mom at home with kids and you can't go 2 hours to get your OB care, what options do you have? And so, it's closure of facilities, but it is, again, the rippling effect of these discussions is so much more than what's being portrayed in some of the conversations. And we really need, to the extent that you end up talking to folks on the Hill, it's so important that full picture is really communicated. And you talk about kind of what that means to people who have employer-sponsored coverage, who are on Medicare. Those services go away for those folks too, when hospitals who are 53% of hospitals in non-expansion states operate with negative margins, meaning at the end of the year, they have negative operating margins. And there's only so long you can do that. And there's only so many cuts you can take before you have to start closing services or closing altogether.
And so we talked about the marketplace, and then I alluded to Medicaid and the conversations that are happening in Congress right now. But I want to make it more explicit, Craig. Can you talk about what are the discussion happening right now in Congress about Medicaid?
Yeah. Yes, I can. But can I start with one comment, which is if Tennessee expanded Medicaid, you could make it to those communities. Mm-hmm. Right?
For sure.
You could be in those communities.
We are doing it right now, but I don't know if we could in a year from now.
But if they expanded Medicaid,
absolutely,
you'd be in a whole different place.
Game changer.
And of the states, when it was originally come up, Medicaid expansion, a lot of states said no. There's still some states that are still saying no. But every single ballot measure that sought to expand Medicaid passed. Think about that for a minute. Every single in every color of state, mainly red, because those are the ones that chose not to expand Medicaid to begin with. Every single ballot measure to expand Medicaid, South Dakota, Missouri, hard red states, all passed. Medicaid is a popular program. So let's change let me answer the question that you had, which is Congress right now is debating, they put in, the House put in an $880 billion savings goal within the committee that Representative Kelly sits in. That was when she said, I get to go back into this. Thank you.
She does not support.
Yeah.
No.
Thank God we have her sitting there, which is that she gets to have that voice too in the committee while it's happening. But that may be happening within the next week. Next week, the Energy and Commerce Committee is set to have a markup on this topic. Meet that $880 billion savings goal. Largely within their jurisdiction, it's just the Medicaid program that can get there from here. $880 billion is a big number. Let me give you an example of how big
Can I pause you real quick?
Yes.
Savings is very DC speak. What does savings mean?
Mm-hmm.
What does it mean to find $880 billion worth of savings?
It means that they have extrapolated how much they think they're going to spend, and they need to cut $880 billion out of that spending over 10 years.
So it's an $880 billion cut.
Cut over a 10-year window. But let me tell you what that means. I know these numbers, we talk about billions and trillions here in this city, but $880 billion is about what the federal government spends on Medicaid each year. It's about $800 billion. So, just in real terms, if you cut $880 billion out of Medicaid over the next 10 years, you could do it one way, no Medicaid for 1 year. It's the same thing, right? Pick a year of the next 10. Dr. Puckrin spoke about the next 25. Think of the next 10. Which year do you pick that we're not going to have Medicaid? That will achieve the savings goal. That's crazy to me. That's how much money they're looking to save within this program. Just eliminate the program for 1 year. Wow. Right? That's the impact.
Can I just add something? And I think you made a good point, that savings is not fully accurate, because you can cut, but I'm not quite sure you're really creating the savings that you think you're creating, because there is a cost. There's a cost, and there's going to be an economic cost. There's frankly a moral cost.
Personal.
There's a social cost, and there is a political cost. So you can say, I'm going to cut. It's like, I'm not going to put gas in my car this week. I've saved $40. Well, you can't go anywhere.
You lost your job. You lost your job.
You're going to lose your job.
Yeah, you lost your job.
Right? You will probably get depressed because you're looking at four walls that you can't. You're not going to be able to get food. So savings, this is why it's important. It's a cut. I'm not quite sure it's a savings in any way if you look at the overall picture of the budget.
Great. You know it's getting good when people say, Carrie, come back into the conversation. So what does these cuts mean for disabled Americans? What does it mean for nursing homes and rural communities? What does it mean for the system in rural communities if these cuts go into effect?
Right. So I've thrown some numbers at you all, but again, just talking about the number of rural hospitals that have closed or discontinued inpatient care in the last 15 years, we've got 190 of those. We've got nearly half of rural hospitals overall in the country operating with negative margins. We've got another 432 that are vulnerable to closures. And I've talked a lot about rural hospitals because that's where we have access to data. But these trends are the same across long-term care, Marvin, that you mentioned, so skilled nursing facilities, around independent pharmacies, around independent physician offices. So the rural healthcare infrastructure in many parts of this country, and again, I'm giving you national numbers, but this looks very concentrated in certain parts of the country. And if I had my maps up here, you would see all the dark red, meaning the hot spots, the most vulnerable. I hate to say it, so many of them are in the south and southeast parts of this country. The healthcare infrastructure there is hanging on by a thread. I will reiterate that you start to cut around the margins, not even $880 billion, but let's say they do a small piece of that, or let's say the marketplace enhanced tax credits don't go through and people are going without coverage. Those numbers very quickly add up that you will see. I actually am not sure how we get through the next year of conversation, whether it's Medicaid or the marketplaces, without having some kind of effect of closures or service loss in rural communities. Because like I said earlier, we need to be expanding, we need to be supporting these folks even more, and we're going the wrong way. And we haven't even started talking about what's happening in the administration and the proposed cuts that are happening there, and I won't take us down that path, but it's not like anybody's wrapping around on the other side to make sure that these programs, whether it's health centers or rural hospitals, are getting kind of the support they need at the end of the day.
Great. And we'll be taking some audience questions shortly, but Lauren, what does it mean for a healthcare system if the enhanced tax credits go away?
I mean, we talked, I think, a lot about this morning. I mean, it really is, for the healthcare system, we're going to have patients who are going to forego care. They're going to forego their preventative screenings. They're not going to be able to afford going to see their physician or afford their medications. And for the healthcare community broadly, we're going to see closures, and we're going to see just a reduction in access to care and the ability of providers to offer that care. So the consequences are just catastrophic across the board. And then you compound it with the conversation around Medicaid. You know, you can't look at these issues in a siloed way. And so when you're talking about a double, whammy of potential reductions in Medicaid, along with the tax credits potentially not getting extended, you can't underscore enough what the consequences will be for patients and communities.
Great.
And building, one other thing on Parinda's earlier point. So, in rural communities in particular, a healthcare provider tends to be one of, if not the largest employer. Mm-hmm. So there is, again, a rippling effect of these decisions where you lose your hospital or your healthcare provider. Not only do you lose the major or one of the major employers in the community, you lose your ability to attract business. No new business is going to want to come to a rural area or a community where you can't offer, basic healthcare to your employees. And again, this is when you think about these cuts. It is to healthcare, but you are talking about cutting underserved and vulnerable communities across the country when you're talking about this.
Thank you. And microphones are set up if folks have any questions for our panelists. Go ahead and start making a line. I think we have one person. All right, we'll just start over this way then.
Good morning. Thank you so much. Danielle Gilliam with Novo Nordisk. I have a question in regards to the comment that you made about rural America. And one thing that stuck with me was when you say, when you think of rural America, you think of, a white male farmer. Mm-hmm. I believe the problem behind why people don't vote in their best interest is because their imaging looks different. Everyone up there said that Medicaid has a different name in their state. And so when you talk publicly about Medicaid's getting cut, they don't think that's happening to them. Mm-hmm. What is happening in your particular organizations to increase this? So this all falls under health literacy. We think it's just making people understand what the big doctor terms means. It's not. It's things like this where maybe we wouldn't be in the situation we're in now if people really knew that when they were voting, this is what that meant for them. Because right now, Medicaid and DEI looks like the single unwed Black mother with children, and that's not the case. So I'd like to hear your response to that.
I mean, Craig, do you want to?
Yeah,
I'm
take it. I'm going to take a
I can
crack
talk
at it.
too.
Take a crack at it. Longer
Yeah.
discussion.
Now you have 45 minutes.
Yeah, and now I got 45 minutes. You know, to be honest with you, I think a lot of folks spent a long time trying to get Medicaid branded as something else. They worked on that. That was intentional. That's an intentional look about Medicaid. It's not, you don't get a card from your state. You get a card from a private health insurance company. You get something else that doesn't say Medicaid on it. It doesn't say that you're insured by the state of Vermont. It doesn't say that you're insured through the state of Tennessee. They intentionally did that so that folks said, oh, look, to use the term, I'm not on welfare, right? You remember how bad that word was in '94, right? Which was welfare reform. We need to get people off of these things. It's still there, but they intentionally rebranded it that. And this is kind of the other side of that, which is now you've rebranded it, now you don't realize where it came from, right? So you rebranded it so it wasn't government-sponsored healthcare. That's on purpose. And now you're like, you don't even know how it's funded. So you're fighting an intentional discussion, which was, I was trying to get you a private insurance card. Now let me go back to the other discussion, which was Medicaid was originally set up to be a marginal payer, which meant you serve 100 people. If you serve one more, how much does it cost? It's not supposed to be the bedrock of the entire foundation. It's supposed to be one more person. It's actually supposed to be the payer of last resort. Is how it was phrased in the very beginning. It's supposed to be the marginal payer of last resort. And that's the legacy that even you heard of from the beginning of this panel before this, which was fighting a legacy of injustice within this country, right? Which was, I'm going to make it a marginal payment. I'm going to make it the worst thing. I'm going to make it only for this, and it's going to come through these folks. We have tried to move it away from that. But it's an intentional move away, but you're exactly right. It changes that branding it changes the advocacy arm of it. But to be fair, Medicaid expansion, extremely popular in this country. And I would say that if it came up as a ballot measure, some states, the states where it hasn't expanded, the Floridas and the Texas, you can't do it by ballot measure, right? They don't have ballot measures. I'm from Oregon. We believe in ballot measures. We ballot measure everything. But so the states say, no, we're not going to listen. We're not going to do that. So that's how you have Medicaid not being expanded. But I think you're exactly right. But it's even an intentional challenge.
Yeah. Thank you. Yes, my name is Bruce Taylor. I'm a patient advocate. And one of the questions I've got is that when you look at this $880 billion, I've got 5 grandchildren and I'm trying to teach them modern math. Does anybody have government math for dummies? Because I appreciate it. Yeah. Is it a cut? Is it a savings? Yeah. But I don't think we've really gotten into, if you're a state legislator and all of a sudden you're trying to get your balanced budget, which you have to do statutorily on a biannual basis. I live in Indiana. They were about ready to pass the budget. The bean counters came in. We're $2 billion with the B dollars short. So there was this last end scramble trying to do that. Well, when your tax dollars go down, there's only 4 levers that you can do as a state legislator. You can cut professional reimbursements. Well, right now, when you treat a Medicaid patient, you're underwater.
Yep.
So do you want me to, I know enough about business to understand if you lose something on a transaction, you're not going to make it up in volume. It just doesn't work. 2, you can limit the benefit of Medicaid. You can change the eligibility criteria. 3, you can start cutting benefits. And the expensive benefits usually go to people with chronic conditions. If you're not managing chronic conditions, then it's going to come back, and they're coming back they're going to the hospital. The billions of dollars that you saved in Tennessee are real. Hospitals are ungodly expensive. The 4th one is just eliminating benefits. So we talk about the $800 billion with this new math here in Washington. we got to really start looking at the math of what's going to happen in Tennessee or what's going to happen in Oregon, because those state legislators are at gunpoint right now. How do I make our budget work?
I think that's a standalone comment, right? I think that's very true. Craig, I'm happy to let you come in, but let's let Craig talk.
Something on my face says that. So, two things. States have a mandatory balanced budget. The largest source of funding transfer between the federal government and states, Medicaid. It's the largest source of funding from the federal government to the states. So when your state, exactly what you said, has a challenge, the largest source of funding coming from the federal government is Medicaid. I would only argue with the 4 points. You could also do it better. Yeah. That's what we try to do, right? All of us up here. You could do it better. And there are ways to do that. Longer conversation.
Well, and I'll just say, Tennessee has actually financially been in a really good position.
Yet didn't expand Medicaid.
It didn't. So actually there are, it's billions of dollars of shared savings. Our rainy day fund has gone up even more. They're very, very proud of it. Yet they're struggling with the healthcare issue and the education issue. But even this year, when they passed the budget, and I'm not saying it's going to be that way in the future, but they have a lot of money in Tennessee. It's just not going into healthcare.
Yep. We have another question here.
Yes, Angela Moore from North Carolina A&T State University. What can be done to force healthcare institutions to work with federally qualified healthcare centers? Mm-hmm. When you talk about trust, most federally qualified healthcare centers have the trust of the community.
Yes.
Yet you have academic institutions, healthcare entities that receive, you have individuals within a 5 to 10 mile radius of those institutions cannot get into the door of those institutions. Mm-hmm. And then you have them fighting and trying to take away some of the patient populations from the federally qualified healthcare centers, especially when Medicaid expansions come around. It's all about dollars, not necessarily helping the patients who need it the most, but it seems to be this push and pull. Yeah. We have the resources, so we'll offer certain things. However, it's not consistent.
Right.
And so how do we get federally qualified healthcare centers to partner, well, academic institutions or healthcare entities to partner with federally qualified healthcare centers to have more sustainable care for our communities?
Okay. I'm trying to think how I can say this. Most academic medical institutions have two main, they're organized into two different entities. One is the academic, which is the Graduate School of Medicine. That is the state funded, or they've got some federal funding, but that's that. Then there is the practice arm, which is very often a for-profit entity, and they are run like a wealthy private practice. And so many of the medical providers, healthcare providers who work in an academic health institution get two paychecks. They get one to be a professor or to teach, and then they get another, which is the big paycheck, which is the practice arm. And so when I speak with our local academic medical centers, they are very happy to give our patients infusion centers, do surgery, procedures, diagnostics. They love the diagnostics. They do not want to see our uninsured patients. Trust me, even last Monday I met with CEOs. It's just, don't get me started on GME, please do not. But the issue is that this is for many parts of the healthcare sector, this is about commerce and it's profit. For community health centers, we're nonprofit. We're like, this is about our mission. And so when you don't have alignment, we are not going to partner with you. We are not going to let you take advantage of our patients. You cannot do that. And you have to give something back. So we train physicians, nurses, psychologists from these places. We don't get paid to block our schedules to train. And in fact, we have to pay a pediatrician to go, we pay her salary and she goes for free to the academic medical center to do grand rounds for them. And again, it's not all that these people are bad or these people are good. There is this tension between the education and academic component and the for-profit practice management where they're running it. And I'm adding a third group in there, which has exploded in the last several years, and that is venture capital, private equity. Most anesthesia groups now, GI groups, they're all owned by private equity firms. So it has changed. It is a business. And so you have to have, in order to be good partners, you have to have at least some overlap in mission, values, and that's not there consistently because of this tension that you have often in academic medicine.
Thank you for that. And running against time, before we step down, I want to be able to do a quick lightning round. What should people know and what should people do based on the information that they just received?
Yeah, well, I want to build off the comment here in the front about health literacy. I think it's on all of us to be having the conversations with people who are living in our communities and the lawmakers and policymakers who represent them so that they understand and can put a face to the conversation and loss of coverage that we're talking about here. It's understanding that ripple effect, and it's going to take all of our voices to help make that happen.
And I'll pick up where Carrie left off. Use your voice. Your voice is powerful. Members of Congress, elected officials, pay attention when they're hearing directly from people in their community. And please, 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 as you're talking about healthcare issues and what's at stake, it's Medicaid, but it's also the tax credit piece. And so we need to make sure that we're talking about both and what the compounding effect of these changes will have in our communities.
Dr. Carey.
I would just say yes, and focus on the consequences of. If you do this, what is going to happen? Because right now, many times people aren't thinking about that. It looks so sexy and good. Let's cut $1 trillion. Let's do this. And then what? And then what? So help them think through beyond this next budget cycle.
Bring us home, Craig.
Make it personal. You know somebody on Medicaid. Make it personal. All the stuff, all the $880 billion of this and the hospital, that and this, yes, that's important. But when you tell your story, that's the most important.
Great. Thank you all for being a great audience.
Oh, okay.
Good job.
All right. Thank you.
We can talk. We can all.
I know,
we
yeah.
can talk,
Keep
and
going.
talk and talk.
We can keep
Okay,
going.
hold on.
I'm going to put this down by you.
Freezing.
Or do you want us not to touch ourselves?
I don't know how to do this.
Am I supposed to button? Sorry.
All right. Hey, everyone. Brandon over here.
I blinked.
Hello, hello, hello. Just a couple of housekeeping announcements. I know a lot of you were asking about Wi-Fi. Is that still a concern? Wi-Fi?
Thank you.
So it's Hilton Honors Meeting.
Great job.
Thank you.
So if you want Wi-Fi,
$880 billion.
Hilton
And the fact
Honors
that you
Meeting.
Cut it for 1 year.
Word is Nmqf
But that's what it is,
25.
right? Am I wrong?
All caps, sorry. It's all right, I have. All right, just make sure you got this. I'm doing a couple of housekeeping announcements. If you want Wi-Fi, it's Hilton Honors Meeting, and the password is Nmqf 25, all caps. All right, that's one. 2, restrooms. Sorry, Nmqf, all caps, 25. Nmqf 25 is the password. 2, restrooms. They're near the escalators. So if you need to use a restroom, it's near the escalator. All right, if you can hear, is this on? It's on? Bruce. Michael Joyce. Michael Joyce. Michael. All right. Making sure y'all get these announcements real quick. So restrooms are next to the escalator. Password is NMQF25. If you're participating in CMEs, they're actually out this door to the right. There's also poster presentations that are going to happen between sessions. And there are the posters that are to your left. Well, from my left. So posters, my left, CME, my right, restrooms, escalator, password, NMQF 25, all caps. All right, well, we'll have the Ferdinands on in a little bit. Thank you.
Right.
Like, you know, we're missing.
At the National Minority Quality Forum, we start with data. Over 5 billion patient records harnessed to reveal the hidden stories behind health disparities.
I'm gonna give some opening remarks. I'm talking to everybody.
Way, asking the right questions to build evidence for a healthier tomorrow.
Nice.
Then we take that evidence to those in power, shaping the policies that drive change
Candace,
for those who
come
need
on
it
now.
most.
Oh, thank you.
We unite the brightest minds.
I'm gonna give some opening remarks,
building powerful alliances.
and then the way I have it lined up is
we tell the stories that
I'm going to first go to
reaching patients
Daphne.
where they are, and
I'm gonna call you doctor, okay?
They call me Doc G.
And on the
Dr.
ground,
G?
we partner with trusted messengers.
Well, she's Dr. Daphne, Dr. G, Dr. Moss, and then Dr. Robinson.
Okay.
So give you 5 minutes.
From data to action.
Huh?
Together we are shaping.
Yeah, well, we ready. We ready.
Just future.
All right.
That's a bridge Ryan, girl.
So give you 5 minutes. Daphne, come on now. Let's go.
Welcome to the National Minority Quality Forum's
I hate late
2025
sessions.
Leadership Summit.
There it is. Oh.
Because then when you get to the end,
Is there a hair going across my face like any of these, like a little straight hair? No. Okay. It's just ash.
then you get
Okay,
to the end, we won't be able.
I'm used to these lashes.
We won't be able to make our closing remarks because everybody's milling around, and they start late, and then you get to the, oh, we're on. And I was just making a comment about starting late, that it has the unintended consequence that at the end, people don't get a chance to make their closing remarks. I'm going to use the term take-home points, because that's important also, that our panelists get the opportunity to give that one thing that they think is most important. So I'm Dr. Keith C. Ferdinand. I'm a professor of medicine at Tulane University School of Medicine in New Orleans, Louisiana. Tulane is my vehicle. I'm a native of New Orleans. I'm going to go through the panelists. I've met them all, but I'm going to still read it because I want to give everybody their formal titles. Dr. Daphne Pajot Ferdinand. She's the Executive Director of the Healthy Heart Community Prevention Project, also in New Orleans. Dr. Latricia Gordon is Director of Programs at Michigan United Health in Flint.
It's all over. Yes.
Close.
I mean, Flint. Yes.
Oh, you're from Flint, but yeah. And Dr. Sanovi Moss is the CEO Managing Partners of Moss Consulting and Management Group and National Project Manager for NCNW Good Health. And Dr. Candace Robinson, Director, Scientific Affairs and Public Health, GSK Vaccines. So we have an hour, and we're going to start on time and end on time, but I think it's important for me to make a few comments. United States is in trouble. From a public health point of view, how people work, live, play, and pray, the social determinants of health are going to have a terrible penalty. We already have it in cardiovascular disease. I'm a cardiologist. We thought we had it beat in infectious diseases, but with some of the vaccine hesitancy, mistrust, distrust, misinformation, there have been 800 plus cases of measles. The epicenter was West Texas, but now it's in Ohio. We've had 2 cases in Louisiana. They've even had a couple of cases in Canada, and it's going to spread like wildfire. At least 2 children have died. That's reported, but it's probably more. Diphtheria, which is part of the immunizations that probably everybody in this room got as a child, DPT, whooping cough, sounds funny, but it's not, it kills. And that's probably going to be more cases than we've had in the last 15 years. Oh, by the way, measles was eliminated in the United States in the year 2000, so that just goes to show you. COVID, fortunately, has come down and it's not going away. For those of us who are older or have comorbid conditions, get your boosters, because the viral immunity is not lasting forever. That doesn't mean that the science is bad. It just means we're simple human beings with simple tools. We try to help people, and sometimes we have outcomes which will then come back. So COVID's not gone. Polio is now being found in the wastewater throughout most major cities. It's a virus. Again, I see a few older persons in the room. When we were kids, someone would go away from school, come back 6 months later with a withered leg with this big metal braces, or their arm shrunken. That's going to come back. So this panel is very important. If we don't do the appropriate public health interventions, all of these diseases are going to come roaring back. They didn't go away. And from a political point of view, I always struggle because I'm a retired militant, not to get too political. I used to think, how did the Europeans conquer all of these places? How did they kill off the Indians? How did they get rid of the Aztecs? Well, they had muskets. It wasn't a musket. It was infectious diseases. So we're going to start with opening comments. I appreciate your attention. Each of these powerful women have different perspectives, different fields of training and expertise, and we allow their voices to speak. We're going to go from left, right, like that.
So I will not stop and introduce yourself. You can say anything you want to say in your own introduction.
Okay. Thank you all, everyone, and good morning. I first want to thank some people, Laura Lee Hall, Nmqf, for inviting me to come here and share my story about what we're doing in New Orleans. We couldn't do this work by ourselves without that support. And Laura Lee, thank you very, very much. So I'm a registered nurse by profession, and I'm the executive director of the Healthy Heart Community Prevention Project in New Orleans, which is a small 501c3 nonprofit organization that does community interventions to help people in our city to reduce their risk for cardiovascular disease by our educational interventional programming. And because this is the type of target audience that we have in New Orleans, flu vaccines became very, very important for us to address with the people who are living with chronic conditions like heart disease, kidney disease, heart failure, diabetes, morbid obesity, and other immune suppressive disorders. For them to get this flu vaccine shot, because if they become infected, what happens? It can exacerbate their conditions, their symptoms, and become sick, and at risk of hospitalization and even death. So we felt it was important for us to be involved in flu vaccinations, although we focus on cardiovascular disease education in our communities with vulnerable people. So what we did as a result of our gracious funding is started in 2022 into 2025 this year. First, starting with flu vaccine events. We held 4 events in different pockets of the city, in pockets of the city that target African Americans. Our flu vaccine rates are extremely low, so we wanted to make sure that we engage partners that support the same vision and mission that we have in improving public health for our residents. So we engaged in various partnerships, and that's key. Whatever you do back home, partner, partner, partner. That's my take-home message for anything that you want to get done within your cities or in your communities, is to engage in those partnerships. And our local health department has been extremely helpful in supporting us, and likewise we support them in the same efforts. We also partner with a local hospital, a local community hospital that in my area that is very community-minded and supportive of those efforts. Walgreens, our pharmacy stakeholder, was also involved. But the other thing, in order for us to have these vaccine sites across the city in our targeted communities, we also needed to partner with our local recreational department, and we didn't have to pay anything to any of them. But what was instrumental with our campaign is a PR firm that we decided to partner with that has spent 40 years in New Orleans doing this type of work. They have developed relationships, trusting relationships with various partners throughout the city. So they were very, very key and instrumental for getting the word out to all of the residents in New Orleans. So we did somewhat like a two-stroke campaign: vaccine sites as well as an educational promotional campaign. And that was in 2022, the later part during the flu season, into 2023 in January when we ended that campaign. But in 2024 and also in January of this year, we decided to take a different twist. We focused strictly on education and promotions. And the PR firm, again, Bright Moments, I love to toot their horn because they're excellent in doing this type of work. They helped us to develop strategies and various messages using social media, television programming, radio streaming on various platforms. We also had digital billboards in 4 different areas within New Orleans that is frequented by a very, very high population area. So we flooded the airways with our 3 trusted messengers, our physicians, who are the face of public health in New Orleans. Yours truly, Dr. Keith Ferdinand. He has been a long-term resident and physician, cardiologist in the city, and It's important to align with physicians and healthcare professionals that have established those trusted relationships within the community. Our local state health department director, Dr. Jennifer Avegno, very community-minded, great stakeholder. It's good to align with your local health departments because that's a part of their job, is supporting the public health efforts within the community. And our other trusted messenger was the CEO of the local community hospital in our area, Dr. Tatisha Davis, that does a number of community activities within the hospital itself, bringing people forward to increase their health care status. So we flooded the airwaves. They made videos. They provided messaging throughout the radio, even into the Spanish-speaking community. Television, we were even on MSNBC. Surprisingly, it was really great to see our doctors delivering these health promotional messages about the benefits of getting the flu vaccine on the airway, even on cable television. Newspaper, targeted areas within our own communities, and it was just a phenomenal campaign. And I can talk a little bit more about the numbers and what we arrived at, but the differences from year to year, later on, after everybody else has an opportunity to speak.
All right, thank you. Dr. LG, Michigan.
Yes, Dr. It's a pleasure to be here. I also like to thank Dr. Laura and Chinny for inviting me, and National Minority Equality Forum has been very instrumental and also in our progress. I'm from Michigan United. I'm also a nurse. I'm a U.S. Army veteran. During the COVID pandemic, we started a pilot program with nurse navigators and navigators for the community. And then in 2021, the vaccination for COVID came out. This is where we get to the flu. And so our community was having, and the Flint, it's most predominantly African American and Hispanic population, were having a poor uptake, a lot of vaccine hesitancy. So we developed a program. The community couldn't get them to get vaccinated. So I developed a program where I'll go out to people's homes. So we created access in the community. First of all, building upon that trust during became the navigator, providing education on vaccinations, and then setting up different events, providing people with a time to come, a safe space. And they would come up to me, Dr. J, tell me about this vaccination. Keeping it real and being transparent about what vaccination is and what vaccinations isn't. So the biggest thing is we already have the historical traumas within our communities, and then also being afraid to take any vaccination. So there was a team also developed partnership with over 35 partners in Flint community, partner with local major #1 trauma center, Hurley Medical Center with Tarnisa Martin. Dr. Hacker was also instrumental. I became partner with the Genesee County Health Department, so I had a dual role with Michigan United that provided me access, 24-hour access to vaccinations. So with this, I was able to do pop-up clinics all the time, not just during regular standard hours. I could do it any times of the day. We went to barber shops, beauty shops, churches, clubs, even to people's family reunions. They had invited us there to have education. I'm talking about, packing. This is a mobile clinic. And then for those that were afraid to come out to do the vaccination, we would also do the home visits for those homebound and those that were afraid to come out. So the biggest thing that was created, breaking down the myths, the barriers, and those partnerships, the instrumental partnership was with the Genesee County Health Department by having that access to vaccines that broke down the barriers. So we bridged the gap between the health department and our communities, also fostering trust within those, rebuilding that trust within the health department and our health systems. And then once we got out there, we realized that there's a lot of social determinants of health that need to be addressed. Like, well, Doc, gee, I know about this vaccination, but I don't have food, or my lights are about to get cut off. So then we branched out and becoming more resourceful, providing those resources. But the biggest thing with the vaccine was breaking down the myths and building the trust in the community. And the way they said that I asked them, well, how can we build trust in this community? Me and my other partner, Nurse Tarnisa Martin, they were saying consistency, being visible. Just don't come out in our community for 1 day or 2 days and then, you're gone. So that's the biggest problem with, we developed these wonderful and beautiful programs going out into our communities, but then the sustainability of them, being able to continue these programs and continue that trust. So the biggest thing I take away is, building that trust in the community. I'm a trust. We do It was weekly, but now it's every second Friday of the month. That also continues to provide health resources as far as vaccinations, where our vaccination pop-up sites. We do over 25 to 30 events a month throughout Genesee County and Oakland County and even out into Detroit, providing the resources. So one of the things is you'll come in, they would come talk and ask their questions, and then at the time they're like, okay, we have the vaccination. So we start out with the COVID, then we have flu, and then we brought all vaccinations out. So all ages, and we vaccinate all ages. And the same people that start out with me when I start out with my small pop-up, start out with me and myself and another nurse, every year they follow me and come get their vaccinations. And so we partner with Walgreens, Cloud Pharmacy, and Big Brother Pharmacy, and our local organizations to provide those resources in our community. So biggest thing is trust and access.
Thank you. Dr. Moss.
Well, good morning, and thank you to Nmqf for this invitation, because our organizations, we've been partnering together, so this is not new for us. These are consequential times that we are in. And so it takes consequential organizations like yours and like ours to continue to do this work. As you talked about the infrastructure and building trust, if you think about just centering yourself, the Black church, sororities, fraternities, organizations, that's the work that we were able to do in pulling together all of our groups and organizations to do this consequential work, which 5 years ago, COVID called us all to the table. Yes. It made us all stop and do this work together. And we at the National Council of Negro Women, being a 90-year-old organization this year, founded by Dr. Mary McLeod Bethune, with the premise of bringing all of us together. We are an umbrella organization for 37 national women's organizations. So when the National Council comes to the table, you get all of us. We are Black women committed to empowering and advocating and educating people in our community, our families, and making sure that we meet the needs of the time. So during COVID, we at NCNW, we have been doing health, all of our organizations have very strong health platforms, but we had the opportunity to really come into the vaccine space in helping to manage the pandemic. And so with Good Health Women's organizations, Good Health Wins, that's what we call it, we understood the importance of vaccines to good health, because this wasn't something that the pandemic brought our attention to the matter, but you think about it, we had disparities prior to the pandemic, and so we sat in this work and we were able to forge this coalition together. Good Health Wins is comprised of 40 state and national organizations that help to build vaccine confidence in communities across the U.S. We have been working very hard to make sure that our groups and organizations, we provide many grants to over 1,000 community-based organizations to do this work. And so with Good Health Wins, we do 4 things. We activate the organizations and groups so that they stay committed to doing this work. So it started off with COVID, but we very quickly saw that it's important to talk about COVID, flu, RSV, pneumococcal, but all of the vaccines across the lifespan. And so we wanted to activate our groups to stay in this work. We educate. We have, at the beginning of COVID, we started what was called our community of practice. And we literally, bi-monthly, every first and third Thursday, since the beginning of COVID, have hosted our community of practice sessions. And literally, you all, next week, or May 15th, will be Community of Practice 100. So you talk about community and sustainability. Community of Practice 100, but we are averaging around 1,000 people per call. So we're gonna hit the 100,000 mark. And I would say that our communities are very hungry for information. So we activate, we educate, but we also motivate. We provide not just information that's real and relevant to our groups and organizations, but we also really work hard to continue to motivate them to do this work. So we have things like our certificate training program, where we are looking at making sure that community-based organizations, think about it, they're the real network and the glue that hold a lot of our African American communities together, or communities and marginalized communities. And so we do this work to make sure that they are informed and educated, but we also celebrate. because you all, we have survived a lot over the last 5 years. And so as we are continuing to do this work, we really want to make sure that people have the information, that they have the opportunity to access the information and to do this work on the ground. So what does it look like on the ground? We currently have 1,084 mini grants that we give out. And so in the work that we've done through the PAVE program and with our industry partners, our goal is to get information and to be that infrastructure of trust. So we are the trusted messengers with trusted information that we can go out and have those conversations at the dinner table, at church, in your civic organizations. And so that's the work that we've been doing a lot. It's just been very exciting to be able to say that this is not new to us and that we have to stay in this space because it is so real and relevant to making sure that our communities stay healthy.
Thank you. Dr. Robinson.
Well, hello. Good morning, everyone. I'm Candace Robinson. First, again, I echo my fellow panelists. Thanks you to Nmqf for bringing together this panel at this time. So I am a physician, pediatrician by training, and I currently work at GSK, which is a biopharmaceutical company. I work, my role is really in scientific affairs and public health to really kind of amplify the importance of vaccination and prevention across the lifespan and implementation of immunization here in the U.S. Before joining industry a couple of years ago now, I spent 15 years in pediatrics and in public health. So I'm going to take my hats on and off today and talk a bit about public health as well. As a company, we really work to combine our knowledge of the immune system and cutting edge technologies to try to create new medicines and vaccinations with the purpose of preventing disease. We know that our population is getting older. Infectious diseases continue to spread. Chronic diseases take such a toll. And so really, we believe the best return on investment in health is prevention before you become ill, if you can prevent an illness. So a few things as well, I think some of the key words I hear resonating across the panel, and you're going to hear me talk about them too, but partnership is so important. We work a lot with medical providers. We work a lot with informational campaigns for the public so that people are aware of what may be recommended for them and have the information they need to feel empowered to talk to their healthcare provider about the vaccinations they may need. And also making sure physicians and providers and your nurses and your pharmacists have the information they need to engage in these conversations with their patients when they come in seeking advice or having questions about what may be recommended for them. So we know, I think the quote has been said before, it's not the vaccine that saves lives, it's vaccination. So how do we move from just having the vaccine to vaccination is the key. And how do we support providers in those conversations? How do we partner with organizations at state or local levels so that they can kind of address issues in their community and support those efforts at the community level? So I think that's a little bit of our role and how we approach it. But I'd say my two key words are prevention and partnership.
Great. So one of the problems with science is that it tends to sit in a vacuum. And although National Minority Quality Forum is certainly interested in policy, you have to be careful when you talk about politics. I'm not being political, I'm being real. New Orleans is a great city. It's one of the main hubs of the African and Afro-Caribbean population. We've been here 300 years. The state is red, even though New Orleans is an international city. Our governor and our so-called Surgeon General said that they will no longer have mass immunization drives. They will no longer make vaccines available to the various cities and parishes. Parishes are our counties. So I'm going to ask Daphne a question about how she's going to overcome that barrier for 2025 fall. And then I'm going to end with a question to you is, how do you get vaccines to an area, not an enlightened area like Michigan, but into an area like Louisiana, where the agencies no longer are going to assist us in these areas. So you can think about how you're going to come back with that, Dr. Robinson. All right, Dr. Daphne. The governor said we ain't gonna give y'all no vaccines. How you gonna do a flu drive in New Orleans?
Okay, Dr. Keith, we're gonna keep fighting. We're gonna keep working. We're gonna keep advocating, okay? We're gonna build up this spine, right? Okay, be spineful and still fight for the public health of our families, our friends, our neighbors, our communities, our city, and our states. We gotta keep moving. Don't ever stop, okay? So misinformation, our local health department director wrote an article on grassroots working around flu vaccines, okay? She encountered an individual who was inundated with misinformation and spent 20 minutes. Now this is our health department director who we have partnered with over the past 3 years. Great person, community-minded, supportive, works hard to try to address all issues within our city with regards to public health of our residents. She spent 20 minutes with this individual and convinced this person to now get a flu vaccine. She suggested that if we were able to do many town halls around the city, which is quite difficult for this one health department to do, right? That we would be able to get full flu vaccinations to all 400,000 of our residents. So after I read her article, I said, this is something that we should do, Larlee. Okay, all right? We should all come together within our own city confines and partner. Partnership is just so very, very important. We can't do this work by ourselves. It's impossible. You know, no one is an island, okay? Develop the relationships, trusting relationships with people who envision the same mission that you share as well. There are people out there that believe in that, okay? We've done it. Over the past 3 years, we have done some phenomenal work that we are very proud with the relationships that we have developed within our community in New Orleans. Health department is very, very strong. If they are not supportive of you, you go to them and you start the conversation. Have that conversation and talk about what the needs of our residents and the importance of that. Many town halls, I love this idea that our health department director proposed. And this is something that I am suggesting with funders who are in this room to support community organizations who are about this public health work and consider moving forward with providing the education to our residents, because this one health director convinced this one person 20 minutes. Now she can't spend 20 minutes all throughout her lifetime, you know, with the work that she's doing with single individuals, okay? So it takes a village to come together and work together to accomplish this mission. So this is something that I'm proposing and I would like to work on within our own city, is to get pockets of coalitions within our neighborhoods and start talking about how we can improve the public health of our communities, you know, especially with these flu vaccines. We've made a difference in how we were able to provide our educational and PR promotions. In partnership, we hired the PR firm, but we are in partnership with them. They're not just a contractor. We treat each other like family. We've developed those trusting relationships with one another. And they share the same mission that we have. And we've been sticking with them for the past 3 years. And we will continue to do that because they have done the work within our community already. They have already developed and solidified those relationships with the partners that they have that brought them into the fold with us to support the mission that we have with increasing vaccination rates in New Orleans.
All right.
So partner.
So Dr. Robinson, I gave you a little time to get your armor up. The way we make flu vaccines is we look at the global south. We look at South America, we look at Australia. They're already in their winter. And we look at the strains that they have. The World Health Organization coordinates some of that. The CDC coordinates some of that. And then industry makes the vaccines and then they're distributed. CDC may not be as strong a partner in developing and distributing vaccines or getting the information to the companies. And I've already told you, in Louisiana, you're probably going to hear about this craziness in other cities and other locales. The health directors say they're not going to even participate in this. How are you going to get the vaccines made and distributed?
Yeah, I think you're highlighting a critical issue here, which is access. How do we ensure people have access to prevention and access to vaccines? And we know there are lots of things that are...
She's alarmed about that.
She's alarmed.
Bring the alarm.
And we know there are a lot of potential barriers and lots of access concerns. We know that policies vary by states, right? And so different states have different policies, different landscapes in which to navigate. How do we navigate those? We know that there are still physical access barriers as well. Rural communities, as was talked about in the last session, often have access issues. There can be transportation barriers. There can be lots of barriers. There can also be, there are still federal barriers that we're looking at. For instance, policies that may come up in the future, like adult vaccine safety nets, are still uncertain. We don't know where some of these things are going. And then, of course, misinformation and disinformation is also another source of access issues. And how do we battle with all of that? And I think there's a few things. One, industry can really serve as a partner to our organizations, to our state, to our public health organizations, to local organizations. We're doing this in a few ways. One, first of all, for state issues, we actually help provide kind of information at the state level when there are legislative actions or legislative bills that come up related to vaccines. And so how can we kind of provide the information that is scientifically accurate to get that information out? And then number two, how do we continue to partner with people working at the state level, at the local level, to kind of continue to get vaccines out to the public? And so one thing that GSK has done in recent years is what we call our co-immunity initiative. And that initiative has worked to provide grants to organizations at the state, local level to help those organizations that are working on issues of vaccine access and vaccine equity. And so in the first 2 years of the program, we allocated $3 million in grants to these organizations for these access issues. And in 2024, there were about $2 million allocated, and they're spread over 15 states, 15 local areas, and 15 local organizations. So really, we are focusing on how can industry be that partner to those in the field, those working with communities, those working with legislators, those working with providers, to help address access issues.
So, Dr. Robinson, I'm a nice guy. I have to tell you that because it's going to sound harsh. At some point, you're going to come up, for this year coming up, not what was done last year or in 2023, you're going to come up against politicians who don't believe that they should participate in vaccination distribution, information, et cetera. So you don't have to answer that, but when you guys have your internal meetings, be aware that this is real. That they're going to, all the things you said, help and partner, et cetera, they're going to say, no, we don't want your help. We don't want your vaccine, because they consider it poison. And that now goes to my two informatics. I know you're trusted. But the internet, X, Instagram, not as much Blue Sky, are full of people who have loud voices, which are the opposite of what you're doing. So techniques to overcome misinformation and disinformation, techniques to have a platform, and you do have a big platform, but it's really huge out there. There are whole streams and threads where somebody dies and they'll say, well, I guess he got vaccinated. I don't know if you've ever seen it. It sounds bizarre, but that's what they do. So who wants to go first? How are you going to fight frank misinformation and disinformation?
That's one of the main things that I did when I was out there. I also have a little TikTok that I do videos on.
Yeah, TikTok's another one with that bad stuff on it.
Yes, TikTok videos on educating, like, I had one person come to me and say that if I get the vaccination, I heard they'll turn you into a butterfly. So
Really?
That's that trusted space I'm talking about, where someone can come to you and I look at them like, oh, so tell me more. So like, yeah, I was, You'll turn to a butterfly, you'll get a TB in your hand. These are things, I mean, people are really afraid. So just having that straight face, like, okay, well, this is actually what the vaccine is, and this is what it isn't. So providing that information, and on, like, say, the platforms that that I use, like TikTok or Instagram, just providing that information. Like, I'll have a fact sheet up of, flu vaccine, COVID vaccine, RSV or HPV vaccination, and just provide the facts. And then they'll interact and they'll send questions in my inbox. Can you tell me more? Where can I get it? What ages is it safe if I'm pregnant? So providing that information is key. And also that health literacy piece, that's, disseminating information and tying in the health literacy. So they'll be, people that get the vaccination, they'll be informed when they go make a choice. So the thing about it is when we're out there, it's like, hey, you better get this vaccine. If you don't get this vaccine, X, Y, and Z is gonna happen to you. The thing is providing the information. This is what the vaccination does. It's not a silver bullet. It's not gonna stop you, but it will decrease. It will keep you from dying. I love the one campaign, it will take it from wild to mild. So providing those little nicks and things like that nature, but that's the biggest thing, is providing that information, letting people become an advocate for themselves and making their own decisions. So when they will come up, provide that information, disseminate the information, dispel the myths, misinformation, and then allow them to make their own choice if they're going to get vaccinated. So that was the key in our program when we were out there, not saying like, hey, if you don't get the vaccination, X, you're going to fall out of these different things. The vaccination here is a layer of protection. It's proven safe. There are some side effects, and just provide them the whole truth, the whole facts, and transparent about the process. But that's the biggest thing that I did.
I know you have a long history in your organization, and you're a valid source, but I'm telling you, it's out there, it's noisy. How are you going to fight that?
We deal with this all the time, and so it's not just trusted faces, but it's trusted spaces, trusted places. So just a true story. So one of our trusted messengers, and again, we have a very broad network, we're about 4 million in our trusted messenger network now. And one of our trusted messengers came back and shared a story with us that she was on a bus stop, she being an elderly African-American woman sitting on a bus stop with 2 young boys. And they were teenagers, and they were talking about the vaccines and some of the myths that they had heard. And she just shared information about, let's have this conversation. So she was willing to take the time to really talk to family, friends, but anyone about good information. And she also shared with them where they could get sources to find it up and look for this information for themselves. And as they were having this conversation, they were all going to the FQHC, headed to the health center. And she went with them after having this conversation and having them look it up, but she went with them to the health center, and they both got vaccinated. So it's gonna take just making that commitment and the intentionality of being able to be with our folks and talk to everybody to say, this is not just why, but here's good information. So you have those trusted faces, but also trusted spaces and trusted places. What we've said to our groups and organizations is that this is not a conversation that's a one-off. We have to make this the norm around what is important and why vaccines are important in our community, and what does that really mean to good health. And so as we're having these conversations, but it's everywhere. So whether you're doing a breast cancer walk, whether you're talking about heart health, whether you're doing diabetes, we say layer it onto everything that you're doing, and so now it becomes the norm. And so to answer, I got a solution for you. We have our own Project 2025.
I was just thinking about that.
I'm just saying. We are listening. We just lifted up this year 25 community listening sessions in 25 African American markets across this country. How do we get this out into the community? We have to go out and be in community. And so in 25 cities across the US, we've actually just completed 12. We are going into the community to have a community at the zip code level conversation to talk about, how do you feel about vaccines? How do you feel about health? What challenges are you experiencing? And our goal is not to have the conversation, is to lift up 25 vaccine confidence hubs in communities across the country. As soon as we announced our Project 2025 this year, we automatically, we really have another 50 cities that are ready to go. Because people are hungry for information, and they want it to be real, and they want it to be relevant. And so it is going to take going out into community, but understanding that we are community and we are empowered to really help those who cannot help themselves, and that's giving them good information.
Dr. Robinson, I'm not picking on you, but there's just so much distrust and mistrust. What is GSK going to do to overcome that? For those of you who don't know, in the United States, anywhere from 25,000 to 35,000 people die from influenza. The flu is not just a bad cold, and that includes over 1,000 kids. We're not really sure CDC is going to be that trusted source of information that it used to be to tell people that this is not just a bad cold. So I'm asking you, because you're a pediatrician and because you work with industry that makes this life-saving vaccine, how are you going to overcome that?
Well, I think the studies show that still provider recommendation is the strongest indicator for receiving a vaccine. Having the provider say, I recommend you have this vaccine for this reason is a very strong indicator of vaccine acceptance. And so, we recognize that our role in industry is to provide that information to provider, help that provider feel confident in making that recommendation, and to partner with others. We may not be the voice that people want to hear from. When I was at the public health department in the height of the pandemic, we recognized we may not have been that voice that people wanted to hear from at the time. So finding those trusted messengers, as Dr. Moss has indicated, be that their provider, who they're going to and seeking out their advice, seeking out their recommendations from their provider, be that someone in the community who becomes that trusted face and that trusted voice. That's how we kind of work against the misinformation that's spreading. And making sure providers have the information they need, making sure providers feel confident in these conversations when they receive questions about what they heard on TikTok or about the latest thing they've seen in the media, having them have that information so that they can address those questions will go a long way in helping that as well. But it's something that everybody in this time, everybody in this field, we all have to partner and we all play a role in combating this information.
I'm glad you brought that up. I'm a past chair of the Association of Black Cardiologists, and the present chair is in the audience if he's still here, and the president and the CEO are all here. The same patients who die from heart disease, hypertension, diabetes, kidney disease are the people who die from flu. And those of you who deal with children, the same children who get accidents and trauma and suicide die from flu. So if you have the National Forum for Heart Disease and Stroke Prevention, you have the Association of Black Cardiologists, we're going to have to build into our platforms, not just control your blood pressure, get your sugar down, but tell patients the benefit of vaccination, because I'm just not sure CDC is going to help us this year. I don't think I can tell people anymore, go to that cdc.gov and get the information you need for this. So I recognize that industry is a bad word in some people's lexicon, so maybe if you can just support these various national organizations, National Council of Negro Women, et cetera, the Michigan program, and Healthy Heart in New Orleans, in order to get the information out, because people are going to be inundated. It's going to get worse. It's not better. Time does not always equal progress. There's a mic up front. I don't know if it's live. If you have a question for this wonderful panel of dynamic women, feel free to come forward. Dr. Daphne, go, please.
Dr. Bennett, one of the things that we're very excited about is that at the council, we say we're better together. And one of the things that we saw during the pandemic and over the last 5 years is, look at what happened when the entire world had to stop and focus on one thing at one time. We got this country to herd immunity. But it is extending and sustaining those relationships that have been so important, and just as we have to work with providers to make sure that they are informing their patients, but we also want to do the patient advocacy part and making sure that patients know to ask every time. Ask, what vaccine do I need, or what am I missing? And so that's some of the work that when we talk about educating the community, is empowering them to take charge of their health care, but also that they have that that shared patient relationship with their doctors as well. And so that's something that we really want to work hard on, is that campaign of empowering the community to know that you can go in and ask questions and advocate for yourself.
Yeah, we're gonna have some hard work. You know, when we were kids, getting your MMR shot, no big deal. Go to the pediatrician, get your shot. But now it's a conversation. And unfortunately, so many people are unvaccinated. But what you think, 90% of the people who are getting these measles had not been vaccinated as kids?
Yeah, you know, we've seen that the U.S. in general, there's about $9 billion a year in spending related to vaccine preventable diseases. And 79% of that spending is amongst persons who are not vaccinated. So we know that, you know.
It is hard.
It is a challenge, but we know that the power of prevention, and we know that it's important, particularly as our population ages, to have these conversations. And also to make people aware of, you know, vaccines they may need, but also disease awareness is important. Some people may not know their risks. They may not know what they're at risk for and what may come of if getting that illness, that infectious disease. So all of this education, all of this disease awareness, all of this vaccine education is really important.
At the mic. The mic. Is it live?
Not live,
But go, please.
Yeah, I was like, oh, hello? Okay, there we go. Hello, and thank you so much. My name is Shawnee Scott. I'm a physician in the Bronx, New York. I'm also an assistant professor of medicine, and clinically I practice, I might have said this, internal medicine. Thank you for sharing so much of your insights from the programs that you have implemented. Also, I'm also a member of NCNW, Manhattan chapter. I wanted to take a step back to get a little bit more granular about the conversations that a lot of the advocates or champions have. I think one thing that we do seamlessly and don't get a lot, especially as women, especially particularly as Black women, is emotional labor, and where we create safe spaces and have a innate ability to open up safe spaces to discuss things and ideas, and then also to close them in a very nuanced but effective way. When it comes to your thoughts regarding train the trainer, I think as a physician in my own practice, I work in an FQHC, I'm able to do this just naturally, but when trying to export these talents and get other people to champion this and be able to do this type of emotional labor, I'm at a loss on how to maybe come up with a framework for that. Have you thought of that in your work, and what has proven to be successful?
Okay.
Well, I could say for NCNW, the community listening sessions that we're hosting, these are 30 focus groups around the country, and this is something that we absolutely will be able to scale out. One of the things that we're seeing is that, as you say, creating these safe spaces is not making the assumption that the first thing we've got to do is to convene the conversation and be very intentional about it. And in the first 12 that we've committed to, that we've just completed, we've been surprised because the groups get to self-select who they'd like to attend in their communities. And we are noticing that almost 2 to 3 of their 30 people are anti-vaxxers. And, you know, we did one in a particular city, and the anti-vaxxer, the closing comment was that I've never been in a safe space where I could talk about how I feel about this, and that I'm not an anti-vaxxer to stop other people. It's a personal decision and choice that they made. And people in that wide spectrum, they're all dropped in. So some people said, one person who we would say is anti-vax said, I'm needle adversive. I don't want any kind of needle. So, but we have to put them in that category. And so these are lessons learned that we're starting to see, is that we have to create the safe space, but it is important what we do and the value that we bring to this entire conversation. It's the infrastructure. It started off with bringing all of our groups together to talk about vaccines, and we call it Good Health Wins, but it very easily is the same infrastructure that now we're seeing that we have to talk about all of the other issues, the heart disease and hypertension and diabetes, because this is the work that we come with a multiplicity of issues when we talk about health. And so that's something that, you know, can be scaled, having these community conversations, but it is partnerships, it's infrastructure.
So,
Dr. Burnett,
yeah, Dr. Dow.
I'd like to address her question. I wear another hat with regards to public health, and that is co-chair of the Association of Black Cardiologists Community Programs Committee. And we have a train-the-trainer program which focuses on the reduction of cardiovascular disease risk factors. But we also have an additional component as a part of that, which is focusing on vaccine education. And we have advocates all across the country where we include vaccine, that vaccine component in terms of the benefits, and as well as educating our advocates around this particular topic so that they can go back to their communities, as well as to stimulate, encourage, and educate their community members about the value and importance, not only about cardiovascular disease risk, but also how vaccines can play a role in exacerbating their chronic conditions as well. So it works, because it works within our organization, and we're doing that kind of work.
One more brief comment at the mic.
Yeah, thank you so much. I am Councilmember Letitia Plummer from City of Houston, and so Texas obviously conservative. Unfortunately, we have to mix politics with medicine, which is unfortunate. In the City of Houston, we just lost about $45 million in funding. Our health department is primarily funded by grants, and we've lost those resources. So as someone which is doing this amazing work, so thank you so much, what would you advise local officials in terms of finding resources to be able to continue doing vaccinations in communities? And let me also say that Texas also, we have no Medicare, Medicaid expansion in Texas, and the anti-vaxxer conversation is very apparent.
It is real, and I just think those members of the audience who don't come from those type of areas that we're in don't recognize that there are now governmental leaders who not only are not going to support your efforts, but who are against it. I don't have any easy answers. I think it's going to be pretty tough. And as you know, there is a white-black mortality gap. This is not EDI. This is not social science. We're talking about people being hospitalized and killed. I don't have any easy answers. I don't know what we're going to be doing going forward if our local health departments don't get the funding from the federal sources and the support from the state of Texas or the state of Louisiana. In fact, we just had conversations with our own local health director in New Orleans. She said that she may have to find funds and grants to buy influenza vaccine for the city of New Orleans. Fun city, but a lot of poverty, a lot of people who are not going to be able to get the care they need if we don't get those resources. I don't have any answers. Anyone has answers? Anyone has any suggestions on how we can get vaccines to these local areas where they're not going to get the funding from the federal sources in the state?
Our local pharmacies, Dr. Ferdinand, we partner with Walgreens as well as CVS, and our local hospital also has a vaccine supply. So we utilize those resources that are available to us. And Walgreens, you know, not to point out just one particular pharmacy partner, because all of the pharmacies were willing to partner, but we decided to work with them because of our relationships with their regional director. So they have been overwhelmingly welcoming with being involved in getting the word out and providing the services to the community that they serve as well.
Likewise, with my community, you have the pharmacies, but they, you know, some of them eat it at cost. But so now when it comes to where they can't, the pharmacies no longer carry that burden to get people vaccinated. But some, right now, they will provide free vaccinations to the community at their own cost. Some of the partners that we work with, like the Clio and Brothers Pharmacy, allow the access.
So we started on time. We're going to end on time, but before we end, I would like each panel member to give what I would call a take-home message, because sometimes people say, that was a really good panel. There's someone at the mic? Speak, I don't see you.
Right here, Dr. Ferdinand.
There's lights right in my eyes.
Thank you. Just want to quickly tie together the comments that both Drs. Ferdinand made about it takes a village, and then about governmental information, and then finally the question from the city of Houston. I'm John Clymer with the National Forum. We work with a couple hundred mayors across the country to promote cardiovascular health, and during the pandemic, We expanded that into vaccination confidence, vaccine confidence, and immunization promotion. We have black, white, brown, yellow, boy, girl, urban, suburban, rural mayors who are all actively involved in this. And Tony Haygood, the mayor of Tuskegee, Alabama, gives, I think, a great example of the effect that mayors have as influencers in their communities when he talks about a gentleman who approached him and said, my family and I had decided, we sat around our kitchen table and we decided not to get the COVID vaccine. But then we saw you, Your Honor, we saw you get your vaccine, and we listened to you talk about the decision process you went through and why you chose to do it. So we had another meeting in our kitchen, and we all decided that we would get vaccinated, which we did. So thank you, Mayor Haygood. And we hear stories like that from all around the country. We will very soon be working on a project with Dr. Fletcher and ABC in Little Rock with Mayor Frank Scott. And mayors have a tremendous amount of influence. It doesn't cost them anything, any dollars to promote it. And finally, the mayor of West Chicago, Illinois, which is a majority-minority community in DuPage County, he organized a clinic that provided free flu immunizations to over 2,500 community members who wouldn't have had access otherwise.
Thank you very much, John. It's a great message.
Yeah.
All right, 1 minute, 2 minute take home. We're gonna start, I started on the left, we're gonna start on the right.
All right. I think the take home is we have to continue to do the work. We have to continue to do the work for vaccination. You know, GSK just announced year 3 of our co-immunity initiative, so we'll be allocating another $2 million to organizations at the state, local level who are working on issues of adult immunization and health equity. We're going to continue, you know, with awareness campaigns. We're going to continue the work, continue with awareness campaigns around vaccination so that people are aware of what they may need, such as our Thrive 50+ campaign, which is a shingles awareness campaign. And we're going to continue to partner. And so GSK is partnering with some integrative health systems like Temple Health on a project around vaccination equity using community health workers to help with patient discussions and navigations. So we have to continue to band together, continue to do the work, and continue to partner with one another because prevention is key.
Dr. Moss?
So I'll end with a quote from our President Emeritus, Dr. Dorothy Irene Height, who was such a hallmark in this community and into our country. She said, if the time is not ripe, you have to ripen the time. And so for us, it's time for us to get involved and to not just activate, educate, motivate, celebrate, but now we have to advocate and really become a hallmark for ourselves to make sure that the resources are there for our communities as needed. And we do that through our partnerships. We just lifted up a National Committee on Vaccine Confidence in which we will create a think tank around how do we continue this work across our demographic groups. And so for us, this is our opportunity to ripen the time.
Dr. LG?
Okay. As you know, we are in trouble. We are in this climate, we are in trouble. And to continue improving vaccine uptake rates, decreasing vaccine hesitancy, we need to act now. We need to partner together, continue to collaborate, find workarounds, different bridges to find these resources for our communities can be vaccinated and remain safe.
And Dr. Daphne?
It's 2025. It's time to get involved in some good trouble.
Yes.
Okay, y'all know y'all heard that. Good trouble
yes.
from that famous
yes.
man that we miss so much.
Yes.
Advocate, fight, shake it up, deal with this, hit the miseducation at the forefront. Do the work. Give back and serve.
So we have had a very powerful and hopefully stimulating session combating vaccine misinformation and policy turmoil with data and community action from trusted voices. You've heard some powerful trusted voices. We shall now end. Thank you.
You're sick, on vacation, and now your wife is faced with going out there, with them, alone. But mom's having none of that. She got you a virtual visit with Amazon One Medical. And soon, beds will get delivered right to the hotel. Because no one gets out of joyful family fun. No one.
Good afternoon, everyone. Welcome to the Food as Medicine panel. You're in the right place. I know there's a maternity panel going on right now, and I might confuse you, but this is the right room, all right? I'm Latasha Celebi Perkins. I'm a family physician at Georgetown, and I have the honor of moderating today's Food as Medicine panel. We have some fantastic professionals on the stage. We're gonna ask a few questions of them, and then once I ask my questions, this is going to be an interactive panel. So please have your questions ready. We understand that we are the last panel standing between you and lunch, so we'll be mindful of that. But please, please be prepared to ask questions. Does that sound okay? Okay. I'm gonna do that again. So I'm African American from the Black church. So response is important to me. Everybody, is that okay? Okay, that sounds better. All right, so the first thing I'm gonna do is introduce you to our panel. And just so we're all on the same page, I'm gonna read the educator in me wants to read the definition of food as medicine for you. Don't take this the wrong way if you're like, I do this for a living. I didn't know, not trying to offend anyone. Just wanna make sure we're on the same page. Food as medicine is the concept that what we eat can play a key role in preventing, managing, even treating disease. It emphasizes the idea that healthy, nutrient-rich diet is one of the most powerful tools for maintaining wellness and addressing chronic conditions like diabetes, heart disease, obesity, and more. So let's go ahead and introduce our panel. I'll start with, on my right, Mr. Eric Mitchell. Eric is the president of Alliance to End Hunger, where he leads the organization's strategy to expand and mobilize a diverse network to build the public and political will to end hunger in the US and globally. Previous to this position, he worked for Food for the World, advocating for critical food assistance programs for our world. That's Mr. Eric Mitchell. Next, we have Ms. Kelly Horton, the Senior Vice President of Public Policy and Government Relations at the Academy of Nutrition and Dietetics, the world's largest organization for food and nutrition professionals. Kelly oversees the Academy's public policy agenda and advocacy efforts that promote health and reduce the burden of chronic disease through evidence-based nutrition services and interventions. Kelly is a registered dietitian, and her experience includes launching a novel nutrition intervention which grew into a basis for what is now known as the Food as Medicine movement. So just a pen if you want to ask her about that later. It'd be a good thing to ask Kelly about. Next is Dr. Kofi D. Wessel, MD. He's a board-certified community pediatrician at the Children's National Hospital and clinical associate professor of pediatrics at George Washington University School of Medicine and Health Sciences in DC. Most recently serving as the director of the GWU's culinary medicine program. He is currently the inaugural Food as Medicine program director at Elevance Health. And he'll tell you more about that later, or you can ask him specifically about that. Give you all some little nuggets to ask questions about. And last but not least is William Billy Dreyer, serves as our senior legislative assistant for Congresswoman Kelly. Billy covers a diverse legislative portfolio and leads the Congresswoman's Food as Medicine efforts, including the introduction of the Food for Health Act in the 118th Congress. So that's Billy. All right. I have a few questions prepared for them. We'll start there, but again, please be prepared to ask any questions that you want, as we will have a question and answer segment that will come early in our program, okay? So starting with Eric, you ready? Mm-hmm. All right, first question. What important role do the federal nutrition programs such as SNAP and WIC play in the food as medicine space?
Well, thank you for the question, and I'll start off by just giving a quick overview of who we are as the Alliance to End Hunger. We are a coalition of over 100 national organizations spanning across multiple sectors. So we have businesses, corporations, faith-based groups, universities, foundations, even individuals, international NGOs, U.S. NGOs like Share Our Strength, Meals on Wheels, Feed America, et cetera. And our goal is to move policies forward that will put us in the path to ending hunger and malnutrition, not only in the U.S. and globally. To answer your question directly, the role that our federal nutrition programs play, across the board, we believe that a foundation of providing healthy foods, making it available for everyone has to be key. And our nutrition programs play a central role to ensure that everyone has the access, can afford, and that healthier foods are available to people across the board. And so when you look at our programs, our nutrition programs like SNAP, WIC, school meals, even some of our senior nutrition services and other things, these programs range across millions of people. SNAP alone covers over 41 million people in this country. Within that program, there are certain incentives within that program that helps to make healthier foods more available. SNAP Ed is a way for local NGOs to work with local state governments to do education training around healthier food options. There's things such as the GusNIP program, which makes healthier fruits and vegetables more affordable and for low-income families. There are even incentive programs like Double Your SNAP Bucks, where for every a SNAP dollar you use in buying healthier food options, it gives you twice the amount in return in regards to the healthier fruits and vegetables you can afford. Studies have even shown that individuals who use these incentive programs consume more fruits and vegetables than average Americans who don't. And so to answer your question directly around the role that federal nutrition programs play, they help to expand access to healthier foods. They also make healthier foods more affordable, and they make them more available for the most vulnerable communities.
And that's extremely important, because if you look into, as we all know here, the communities, there are food deserts, there are, grocery stores that may not have the produce that our patients, our communities that we serve need. And so it's extremely important that programs exist that definitely support us eating better, because food can be medicine. So I want to move on to Kelly. In your role as a registered dietitian, I want to know more about what that role plays in this Food as Medicine initiative.
Sure, thank you. So registered dietitians, or you'll hear us called RDNs, registered dietitian nutritionist, we play a critical role in screening, assessing, and then tailoring nutrition interventions for people and ensuring that food as medicine interventions are clinically appropriate, culturally responsive, and aligned to the patient's medical needs and treatment plan, not one size fits all. And RDNs put into practice the concept of good nutrition to promote health and to prevent or treat disease. If you hear the term nutritionist versus dietitian is trained in what's called medical nutrition therapy. So we are looking at evidence-based science to treat a patient. And we use those evidence-based science and interventions to treat chronic disease. It's really the cornerstone of what we do and has been proven to help with diabetes, dyslipidemia, hypertension, HIV, eating disorders, renal disease, and a whole bunch of other things. And you mentioned my involvement in the beginning, so I just want to mention that it's really exciting to see food as medicine become a movement. About 20 years ago, a small group of dietitians came together. I was not part of the group that thought of the idea, but I helped to activate the idea. Came together and said, what if and they were working in community-based organizations that were serving folks with HIV and AIDS and expanding to serve folks with diabetes and chronic disease, and often those patients actually overlapped. And they said, what if we could offer medically tailored meals, nutrition counseling, medical nutrition therapy, produce prescriptions, medically tailored groceries, and have a proof of concept that proved to reduce chronic illness and also healthcare costs, and we could then have a proof of concept that we could get Medicaid to pay for it. So we're 20 years into that policy intervention, which is sort of like the life cycle, so to see real change happen, so it's very exciting to see that happen. But we still have a long way to go to make sure everybody has access. And then maybe the last thing I'll just add is that the counseling by the registered dietitian is vital, but it's often not paid for. So right now, dietitians can get reimbursed for care that they provide for diabetes, renal disease, and post-renal transplant. Like I mentioned, there's a whole host of other diseases, such as obesity, diabetes, heart disease, cancer, that are not currently reimbursed. So people can go see a dietitian, but they may not get the full complement of care that they could get if we got full reimbursement. So that's something that we're working on, and I think there's a lot of momentum to get that moved forward with the medically tailored meals as well.
Amen. Sounds like a few action items that we're already getting early on. How many people just learned the difference between a dietitian and a nutritionist? Be honest. You can put your elbow up or maybe just say it to your neighbor, but that's an important point. And so we're hoping that we're learning and we're sharing this, but thank you so much for letting us know exactly the difference between the two so you know how to use the right terminology. I do want to move to Dr. Essel to ask a question more in the lines of what you do as an educator. Can you describe the gap in nutrition education and medical training, and how does this impact the food as medicine movement?
Yep, excellent question. So recently I transitioned to the payer world. I work at Elevance Health, and I'll be able to talk about that more with questions moving forward. But before that, and actually currently right now, I still do a lot of teaching, but I was actively invested in sort of educating the next generation of providers and how they can incorporate more nutrition into how they care and work with patients and families. And some of you may say, well, why do you need to do that? Doctors know a ton about food and nutrition. That's part of the curriculum. If you really look at sort of the timeline, you can see some big gaps. 1985, groundbreaking report from the National Academies. National Academies brought together a group of leaders from around the country and said, hey, let's look at what's going on in medical training. How are we training the next generation of providers to sort of address the current challenges around food and nutrition? Malnutrition, diet-related chronic conditions. How are we doing this? So they looked at the data around the country. They asked a lot of different medical schools, and they found that the vast majority of medical schools weren't really incorporating this. When you looked at the data, what we saw was at a minimum, they said, hey, we're not doing a good enough job at incorporating this. They said, at a minimum, we need 25 hours of nutrition education in medical school. This is at a minimum. And so this was in 1985 that this was recommended. Years later, things have gotten so much better, people would say. The most recent literature shows us that when you look across the country at all medical schools, you're seeing about 71% of them fail to meet the minimum number of 25 hours of nutrition education. Okay? A third of these schools don't even meet half of those hours. So in general, there's very limited education around food and nutrition in medical school. But you must ask the question, are you not talking about this with patients and families? Patients and families are asking about this. Well, what do we end up telling patients and families? Well, what we learned from grandmother, what we learned from mother, what we learned from whatever magazine we were reading, oftentimes can be very off-putting, not recognizing the diversity of diets that are out there, not recognizing challenges around food insecurity, food access, and really treating food as not a deeply personal experience, but this absolute experience that is unique to the individual versus unique to our cultures and personalities. So I think there's a big challenge there. There's a lot we can do there. There's a lot we've been invested in around the country to really sort of improve this process, but there has been a big gap there for many, many years.
And I can remember even in my training, most of the training I got, I did have some nutrition training in the beginning, but in the hospital, it was a dietitian when we did the referral for certain chronic diseases that kind of told us the medicine, the science behind it, which was great. But definitely a point that I hope we can talk about a little bit more. But because this is a advocacy and policy panel, we want to make sure that we get to that as well. So I'm going to turn to Billy to ask a question specifically about what is the status of Representative Kelly's Food for Health Act and other legislative efforts focusing on food as medicine?
Yeah, thank you for the question, and it's really great to be with you all here this morning. And I guess I'll first start off with, if you're not familiar with Congresswoman Kelly, she does a lot of work in the healthcare space, has been a leader on maternal health, preventing gun violence, as well as some nutrition-related matters as well. And so we've always tried to view this as how can we sort of bring synergy between traditional healthcare and also nutrition. And I come at it from more of the agriculture and nutrition background with some of the items I cover for the Congresswoman's office. My colleague Michelle, you'll probably see her around here. She is more primarily focused on our traditional healthcare and maternal health work, but we overlap on a lot of these things and try to work together. And so I guess I'll take it back to maybe about a year and a half, 2 years ago, we started hearing this concept, food is medicine, coming up quite frequently. The White House had done the conference on hunger and nutrition, and there was a lot of, like Kelly mentioned, there's sort of a movement growing in this space. And so we started hearing this a lot and said, you know, how can we find ways to be involved in those conversations? And we really started with our district. Our district is urban, suburban, and rural. It always surprises folks that we actually have 4,500 farms in our district. So the Congresswoman and I spent a lot of time touring farms and hosting barn hall conversations, meeting with our agriculture groups. And some of those are traditional kind of commodity row crops, corn and soy, but we're seeing a lot of farmers doing innovative things with specialty crops and urban gardens and trying to be involved in strengthening local food supply chains and healthy foods at that. And so through meeting with a bunch of folks, we ultimately started hearing more about how these things all intersect and how do we utilize, you know, emergency feeding organizations, how do we utilize healthcare centers, hospitals, federally qualified health clinics, and really try to add to the supply of fresh food via medically tailored meals or produce prescriptions. And so we worked to draft a bill and talked with a lot of folks on stage here. And we've used folks like Dr. Essel on a panel in the past to talk about these same issues. But our bill essentially would establish a pilot program with HHS and USDA to cover kind of a broad sort of wish list of items all related to food as medicine. And so produce prescriptions, medically tailored meals, nutrition education, even things like on-site pantries within hospitals. I think that is kind of a touch point where if someone with a diet-related disease comes in and they're screened and then you know, we have the RDNs there to sort of oversee the process, how can we get them the food that would benefit them and either manage, treat, or prevent, you know, some of their conditions? I think that is a great point that you don't want to lose them at. And basically, we want to see more funding come to these types of programs. We're seeing it smaller scale going, you know, across the country. There's pilots and there's programs. A lot of states are looking at 1115 waivers to try to get these programs up and running. There's other members of Congress who have more narrowed approaches on things like medically tailored meals with Medicare. I think as much energy and kind of ideas, the better. But our bill, specifically, we kind of view it as utilizing the community-based organizations, the emergency feeding organizations, with healthcare partners to try to really instill collaborative efforts to roll out these programs. And so we're really excited about it. We worked on it for a long time. We introduced sort of a placeholder last Congress. We're still working to reintroduce this Congress. We're trying to make it bipartisan, so we're talking with our friends on the other side of the aisle. They obviously are talking a lot about healthy foods and you know, food dyes and various things like that. And so we're seeing if there can be any synergy. It's obviously, as I'm sure we'll get into, a tough environment for a lot of things, healthcare and nutrition right now. But yeah, so we're working to redo that. And then it's also the middle of appropriation season. So we're gonna work with some of the leaders like Representative McGovern from Massachusetts and some others to try to see if we can make requests for additional funding with some of the existing programs and also try to expand food as medicine more broadly.
Fantastic. So there's lots of work being done. You have these programs that are popping up, but ultimately funding is what's going to be important. Because our conference is about data to action and want you all to leave here with action, our panelists have some data points they think will be important for you to know so it can help with the action that you take when you leave our panel. So I'm going to let whoever wants to go first with their data point, just don't want to put anyone on the spot, to give us a data point and what we can do about it.
Well, I can kick off just to kind of give a certain level of urgency of where we are right now. Billy just talked about Congress is in session. Congress plays a major role in a lot of things that we're dealing with. So some data points just to take away from you all. Again, I mentioned that SNAP program serves 41 million people. WIC program, which is we didn't get talked about, which is another federal nutrition program that's focused on mothers and young children up to the age of 5, serves about 6 million people. For children who are using school lunch programs, 70% of those children are either doing free or reduced lunch. That's just in perspective of the broad level of constituencies that are impacted by our federal nutrition programs. That said, there are policies that are under consideration right now, which will roll a lot of things back. And one key thing we have to remember is that we can't have nutrition security without food security. And you can't make America healthy again without those two are tied together. And so some of the things that we are worried about right now are provisions that will drastically reduce SNAP benefits for families. The House right now, House of Representatives is going to consider a bill which may cut $230 billion out of Department of Agriculture. That can't be done without touching SNAP. There's an effort right now, there's thoughts right now that they may zero out fruits and veggie benefits in the WIC program. We already heard about cuts to school meals. These are all things that will impact the ability for low-income families to be able to have access to healthy, nutritious meals. On average, just to put some dollars and cents to this, and then I'll shut up, the average SNAP recipient receives about $6 a day in benefits. Now think about what you can buy for $6 a day. It's not much. And so these programs are used as a way to fill gaps for families who cannot afford healthier foods. But there's also, on top of that, with the certain incentive programs that we talked about, making these healthier foods more available to low-income families allows those families to make their dollars stretch. So these are just policies that we got to look at. We have to have these conversations where we talk about big picture around the impact of these cuts and what that will mean. And as health providers, definitely I want you all to think about this from your perspective of making sure that your patients have access to healthy, nutritious foods at home.
I'll just add to that. Thank you so much for that. The data shows that people who receive SNAP, which by the way is not like their whole life, it's for a moment in time usually when they're experiencing economic stress. The data shows that they purchase the same foods as everyone else, maybe in different orders, and that's just a reflection of the money that they have available. So they're just like everyone else trying to put healthy food on their plates for themselves and their children. And that response to food insecurity is so important. And that referral from a doctor, just table stakes, when they're seeing somebody who's experiencing malnutrition or trouble getting enough food, referring them to SNAP, making sure the kids are in school lunch and receiving, or on WIC, that's really important. Then the next step is making sure there's a clinical intervention if that's needed. And so I mentioned that medical nutrition therapy is reimbursed right now for diabetes, renal disease, and post-transplant. We have evidence that it works on so many other things, but it only got approved for that because of the money. So we need to really invest in prevention. And when we do invest in prevention, we actually see the cost of those patients who are getting treated for diabetes and renal disease and post-transplant, that their medical costs go down over the long term. So even though it might cost a lot to add medical nutrition therapy for cancer, obesity, and other things, we know that the costs are going to go down by doing that prevention overall long-term health care.
Absolutely. And I don't know how many other people in this room, I definitely was a WIC kid, I definitely was a SNAP kid for a little bit, and I am this floored that this may go away because I know what it did for me and my family. So,
Same.
Yeah, I'm sure like other people, you may not say it out loud, but you remember what that was like, and you know that helped you get some healthy food in your house. So.
Yeah, I want to do some foundational pieces with this really quickly. I think it's important. So we are highlighting the role of food insecurity and how it impacts families across this country, right? You see that 1 in 6 households with children are experiencing food insecurity. 1 in 7 households across the board. We get it. Very, very important, very prevalent, very ubiquitous around the country. Every single county in this country is experiencing food insecurity, hands down. Food is medicine engages food insecurity. It also doesn't stop with only food insecurity. And it's important that we establish that and make sure we're aware of that as well. We're not watering down it at all, but we have to understand that this problem that we're talking about is expansive beyond food insecurity as well. How do we say that? How many adults in this country have hypertension? 1 in 2 adults. 60% of adults have at least one chronic condition. 40% have 2 or more. How many adults have prediabetes or diabetes? One would say, when I talk to my students, 1 in 5, 1 in 4, it's 1 in 2. 1 in 2 adults has prediabetes or diabetes. When we look at 1 in 2 adults versus 1 in 7 households, they don't always overlap. Not to say they don't contribute to each other, because households that experience food insecurity have much higher rates of diet-related chronic conditions as well. So we have to engage all of these at the same time, but we can't only stop to say, when we're thinking about and engaging this topic of food as medicine, we're not only thinking about food insecurity. I just want that to be clear here. Another foundational piece we need to understand is we're throwing out words like medically tailored meals and groceries. Just want to really focus on that for a second. Typically, when people talk about food as medicine, you'll see them highlighting a pyramid, a food as medicine pyramid. On the left side of the pyramid, you'll see at the base of the pyramid is focused on prevention. At the apex of the pyramid is focused on strategies using treatment. There are typically 6 different approaches that people talk about. Medically tailored meals, the most poignant, directed way using the most expensive tool that we have for addressing disease. Medically tailored meals are pre-prepared meals designed by a chef and dietitian, designed to give you 50% or more of your calories for the day. They're delivered to the home, they're ready to heat and eat, right? You can store them in the refrigerator or the freezer, depending on their frozen or fresh or whatever, but you're just throwing in the microwave, you're ready to heat them and eat them, right? So think about a family who's had a recent surgery, having difficulty getting around the house, having difficulty getting to the kitchen or the grocery store. These meals can prevent rehospitalization, can prevent malnutrition, can give them the nutrients they need to optimize their health. They can also be used for a variety of other things as well. Medically tailored groceries, number 2. Medically tailored groceries are produce, fruits and vegetables, and other items as well. Whole grains, nuts, seeds, legumes, other items as well. They can be packaged, delivered to the home, or picked up at the grocery store, but these give a lot more autonomy, right? An individual wants cultural preferences, the foods that they enjoy eating, giving them the ability to go and purchase the grocery items they want. They can then adapt those foods to the foods that they want, the foods that they enjoy. It also can build more skills than medically tailored meals, right? Because you're having to prepare the foods. That's why whenever we talk about any of these interventions, we need to be working alongside high quality nutrition education as well. There needs to be a synergistic effect. This is not just providing food, this is not just providing education, it's how do we bring the synergistic worlds together, right? So that's number 2. Number 3, produce prescriptions. Produce prescriptions are fruits and vegetables. It can be fresh, frozen, or canned. Right? Just providing fruits and vegetables, one may say, why is that valuable? We know that only 1 in 10 adults consumes enough fruits and vegetables. And children, I'm a pediatrician, only 1 in 10 children consume enough fruits and vegetables. Right? So there's an issue, there's a huge gap here. Providing more fruits and vegetables improves the microbiome, right? It does so much more to our overall health. We've seen changes in A1Cs and blood pressure and overall health. I mean, the list goes on and on, simply by providing produce. The last 3 categories, number 4, nutrition security programs, federal nutrition programs rather, let's just say that. Federal nutrition programs, SNAP, WIC, school meals, everything Eric is highlighting. These programs are dynamic, they're effective, they're evidence-based, they work. We can lean on them, we recognize the effectiveness of them. Number 5, community and local policies as well. Community programs and local policies. Food as medicine should not eliminate local community infrastructure. Right? A lot of this work is phenomenal. It's going around the country. These are some new initiatives coming in, but the local community infrastructure has been what has got us to this point. Let's not eliminate that. So that's a really critical piece as well. Our food banks, our food pantries, our soup kitchens, and last but not least, number 6, high quality, empathetic, personalized nutrition counseling and education. How do we meet members where they are, people where they are, providing high quality education, recognizing that every healthy eating doesn't have to look like rice cakes for breakfast, lunch, and dinner, or that sad salad that people have in their minds. We can adapt it, right? Recognizing blue zones. People eat differently all around the world and have benefited from it. Why does it have to look only one way? So these areas are the 6 areas I want us to think about. To answer your question, the data point that I think is critically important is there's still questions we're asking around food as medicine, right? For produce prescriptions, for example, how long should we be doing this? What's the right amount of produce to be providing? What do we do after the program ends? We just send them back into the jungle and say, figure it out on your own, right? When we don't have resources around, what do we do in these situations? So the data points are really getting a better sense of how effective we can be by sort of tweaking different elements of these programs. Once we can understand that piece better, it's gonna make this whole movement much more effective as well.
How many of you learned something from that conversation, right? And knowing that there's levels to it, and culture plays such a good part. when it comes to grocery, like allowing people to make their own meals. And then also the age preference, like when you do the medically tailored meals, I find that my geriatric population loves that because they don't have to cook, they don't have to worry about it. It continues to allow them to do their ADLs without having to think. But then my moms with small kids, they're like, my kid's not gonna eat that. So knowing that there's levels to everything and keeping in mind the action that we need to take to make sure that these programs continue to exist and the policies that come with it. So Billy, I'll come to you. Sure. Let's bring the policy, the advocacy
well,
into
it's
it.
tough to go after everyone else who spoke because they really hit, everything that we agree with as well. And especially talking about how these things sort of work in unison with one another. If you cut SNAP, if you cut WIC, you're likely going to see rising rates of food insecurity, rising rates of related diseases, as well as the medical nutrition therapy. I should note, outside of our Food for Health bill, which is more focused on food as medicine programs, we also have a medical nutrition therapy bill that we're working to reintroduce. My colleague Michelle sort of takes lead on that, but exactly what Kelly mentioned, trying to expand what services are covered and what RDNs and folks like that can get paid. And so those are some things just that came to mind when the others were speaking. But the stat, as we talked about the concept of medically tailored meals, it came up that maybe they're the most cost intensive and the most sort of strategic and narrowed focus in terms of providing food to help treat or prevent or manage a diet-related disease. And Tufts University, who have been leaders on kind of the food as medicine and that space for a long time, they came out with a recent study, and I was looking through my notes this morning. Obviously, everyone is concerned about funding and costs and healthcare, as well as what's happening in Congress, right? That's a huge focus, particularly for the Republican Party right now, as they look to potentially cut $230 billion from the Agriculture Committee, which will touch SNAP, or $880 billion from the Energy and Commerce Committee, which my boss sits on, which will touch Medicaid. And so it's really tough to kind of grapple with making investments when we're in this current climate. But medically tailored meals the data is starting to show that they are a good investment to make. And so just in Illinois, I was looking, for eligible populations, they simulated Tufts University that they would save approximately $2.8 billion annually through the provision of medically tailored meals to treat diet-related disease, compared to just traditional healthcare. And then also that comes out to something like, I think they said like $2,500 for each patient, right? And so these things, while they may cost money up front, we're saving money in the long run. And I know everyone knows the stat about diet-related disease, I think costs, $1.1 trillion annually to the US healthcare system. We know these things can help, and it's sort of making the investment before you need the ultimate hospital stay or serious medical interventions. And so I think we know these things work. They all work in unison. We really have to strengthen our basic nutrition assistance programs, as well as really try to build out food as medicine programs, medically tailored meals, produce prescriptions, and see that hierarchy to its fullest and its full effect, right? If we cut one part of it, we can't get to the top level. And so it's really important that we continue to invest in all our nutrition programs, and then hopefully get even more and more data on the kind of higher level medically tailored meals, produce prescription, things like that.
Amen. So we got some data. You know more about who these folks are and what they're doing. I'm going to ask them another prepared question that I have for them, but then we're going to open the mic. So that's a little bit early for what y'all used to. You're used to the last 5 minutes, but I did want this to be a dialogue so we can have a healthy conversation, especially about, this is a political policy and advocacy conversation. There's so much going on right now, so I want to make sure you all get the opportunity to take the mic. I am going to start with Billy, though, because we have all this information, but what do we do about it, right? So I want to ask you specifically, in what ways it says healthcare professionals, but healthcare professionals or anyone who's interested in this work, how we can engage at Capitol Hill to create momentum for these issues in Congress?
Yeah, well, I'll start off with, and maybe you guys have figured this out, Congress doesn't know everything. We're not experts on every given issue. And so it's really important that we hear, and the Congresswoman particularly, she always references that it's so important to hear from folks. We have an open door policy. We always want to hear from folks who are doing the work on the ground, right, who are in these professional settings. For example, for myself, so I'm a senior legislative assistant. I cover like 7 different issues for the Congresswoman. So I may meet with a group on nutrition, food as medicine related issues. The next group I'm meeting with veterans groups, or I'm meeting with defense or transportation or energy or environment. And so my time is very spaced out. I'm jumping from issue to issue. And it also is dictated heavily on what Congress is doing, right? If Congress is focused on the Farm Bill, if we ever are going to get to see some of the reauthorizations of these federal food assistance programs, we need to do a Farm Bill. If that's front and center that week, that's where my energy is going. If it's something else, that's where it's going. And so I really benefit, and my colleagues will attest to, from hearing from you all, especially when we're drafting legislation. You know, we worked on that bill for a long time, and we're unable to make everyone happy and give everyone sort of you know, the opportunity to say what they think would work best, but we're trying to get that feedback as we're shaping legislation, because I might say, hey, this sounds like a great idea. I think, you know, if we orchestrated the bill this way and this group played a role, that would be great. And then they may say, it'll never work like that, because you folks are obviously in the settings dealing with patients. And so we really value hearing from you all, just, you know, on food as medicine and also other issues. I think it's important also that, especially in this current climate when everything feels so intense and funding is threatened and the stakes are so high, on all sides, right, Republican and Democrats, we need to hear from you all, especially if you're in rural, red districts, the importance of talking to your members and their staff about what would happen if the cuts that are being proposed were made to these programs. I think that is so important. So it's important on kind of the general sense, and then as we get more tailored, specific, into the weeds kind of policy ideas, I think it's really important to hear from you all, so we have a better sense of how can we help you and what's most effective.
Thank you for that. I'm going to go to Eric with this question, just so when we go in and we give the information that we're further educated about it. How does the food as medicine fit into what we understand so far about the MAHA initiative of the U.S. Department of Health and Human Services?
Well, when you say what we understand so far, the funny part is we're still trying to figure out what that really means. But on paper, you would say that food as medicine would fit within what they want to accomplish. However, the policies that we're seeing rolling out, I think, and personally contradicts, you know, everything that they're trying to do. For example, when you're looking at requests from numerous states to restrict SNAP benefits, or at least restrict what people can purchase, you know, using their SNAP benefits, it doesn't take into account whether those individuals have access to healthier foods, whether they live in a food desert or what have you, whether they can afford healthier food options, and how are they able to get to those stores and places where there's healthier foods. Rather than telling folks what they can and can't buy, we should be looking at, from my perspective, MAHA means looking at our federal nutrition programs, which addresses the most vulnerable populations of our country, and how do we ensure that those programs are actually providing access to people, and what can we do to improve access, availability, and affordability for those individuals. So some of the pilots and incentives that I talked about, like double your SNAP bucks, maybe investing more in that to where it can expand even further. The GusNet program, those are all different things that, again, are already put in place to make healthier foods more affordable for individuals. Let's see what we can do to improve those incentives. Finding ways to incentivize bringing grocery stores into local communities that do not have access to healthy foods. I used to live in Southeast DC. We finally got a giant grocery store in that part of the city a few years ago. And even still, the products that's there, you will go somewhere else in a more affluent part of DC, they don't have the same amount of options that you see there. Kind of to piggyback on what Billy was saying. So I'm two parts of one thing on my resume. I'm a former Hill staffer. And he is absolutely right. We know enough to be dangerous, but we're not experts in these issues. And oftentimes my old boss used to say, the squeaky wheel gets the oil, and what I encourage you all to be are the squeaky wheels. Yeah. All of y'all are health professionals you understand you understand what these actually mean to your patients and to the individual lives of people. Bringing that lens and that conversation to this larger conversation around food access, food security, nutrition security is key. And so I would encourage you all to also look at these policies from that lens. And as we're talking about these larger issues around healthcare, health access, making healthcare more affordable, you have to also think about what does food security play in that conversation.
Mm-hmm. And to back up for a second, what does MAHA stand for?
Oh, Make America Healthy Again.
Just so that we're all on the same page. So educators, make sure we're all on the same page. I know Congress folks and representatives like to hear narratives. Narratives, as they say, put it in a narrative, it usually sticks and it helps. So Kofi, tell us more about how can you describe hunger and how it impacts your patients and families in a clinical setting and how we can bring that in?
Oh, great question. Typically, when I talk to patients and families and think about sort of the journey of hunger for my families, for the last 10 plus years, I've been a provider in Anacostia down the street in DC, seeing a variety of families that I love, and I really have enjoyed my role as a community pediatrician. Some of the things that they've shared with me is that one of the triggers to hunger is not just not having food, typically is some sort of sudden impact to one's income, right? When a sudden impact to one's income occurs, it sets off a cascade of coping mechanisms that family has to put in place to maintain a sense of stability. One of the first things to drop in one's home when you have an impact to your income is your food budget. Because the food budget is so flexible, so fungible. So many of us have been in situations where we've had to change what we've been eating, maybe, for example, in schools and different things like that. For me, like even thinking about like college, and I had to change what I was doing because I didn't have the resources. So what do I do in these situations, right? So that food budget is so flexible, so fungible. So the first thing families typically do is change or drop their food budget. But at the end of the day, what we also realize is that food insecurity doesn't travel by itself. Hunger travels along with other social drivers of health as well. So the cascade of coping mechanisms, number one, family says they have this sense of food anxiety, a constant preoccupation, constant perseveration over where one's next meal is going to come from, right? So they're worried, they're stressed. Where am I going to get that next meal from, right? The next thing after that food anxiety is the quality of food will begin to drop. We call that a monotony of the diet. The diet becomes very simplistic. You're getting the same foods over and over and over again. Why? Because when I meal plan, like this person told me to do, that uses a lot of cognitive bandwidth. But with the stress being already high, my cognitive bandwidth is low. My ability to shift and focus on many things is very hindered. Let me get the same foods over and over again because it takes less stress on my brain. Let me get foods that I know my children and my other vulnerable members in the home are going to eat, because if they don't eat it, that's going to increase waste and that's going to increase stress. Fruits and vegetables? You tell me they're going to last how long? Let's not get any fruits and vegetables. Let's get things that I know are going to last. Again, typically are going to be more ultra processed, going to be cheaper, easier, very convenient, hyper palatable, incredibly flavorful. I'm going to lean towards those foods. The last step is after the quality of food will begin to drop, the quantity of food will begin to drop. Well, whose food drops first? Adults, because adults love their children. So adults will try to create sort of a barrier for their children so they don't see it. So adults will drop their food intake first, and then lastly, children will drop their food intake. You may say, okay, well, children are protected. We're not really worried that much. You must not see that much in clinic. The reality is, when that temperature increases at the first stage of that journey, everybody in that home feels that increased stress, increased temperature, in a variety of other ways as well. Just because food is not dropping, the intake is not dropping, that stress increases. And when toxic stress increases, it creates permanent changes in the brain. It creates increased sort of poor outcomes and worsening health. And that's what we worry about across the board. So that's what typically families share with me.
I'm just giggling to myself. I'm thinking about my 6-year-old who will only eat broccoli. That's the only vegetable she'll eat. But you're thinking about it, it's like it's stress. It's less stress. You do the same thing. You want them eating. And there's no stress when it comes to buying food. So it goes across the income field too. So it's not just those who are stressed, but also those without income. But every adult in here is thinking about what I'm going to eat for dinner and how it's going to come across. Kelly, we're talking about food as medicine in general. What, from your perspective, what is the impact that we want to have in this movement? What are we aiming to achieve?
Sure. I first just want to acknowledge, Kofi, you're such an amazing storyteller, and I've heard you many, many times, but you literally just walked me down my childhood experience with hunger and food insecurity. So, and maybe that's happening for other people as well. And it really does impact your life, and it's actually probably why I'm in the field of nutrition. And I feel so passionate about this. So Number one is to make sure people can really activate and have a happy, healthy life and actualize on what they're here for, rather than freaking out and having that anxiety, which is real. That's what food as medicine is about. How can we help our clients or people live their best lives and show up for the birthday parties they want to be at, show up for work and be able to produce and be productive. And given the audience, I would say, and what Kofi talked about earlier, you don't need to know everything about nutrition, but know that you have people out there who can help you, help your clients, help your patients, and be part of your interdisciplinary team. And I love it when doctors are involved and engaged in nutrition. It's really important and become this collaborative team because we actually end up not missing things. And depending on how we approach with empathy to a client, we can kind of learn like what's their motivation, what would help them do better, and rather than me and what I think they should do. So having a solution that supports the dietitian, supports you as the medical provider, and supports the patient. And really making sure that we're looking at community-based solutions. What works in Colorado may not work in Portland, Oregon, may not work in New York. So really tapping the knowledge and the expertise of those community-based organization advocates and experts who've been working on this for quite a long time.
Amen. So we had some education, you know who these folks are. We gave you some data. We talked about something you can do. Now I'm gonna open the mic for folks to ask questions. So I know this group well. You can get to the mic, introduce yourself, no soliloquies. I'm from the Deep South. I will politely cut you off, but just you can introduce yourself and please ask a question. Don't be afraid to come to the mic and ask a question. I think we have someone at the mic now. We have this mic and we have this one as well, but I'll call this mic 1 and this mic 2 just in case folks start to jump up. So please.
Hi everyone, Audrey Davis, Cancer Support Community. I'm in Oncology Patient Advocacy. You all talked about food being cultural, but I think food is also comfort, right? I'm thinking about my dad when he was diagnosed with stage 4 colorectal cancer, being originally from Haiti, wanting to go to the local Haitian restaurant, and maybe it wasn't the healthiest option. I saw how much grease there was, it wasn't, but for him it was comfort. Thinking about my mother-in-law going to Chinatown. My question for you all is this: what partnerships are you all working on with not only community-based organizations, but also local restaurants, grocery stores, et cetera, that keep in mind the ethnic, cultural comfort component of food as medicine?
That's a wonderful question.
Maybe I'll just kick off with dietitians. That is part of our training. And we have thousands of dietitians across the country who are looking into and providing education around the neighborhoods that they are in and the people that they are working with, which are very diverse. And that's, you know, the first thing we're talked about is what's good for me is not good for you necessarily or desired. And so helping people, but like Kofi, or maybe you mentioned, there's not always access. I think you mentioned sometimes it's not a grocery store, and you mentioned the Giant, and I lived in that neighborhood too when it came on board. And before that, it was just a smaller store. So if you didn't have a car, you couldn't get to somewhere, you couldn't get to the farmer's market. And the other thing I wanted to mention is that Giant, and I go there every once in a while, it's still cheaper in my neighborhood in Northwest than the Giant in that neighborhood in Southeast, and that's wrong. And so we need to also fix that and make it more accessible for people to buy the foods that they want to have on their table.
Good question. Go to mic 2.
Good morning, everyone. My name is Raven Parker. I am one of the grant managers at Nmqf. Thank you all for coming. So I have a few questions, but I'm just going to limit it to one out of respect of everyone in time. And it's kind of hard for me to choose, but so maybe the systematic approach to access and conservation of community gardens, sanctions, and also the responsiveness or holding the local government accountable is the topic in general. The question is, how can we hold the local government more accountable since, you know, with our new administration, it's ever changing and in many ways ever challenging. So when I was growing up inner city of Waterbury, Connecticut, I was raised to use my voice. How I'm thinking of it to, you know, finish up my question is, growing up, I used to think of the federal government as kind of like an older sibling that maybe we could go to make sure the local governments were held accountable. But because our federal government is changing, how can we hold the local governments accountable? Thank you.
Yeah, I guess I can jump in, and if you're a DC resident, obviously, DC is in sort of a tricky place given just the funding stream and how that all works. I think you have to use your voice, right? I can speak, only for kind of my boss and what we're doing, but we're doing things like back in Illinois, we're doing town halls, we're doing visits. We went to a food pantry in our district to talk about potential SNAP cuts. We are trying to meet people where they're at, and one of the number one questions at every telephone town hall or in-person town hall my boss has done recently is, what can I do? How can I get involved? And I think we're at a sort of unique time, right, where we're seeing a lot of this play out in the courts, and so we're going to have to hopefully rely on the judicial system, because unfortunately our legislative branch has kind of seceded its power in some ways, and they're afraid to challenge the executive, and so I think that's just making the entire government a very tricky place to work in right now. But I think we have to continue to just raise our voices, show up, call people out, call your elected officials. But then I think you bring up a good point too of when the federal government isn't fulfilling its duties and not meeting the needs of its constituents, that's sometimes where state and local governments can have kind of a preventative impact. And so, if DC or your state or, your city can leverage funds or move money around so that they can help sort of fill in where the federal government is falling short, I think that's super important at this time. But yeah, it's a really tricky spot with the federal government right now in the current landscape.
Latasha, can I answer that as well? So I was at a visual yesterday, and I wanted to even say it was Congresswoman Kelly who said this, that obviously advocacy plays a huge role. It's not just on the federal level, but that advocacy, making your voices heard at the state and local level is also key. And to the point now where everything is hyper-politicized, it is important for your state reps and your governors to hear your concerns, because they are the ones who have access at the federal level. To the point that I was just reading an article today where I'm talking about, I just mentioned around the threats we're seeing around SNAP, there's efforts to kind of push some of the federal burden down to the states, but some of the quote unquote red states, or the states that they feel voted for Trump, are pushing back and saying that, and there's concern now that these states can't afford, to cover those gaps. And so now that's starting to resonate and bubble up to USDA, which is starting to bubble up to the congressional members who have to write these proposals around how these cuts are going to be disseminated. They're starting to hear these concerns. You're hearing it around Medicaid as well. All of a sudden, there's an effort to want to quote unquote protect Medicaid when they know they still have to cut $800-something billion out of the bill that funds Medicaid. But they're telling you they want to protect Medicaid. It's because they're hearing from state and local, as well as people back at home, that you can't touch our Medicaid. So that pressure point has to not only be at the federal level, but also at the state and local level.
And go to your state and local meetings. There are local neighborhood meetings that happen all the time. Who knows who their alderman is, right? Who knows who their supervisor is for their neighborhood? So knowing who the local officials are, so you can, because I've been in those meetings and there's very few people at those meetings, unless you're in DC Ward 7A, debate, we show up at those. But making sure that we show up at those and run for those. I can name some names, I'm not gonna do it. People in this room that could probably run for state representative right now, but you don't look at yourself that way. So I'm gonna throw an action out there. Look into the requirements to become a state representative for where you live. Look into the requirements it takes to be a local representative for where you live, because believe it or not, it doesn't take a lot of hours, and you all are extremely equipped to run and be in those positions. So I would definitely encourage you to consider it. So I think Mike 2 was up before Mike 1, or or was he up first? Okay, Mike 1.
Oh, you're sweet. Thank you. Hi. So thank you all for being here. I think this is an amazing topic. I'm a family medicine physician by trade, and I have been in correctional medicine for quite some time. And I believe this conversation of food is or as medicine is not a new concept for us. I think culturally we have been doing it for quite some time in multiple different ways. And I often think about the correctional setting because you have a captured environment, literally. And they have been required by the 8th Amendment to have medical care, which means you have to do tailored medical prescriptions for their care. And we have seen decrease in their chronic diseases, decrease in hospitalizations. So systematically, we've proven the improved health outcomes and decreased costs. So my question then becomes, what have you found as being successful, and then what are your barriers when it comes to implementing these policies, and what are you coming up against? Because I can tell you, think about the inmate, because they will sue when they're not getting the proper diet. They have different things that they are using. And so sometimes I think if we think outside of the box, like some of our creative inmates, we might be able to get around some of the barriers we have in Congress and other areas in federal government. Thank you.
I can't speak to the policy part, but I can tell you about programmatically what has been working from our end. So something I haven't mentioned much. So I work at Elevance Health. Elevance Health previously was known as Anthem. It's the second largest payer in the country, over 47 million members around the country. And my role is the Food as Medicine Director there. So I create interventions and programs using food as medicine as a tool to improve health outcomes around diet-related chronic conditions, food insecurity, nutrition insecurity, the list goes on. But one of the things that we've seen is that there's a ton of engagement and excitement around this topic. But if you look at the data points around the country, a lot of these interventions have been quite small. 200 people here, 300 people here. I always make a big argument. There's not much in the pediatric space. A lot of the emphasis has been in adults because adults carry the burden of disease and all these things. And so we're advocating for more of those kind of studies and across the board. We see the effectiveness of medically tailored meals, right? Those programs have been done for many, many years. We've seen them time in and time out. We're seeing Medicare really lean into those programs, right? Produce prescriptions and medically tailored groceries, we're starting to see more of a swelling of those kind of programs, more advocacy around those programs, trying to figure out how to really make them more effective. We see them in the literature outside, but what does it look like in the practical world, working with members in different settings, in commercial, in Medicaid and Medicare? Those are the difficult parts here. But across the board, we are implementing these programs. We're seeing food be used as a great tool to engage members, food be used as a great tool to actually improve health outcomes. And there's also quality improvement that's occurring. And yeah, at the end of the day, what's happening with cost savings? One of the biggest investments into food as medicine from this lens is we're seeing the cost of healthcare go up significantly. So can this be used as a tool to help to curb the cost of healthcare? Also recognizing members, patients, families are asking for this as a tool to improve their health as well. I get it, I want to tap into medications, I'm using my medications appropriately, doc. But can I also tap into these foods as well? I keep hearing about this. Can I use that? How do we work alongside patients and families to help them improve those health outcomes? So those are some of the things that we've seen to be quite successful in.
Yeah, I would just follow up briefly if I could. Thank you for bringing it up in terms of kind of the criminal justice system. That is something I was not looking at, but I think that'd be a great idea to sort of look how we can study. And I think we're seeing this in like IHS and within the VA system, right? Any sort of institutionalized setting, I think it's easier to implement some of these things, and it's also easier to track the data. And so I think that's how we're going to continue to scale and see more and more data showing the effectiveness, showing the cost reductions, and that can help us sort of broaden these programs.
In the essence of time, we only have time for one more question, and Mike 1 was standing first, so I'm gonna have you answer, and then we'll have to wrap up, unfortunately. But our panelists will be here if you want to ask anybody anything individually. Yes.
Thank you all. Zachary Hermes, cardiologist, population health management at Master Brigham. Kofi, I'm gonna direct this at you. I think much of the conversation was rightly focused on federal programs, Medicaid, SNAP, WIC. Kofi, I'd love to hear from you from a commercial perspective, and also thinking about MA even concretely, practically, how are payers looking to push the envelope and again begin to scale and really rigorously pilot these programs? As we know, as I think was called out, food as medicine is also a nuance and separate from nutrition and security. So we know there's a big, I focus on cardiovascular kidney metabolic syndrome, and I think of food as medicine as really a structural component of care for that patient population, regardless of actual financial status. So I'd love to hear your thoughts about practically what our payers doing to begin to scale and push the envelope.
Love it, love it. Let me start with this piece here. Kelly, I always say this, and I haven't said it yet today. I started off talking earlier today about this concept of training doctors to do better and engage nutrition better. The goal of that concept is not to make MDs RDs, right? We cannot replace the work that RDs do. RDs are phenomenal in what they do. We need to work alongside each other better. One of the things we need to do is do no harm. A lot of what we have done is more harm than good because of the lack of training in this space. Because of the lack of training, because of the inaccuracy in how we're communicating about this, the stigma we bring in this world, even around weight and the things that goes on and on and on. There are better ways we can do this. When we think about the payer world and how we're engaging it, I'll highlight some of the work that we're doing in this space to really think about this in a nuanced way. Number one, we work in commercial, Medicaid, and Medicare. And oftentimes when people talk about food as medicine, they're only thinking about, well, isn't this really just a program in Medicaid or in Medicare? No, 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 no. Again, across the board, diet-related chronic conditions are prevalent. Poor nutrition is the leading risk factor for premature mortality. It's the leading risk factor for premature mortality. So this can be used as a tool across the board. So at the end of the day, a few things that we're doing. Number one, we're trying to make sure that food as medicine is a core component to every single line of business, okay? To how we're building out our programs. We're building out novel interventions and programs and setting them up through all lines of business. Even if you talk about food insecurity, right? People are like, oh, food insecurity in commercial? That doesn't exist. Come on. At the end of the day, it's ubiquitous. It's everywhere. Let's not just think about this and narrow in and allow our biases to determine where food insecurity exists. So we're engaging it in all lines of business. Number two, we're trying to advance a digital-first approach to food access and education. Are there digital tools that we can use to improve access to food and education, recognizing that there's difficulty accessing food in different parts of the city, in the region, in the county, in the city? How can we do that better? And then number three, how can we lean into advocacy? Advocacy around thought leadership, our communication, how we talk about this, providing a source of truth that people can rely on, right? How can we do this around education, improving education and medical training, improving education and how we engage this topic, public advocacy, and research as well. We're trying to put a lot of research in this as well. So at the end of the day, we're building out programs across the board in every line of business that does this, that uses medically tailored meals, groceries, produce prescriptions, working alongside doctors, nurses, patient care technicians, teams, and nutrition education to implement these programs so docs aren't having to do everything on their own, right? The dietitians aren't all having to do everything on their own. We're trying to bring the worlds together.
Thank you for that. So that's it, y'all. We got 38 seconds, not time to ask another question, not time to do any final thoughts. So we want to give our panelists a round of applause. They'll be sticking around. It's lunchtime, so food is medicine around lunch. Make sure you eat your vegetables. So thank you all for coming. All right.
Thank you.
Thank you so much. Come.
So, right, yeah. Well, good afternoon, everyone. Happy Monday. I hope everyone's enjoying their food so far. We're going to go ahead and kick off the programming for this luncheon. So I am Earl Flood. I am the Congresswoman Kelly out of Illinois. I'm her Deputy Chief of Staff and Legislative Director. So first off, thank you all for joining us as we honor the outstanding individuals being recognized at this year's Congressional Award ceremony. As we celebrate, it is with great honor to welcome these three remarkable leaders who will be recognized with these awards. To begin, I'm proud to recognize Kevin Chang, Health Legislative Assistant for Senator Maria Cantwell, who will be presented with the Chairwoman's Congressional Staff Leadership Award. His dedication to policy and public service exemplifies the important work being done behind the scenes here on Capitol Hill. Next, Deborah Tellman, Executive Vice President in Corporate Affairs and General Counsel for Gilead, is getting the Chairwoman's Congressional Corporate Leader Award. With her leadership in the legal and corporate fields, she brings a vital perspective on corporate responsibility and public engagements. And finally, Congresswoman Yvette Clark, Chair of the Congressional Black Caucus. She will receive the Chairwoman's Congressional Leadership Award. She is a tireless advocate and trailblazer whose work continues to uplift and inspire underserved communities. The dedication, vision, and commitment of these three leaders are true reflections of the values we are here to celebrate. Thank you once again for joining us. I hope you have a wonderful evening recognizing our award recipients. Now please join me in welcoming the Honorable Congresswoman Robin L. Kelly, who will present the awards. Thank you very much.
Thank you so much, Earl, and I hope you guys have been enjoying the summit so far. Now, let's present the Outstanding Corporate Leader Award to Deborah Tellman. Deb joined Gilead in 2022, and prior to her current role, she served as Executive Vice President, General Counsel, and Corporate Secretary at Organon, a women's healthcare company building out the legal, ethics, and compliance, and environmental health and safety organizations following the company's separation from Merck. She's busy. Over the course of her more than 25-year career, Deb has provided legal counsel both in an in-house capacity and in private practice, including experience in global mergers and acquisitions, governance, and litigation. She has held increasingly advanced positions with several Fortune 500 companies, including Johnson Control, Boeing, Abbott Laboratories, Sorrento Therapeutics, and Morgan Stanley. PR Weekly magazine also named her a top 30 health influencer in 2022. She received a Juris Doctorate degree from Boston University School of Law and a bachelor's degree in mathematics from the University of Pennsylvania. Deb currently serves on the board of directors of the Chicago Humanities Festival. Please join me in welcoming Deb Tellman, our outstanding corporate leader, to the stage. Thank you. To the mic.
All right. Good afternoon, everyone. Thank you to my friend, Congresswoman Robin Kelly, for that warm introduction. And I'd like to extend a huge thank you to the Congressional Black Caucus Health Brain Trust, which does such important work, and the National Minority Equality Forum for shining a light on Gilead with this award. This award reflects Gilead's deep commitment to health equity and inspiring a history of innovation for the communities and people we serve. I'm honored to accept this Corporate Leader Award on behalf of the 18,000 colleagues at Gilead Sciences. It is a testament to our collective work. Awards and recognition can be more than a plaque or a ceremony. It's also the encouragement needed when the work is hard and the work is important. In our field, biopharma, it means so much to be called out for the good that we do. Gilead Sciences is a global biopharmaceutical company based in Northern California. And I was drawn to Gilead for its bold ambitions to create a healthier world for all people. For more than 35 years,
We've been pioneering transformative therapies to improve the care and outcome for millions of patients with life-threatening illnesses, such as HIV, viral hepatitis, breast cancer, and COVID-19. Nearly 40% of all new HIV cases across the US are within the Black community, despite only being 14% of the US population. Unfortunately, Black women account for more than half of new HIV infections in women, despite being only 15% of the female population. Black women are nearly 3 times more likely to be diagnosed with triple-negative breast cancer and 28% more likely to die from this disease compared to non-Hispanic white women. For most of us, these are not just statistics. These numbers represent people we know and communities we serve. And data pushes us to act on behalf of all people, including the Black community. It reminds us that advances in care are not felt equally across the country nor the world. And I couldn't agree more with the focus of this summit, moving from data to action. We know that areas across the country and our own backyards, our own communities, have the greatest unmet needs. That's why Gilead is committed to expanding access to our innovative medicines to help those who need it most. But our work doesn't stop there. We know innovation is the first step. Partnership ensures impact, like with the National Quality Minority Forum. That's why Gilead goes beyond the medicines by collaborating and investing in communities who have historically been left behind. Together, we can change the trajectory of these epidemics, and right now, we have an opportunity to change lives in our lifetime. Gilead recognizes the important role that your offices, teams, and positions hold in changing patient outcomes across the country. And policy is a powerful lever for sustainable change and a way to remove barriers to care. Now is a time to press forward and reach across the aisle, all in the name of saving and protecting lives. I know that's something we can all agree on, and some of you are already doing it in your field. We truly can't do this alone and need champions like you to work with us in terms of changing lives. Thank you again for this powerful encouragement this award represents to me and everyone at Gilead Sciences.
Congratulations again, Deb, and thank you for all your years of dedication. Now I'm excited to present the Outstanding Congressional Leadership Award to my dearest friend and colleague, Congresswoman Yvette D. Clark. Oh, sorry. Hold that thought.
Thank you, Congresswoman. Now I have the honor to introduce our other congressional awardee, Kevin Tang. Kevin is currently serving as Healthcare and Social Security Policy Lead for Senator Cantwell from Washington State. I met Kevin 3 years ago when I was coming to the Senate as a freshly hired for Senator Ben Cardin's healthcare team, and his compassion to newer staffer, and especially staffers of color, was impeccable and remarkable. During his 6-year career in the United States Senate, Kevin has led the introduction of legislation to lower prescription drug costs, increase access to fentanyl and opioid treatment, and expand Medicare coverage of treatment for diseases like lymphedema. He has also served for 2 years as the chair of the Senate Glass Caucus, the Senate's LGBTQ+ staff association. Before his time on Capitol Hill, Kevin served in the Peace Corps in Lesotho, where he partnered with local government agencies to increase English education capacity and promote HIV/AIDS awareness. So it is my pleasure to now bring to the stage my dear friend, Kevin.
Good afternoon. I hope as everyone is doing well. Thank you, Michelle, for introducing me, and thank you, Congresswoman Kelly, and thank you to the Congressional Black Caucus Health Brain Trust and the National Minority Equality Forum for presenting me with this award today. I am truly humbled. Thank you. It is an extraordinary and emotionally turbulent time to work on healthcare policy in the United States today. I feel like at any moment and any single day, I can experience every emotion on the spectrum, which is absolutely not good for mental health, but that's okay. I feel pride because I have the opportunity to work on such an important issue that touches everyone's lives at some points, whether it's you, your friends, or your family. And no matter what age, race, or political affiliation, healthcare affects everyone. I feel joy because even though you don't get a lot of healthcare wins, the ones you do get, whether it's helping a family afford health insurance or helping secure funding for a hospital to purchase MRI machines so that they can expand cancer care in rural parts of this country, that makes it all worth it at the end. I also feel anger when I hear so many people out there pleading for help to obtain the most basic of human dignity, the ability to live a healthy and productive life and to provide for your families, and how people of color and marginalized communities are disproportionately paying the price of inequity. But ultimately, I feel hopeful, because according to multiple studies out there, there is a consensus in this country that healthcare is simply too expensive, too difficult to navigate, and just not working for everyone. And that gives us a chance to make meaningful changes that can last. And that is why I am so heartened to see that there are so many people in this room alone who are dedicated to doing the right thing and helping others. And with that, I'd like to thank you. Thank you for all the work that you're doing, all the work that you've done, and all the work that you will do in the future. Thank you, and I look forward to working with you to make the United States a healthier and more equitable place for all. Thank you.
All right, everyone. So as you know, members of Congress are busy at work trying to save our healthcare. So for the meantime, I will let you all enjoy a little bit more of your lunch before we bring up to the stage our last awardee, Congresswoman Clark, who will be on her way shortly, okay? So thank you all and keep enjoying your lunch, and we'll be back soon. Hello, everyone. I promised I was going to come back here shortly to finish the programming. So we have our last awardee now joining us at the stage. Thank you, everyone, for your full attention. I'm excited to present the Outstanding Congressional Leadership Award to Congresswoman Yvette Clark. I know my boss, Ms. Robin Kelly, was just here, and she was so excited that she was going to get to do this. But Congresswoman Clark is hailing from Central Brooklyn, and she feels honored to represent the community that raised her. She's the proud daughter of Jamaican immigrants, and she takes her passion for her Caribbean heritage to Congress. Clark is a senior member of the House Energy and Commerce Committee, and she has been a member of the Congressional Black Caucus since coming to Congress in 2007, and today she serves as its chairwoman. Yes. As the representative of the 9th Congressional District of New York, she has led critical legislation to support the health of women, including the Menopause Research Equity Act, the Stephanie Tubbs Jones Uterine Fibroid and Education Act, and the Uterine Cancer Study Act. Clark is also a leader in the tech and media policy space. She's also one of the co-chairs with my boss, Rep. Kelly, of the Congressional Caucus of Black Women and Girls, which develops programs to support the aspiration of Black women of all ages. She's also a proud active member of the Brooklyn Alumni Chapter of Delta Sigma Theta Sorority, Inc. Please join me in giving a warm welcome to not only an exceptional Congresswoman, but also one of Rep. Kelly's dearest friends, Congresswoman Yvette Clark.
Michelle, I will certainly let my bestie, Congresswoman Robin Kelly, know what a wonderful introduction you gave for me today. And let me say greetings and good afternoon to everyone. As has already been stated, I am Congresswoman Yvette D. Clark, and I am very proud to represent New York's 9th Congressional District, located in Central and Southwest Brooklyn, and am the proud chair of the Congressional Black Caucus for the 119th session of Congress. Before I begin, let me first say what a distinct pleasure it is to be with you all today during the National Minority Quality Forum Congressional Awards Ceremony and Luncheon. I'd like to take a moment to recognize Dr. Gary Perkerin, President and CEO of the National Minority Quality Forum, for his leadership and in keeping true to the mission of this organization in ensuring the reduction of patient risk and advancing health equity within our communities. It is indeed an honor and a privilege to accept the Congressional Leadership Award and be recognized for the contributions that I've made in ensuring equitable health care within minority communities today. I do not take this recognition lightly. Since 1998, the National Minority Quality Forum has implemented research and data collection in identifying disparities in healthcare for underserved minority communities throughout the country. Now more than ever, it is critical that the Nmqf stays true to its mission and fills in the void that this administration has made with defunding the Department of Health and Human Services and the defunding of Medicare and Medicaid. The administration and Project 2025 have blatantly targeted underserved communities and their quality of care. And I am committed to continuing to shed light on the health disparities within our communities and advancing health equity in America. That's an imperative. When I think about health equity, I immediately think about how Black women, our veterans, people with disabilities, and children in America are disproportionately impacted. And in Congress, my mission is the same. I am focused on laws that target the disparities harming our communities and affecting our health. I'm the "are we there yet" kid. You know, I'm not going to stop. I'm not going to relent until we make it, until we get there. And until then, they will continue to hear my voice. I will continue to introduce legislation. I will fight bare knuckle brawls to make sure that our people receive the health care that they are entitled to. During my time in Congress, I've introduced legislation for uterine fibroid and menopause research and to increase the diversity of participants in all National Institutes of Health funded trials. I've co-led bipartisan legislation on preventing massive cuts to New York's hospitals, Medicaid payments, and ensuring that individuals suffering from end-stage renal disease will continue to have equitable access to private health care. And as for bipartisan support to restore support for programs to reduce disparities in health care, disparities that create serious problems in African Americans, such as AIDS infections, the elderly who are less likely to receive a flu shot and disproportionately suffer from high blood pressure and diabetes, and Black mothers who are less likely to have access to prenatal care services. In closing, I will continue to prioritizing the inequities in our community's health care with the urgency it warrants and use my position to advocate for those who have no voice and are often ignored in the medical room. Let me say that it's times like these where we need to have a vision of where we want to go. At the end of the day, we cannot be mesmerized by the chaos and dysfunction. We cannot afford to be distracted by the distractor in chief. We cannot afford to feel bad about the cruelty that we see around us each and every day. We must remain focused, because in the day after, we have to roll out our proposals for an equitable health care infrastructure in the United States of America. Each and every one of you have put sweat equity into building that infrastructure, and we will be victorious in erecting it. At the end of the day, it's about our collective humanity. That excludes no one. And at the end of the day, it is addressing the inequities that have historically plagued communities of color. We have the talent, the skill, the expertise, and ability to make sure that this nation lives up to its creed. And that means that we continue to keep our shoulder to the wheel, notwithstanding the nastiness that we must confront. So let's roll up our sleeves, and as I tell the members of the CBC, let's go. So to each and every one of you, I know that you will do the same, that you will meet me in the trenches, and together we will blaze a new trail, a victorious trail of healthcare equity for our people. I am truly honored to receive this award, and I promise to make a concerted effort in utilizing my role in Congress to push, to prod, to mess around with, whatever I need to do for equitable health care for our people. So thank you so much for listening. Thank you for every step each of you have taken to bridge the health disparities that for too long have harmed Black lives. And together, I am certain that we will ultimately achieve the health equity that every Black American deserves. So thank you all. Stay safe, stay strong, stay healthy, stay engaged. God bless you. All right. Oh, come over this side.
Oh, okay, I don't mind. Okay. Yeah. If it's okay with you. Okay, thank you.
Congratulations, my love. Many blessings.
Yes. You're representing my home city, Brooklyn.
Oh, really?
Yes, that side is
There was a 22-year-old college senior that came through the emergency department really just complaining of vague flu-like symptoms and was screened through our focus routine opt-out testing and ultimately found to be HIV positive. It probably would have been some time for someone to say, hey, let's test this patient for HIV. There was no reason to suspect anything otherwise.
When I took office in 2017, we were in a crisis. There are notable racial disparities in HIV diagnosis and care outcomes within African American communities here in Louisiana. I was concerned about my community. It could no longer be ignored or minimized. It had to be addressed.
Focus works behind the scene to address health inequities by working with government stakeholders, community partners, hospitals, just to be able to implement routine opt-out screening that normalizes and destigmatizes testing.
Everyone needs to know that it is all right to get tested, and knowing your status, knowing what life you have to live. It helps you support the individual because you know what they're going through.
Removing stigma allows people to get an answer about their status.
We really wanted to tackle better health outcomes for our communities and for our state. And so it made sense in the emergency department that we can incorporate a program like Focus that actually brought resources in to help us do the work and do this testing.
Right or wrong, a lot of people are still using emergency departments as a safety net for access to primary care. Focus is absolutely a systematic change. It's hardwiring these workflow into the fabric of the emergency department. We've altered our electronic health record to incorporate the screening questions during triage. Before the college student had come into our emergency department, had actually presented to an urgent care after feeling weak. They saw him, gave him some anti-nausea meds, told him to go home, but the very next day, his symptoms just progressively worsened. That caused him to go to one of our sites and he got screened. He is identified early, he's linked to care early and unable to transmit that disease.
Before Focus started, we had tested that year about 150 patients. Last year, we tested about 30,000 patients across the different facilities that are doing the program now. Focus has really allowed us to get to patients and identify them sooner and not just realize that they're positive for these diseases, but then help them navigate the healthcare system and actually get connected with care.
Focus is an innovative approach to screening for HIV and HCV, but we think that this model can be applied to a host of other diseases because it really is just making sure that the populations who need it have access to screening and they can get into the care that they need. I have seen firsthand the power of collaboration and the need for collaboration if you are going to see results. I would encourage other cities to connect with local nonprofits, organizations like Gilead, who are front and center when it comes to public health issues.
This is something that is very tangible. It's a bigger part of this organization.
This is bigger than just one facility, even bigger than just one healthcare system. When we work together, we can really make a difference. If we screened all of our patients that come through our emergency departments in 1 year, we could potentially identify 40,000 positive HIV or hepatitis C antibody patients. When you start thinking about stopping the transmission of those 40,000 patients, you're really talking about stopping the spread to potentially millions of people. That's how we end the epidemic.
Wow.
All All right, good afternoon. Good afternoon, everyone. My name is Michelle Galdames. I am Senior Health Policy Advisor to Congresswoman Robin Kelly. Thank you so much for joining us during this session, Advancing Policy-Driven Solutions to Address Barriers to HIV Prevention Access. Right here on stage, I have 3 distinguished panelists, all coming from different sectors, but all with one goal, which is to mitigate some of these barriers to HIV prevention access, but also inform and educate the populations. First, I'd like to say a quick facts to level set before I go on to introducing our amazing panelists. And to paint the picture on HIV, globally, there are about 39.9 million people living with HIV. And out of those, 53 were actually women and girls. Here in the US, it's 1.2 million people that have HIV. So what has Congress done around this topic? Well, we've had great legacies like Rep. Barbara Lee's, who have, she has definitely paved the way, whether it's been globally or domestically. And she actually passed that torch to my current boss, Rep. Robin Kelly, just last Congress, to lead the charge in reauthorizing PEPFAR. Well, I know these 3 distinguished gentlemen definitely have heard of HIV, PEPFAR, and the barriers that our communities experience. So first off, I'd like to introduce Christian Morris at the end over here of our panel. Christian Morris is completing his master's in public health with a focus in health behavior this spring from UAB. He currently works full-time as a research coordinator at Us Helping Us, a historically Black nonprofit working to reduce the burden of HIV on the Black community in the Washington, D.C. metro area. Christian is originally from New Orleans, Louisiana, and has a passion for addressing intersectional stigma and advocating for communities' right to life and mental health. Thank you, Christian, for joining us.
Thank you. Thank you.
Then we have Dr. Keith Rollins. He is a former senior medical director of medical affairs at ViiV Healthcare. Prior to joining ViiV, Dr. Rollins served as director of HIV medical sciences at Gilead Sciences. He is past chair of internal medicine and co-chair of the infectious disease HIV for the National Medical Association. He has published over 100 abstracts and manuscripts and co-edited one of the few books, HIV/AIDS in the US communities of color, on the HIV epidemic among minorities in the US. Thank you, Dr. Rollins, for joining us. Last but not least, I have Carl Schmidt to my right. He has been a national policy and advocacy leader in the HIV community for over 25 years. In December 2019, he formed the HIV plus Hepatitis Policy Institute, which promotes quality and affordable healthcare for people living with or at risk of HIV, hepatitis, and other serious and chronic health conditions. He spent 16 years with the AIDS Institute, serving as its deputy executive director. He's a cancer survivor and living with chronic hepatitis B. Mr. Schmidt earned a BA in the Public Affairs and an MBA in International Affairs from the George Washington University here in Washington, D.C. Thank you, Carl, for joining us. Now, as we saw in the amazing introductory videos, it is about having focused partners and partnership across policy, research, community, and focused partners like Gilead and others in the space to make this all happen. Just like with policy, you need your state, your local, and the federal government. But I think for the purpose of this conversation, it's important that we level set the knowledge in general for our audience. So I'm gonna start off today's discussion with this question for all my panelists. Could each of you briefly describe the primary barriers you see to HIV prevention access and better support the PrEP use in your respective areas of expertise? So whether it's research, clinical care, or policy, and how are these barriers impacting individuals and communities most at risk? Why don't we start with Chris?
Okay, awesome. Hi, everyone.
So my first thought to this question is that it's not a one-size-fits-all, and you have to think like population-specific, as I'm sure we all know. So the primary barriers that prevent, let's say, heterosexual black men versus LGBTQ youth versus black women is going to be different for each population. And so in some of the PrEP outreach work that we do at SWS, we do try and cater it to the specific population. So I would just say, in my personal experience, I feel like stigma is really a big barrier, particularly for heterosexual black men. I would say marketing for PrEP for black women. Every time I have a conversation with a black woman about PrEP, the response is the same. I didn't know that was, for women. All the commercials, I don't see myself represented in those commercials. And then for LGBTQ youth, I really would feel like just low perceived risk. That's really, from my experience, testing people, like I'm on the front lines, I didn't take it, I'm not sexually active right now, but we know it only takes one time. So I think it just really depends on which population you're trying to target and understand.
Oh, that's great. Dr. Rollins?
So I'm going to take a slightly different approach. I'm going to say the primary barrier to PrEP are actually healthcare providers. I'm just going to start there. And the reason I say that is because for whatever reason, a lot of us believe that the age that you're supposed to stop having sex is whatever age your parents are, or what they were. And I say that because we have gotten into a habit of pretending that PrEP is all about your behavior, and I would contend that we increasingly now know that this is almost as important to be your geography. Where you live, where you reside is actually the better teller of whether or not you will actually acquire HIV in the United States, because half of the people that acquire every year can be identified with roughly 48 counties, 3 cities, and 7 states. That's it. And while we like to talk about who is having sex with who and how often and whatever by healthcare providers, I would contend that the bigger problem is that we are using that as not so much as an access, but as a barrier to healthcare. If you are a woman and you went to your doctor and they never did a pap smear, you would not keep going to them. You would not keep advising your friends to go to them. But why do we go? The pap smear is just literally a screen for a viral infection that's mostly related to sexually transmission, leading to cervical cancer. HIV for PrEP is a viral infection screening that looks for the same kind of process that we just don't pretend, or we pretend that everybody that we talk to, we can somehow look at and pretend who they are. And while I agree with you that there's a certain amount of this about what we see in the advertising and so forth, you will not get on pre-exposure prophylaxis unless you see someone who can write a prescription for you. Those two things go together. And I would literally say that we need to begin to think about this less about what is your behavior or the demographics. The demographics overlay this, but if you live in one of these places, everybody in that particular geography should be getting tested. Stop asking people who they sleep with or how many people they sleep with. Just simply test them in that context, because only people who are tested negative get on prevention. The people who are test positive, we want to get into treatment. And if we're talking about PrEP, we need to begin to differentiate those two things.
So I feel that the biggest barrier right now is the lack of political will and leadership. It's wonderful that we have the drugs, both for treatment and prevention. And, but HIV is a public health issue. It's an infectious disease. That's the role of our government, both federal government and state governments and local, to deal with these issues. And, we have a CDC, we have an HIV program there, we have an Ending the HIV Epidemic initiative that President Trump started in his first term. And, it provided a focus on HIV in the United States that we hadn't seen in a while. But it takes sustained funding. It takes sustained leadership. And you need education. This has to be on people's minds. It has to be, yes, it's great to have the ads, But we need the local governments, and it was great to see that Baton Rouge work being done. But we need that in all the jurisdictions. We need the buy-in from leaders, your elected officials. Unfortunately, a lot of conservative, representatives don't get involved in HIV issues. But I think that is the biggest barrier, not getting to the communities that need it most. I agree with Keith, we need provider education too. So it's not only community education, it's provider education as well. Unfortunately, we're seeing an erosion of CDC's power, influence, funding right now. We could talk more about that right now in this program.
Absolutely, and yes, I hope we get to talk about that. What a time to have this conversation and just this convening as well, thanks to NMQF. Dr. Rollins, you definitely brought up a good point that I think we should segue, which is the healthcare providers and how we know there's a work shortage, but even just a workforce shortage. But given the evolving landscape or HIV transmission rates and the growing understanding of geographic factors that contribute to increased risks, there has been some discussion around whether current testing recommendations adequately reflect these regional variations that we're seeing. So do you believe the CDC testing recommendations should be updated to include geographic location as an indication for annual testing? And caveat is the CDC still stands to do that.
Yes. So the short answer to that is yes, I do. Right now, the CDC recommendation is that anyone between the ages of 15 and 64 should have at least once in their lifetime an HIV test, which is fascinating as long as you believe that people behave the same way that they did at 25, at 55, and the people who do things at 30 are the same at 60, which is clearly not true. The other part of this is that, as Michelle has mentioned, we have been seeing a steady decline in the HIV treatment workforce for the last decade and a half, and COVID exacerbated that. The only major infectious disease pandemic in the United States before COVID for a long time was HIV, and many of those providers are either retired, they have moved on, or they have been adversely impacted by the decreasing in the funding in academic institutions that used to support their jobs and their engagements. I will point out, though, that I say this about the healthcare provider because while there is indeed an important role for the federal government around HIV treatment, which is the Ryan White Care Act, which by the way, is the most successful thing in infectious diseases in the last 30 years, where we have been able to go from learning about an epidemic, a new disease state, and then getting interventions to improve. And it is the only thing in the US health system that has shown that you can pretty much mitigate the racial and sexual disparities that we've been seeing in HIV, has been those people who have been getting exactly the population that everybody claims they can't find, that won't come to care, that doesn't have insurance, but is the most successful group to actually suppress the virus in the country. The reason why this is important about PrEP, however, is that Ryan White doesn't cover prevention. It is not part of the federal funding. There is no federal funding that I'm aware of that's specifically aimed at HIV prevention. It's all aimed at treatment. So if you're HIV negative, you don't get the same resources as if you were HIV positive. While there are recommendations within our, for the US Prevention Task Force, it is also, as Michelle mentioned, this is a behavior that goes on also at the state level. We have had states who have literally sent back CDC money because they didn't like the population that we were engaging, even though their particular state was one of the ones that was most impacted by new cases. If you're going to address that, I agree that we need to do something from a policy standpoint, but the reason why I'm suggesting that, for Michelle's question, that they engage geography is that if you only say that you are going to test this person once ever, it would make more sense to not pretend that their behavior is something, let me rephrase this, and you don't talk about what their sexual activity is, The last time most of you went to a healthcare provider, they never asked you who you were having sex with, how much sex you were having, or anything else. I also find it interesting that healthcare providers that give out prescriptions for erectile dysfunction drugs don't want to talk about sex. So, which is kind of defeats the purpose of why you gave them the drug in a certain level. But the other part of this is that HIV is not just a disease of young people. 50% of the people living with HIV in the United States are now over the age of 50. By 2030, we anticipate that will be 70% of the population. We have to stop pretending that we are going to be able to pigeonhole people either by age or by race or by their sexual activity and begin to engage them about making this part of a routine form of primary and preventive care. And to do that, the recommendation about geography is that instead of saying only within this age group, which the second line in that in the current statement is, if you have some other reason to test more frequently, the argument here is to be more explicit about the idea of geography. If you live in one of those states, in one of those cities, in one of those counties, which, by the way, came out of the Trump administration the first time. This isn't something that was there. They created this model that has been incredibly engaging about understanding, but we need to incorporate that. And I think that that manifestation, along with adding it to the U.S. Prevention Task Force, would be the two places that I think, from a policy standpoint, you could begin to influence this. Because that would influence what insurance companies do, what states do in terms of their funding, how Medicare, and increasingly, for those of you who do not understand, if 70% of the population living with HIV is going to be over the age of 50 in 2030, a bunch of them will now be in Medicare. And so I think that those policies and those kinds of things, particularly around the geography, have got to become a part of our discussion if we're ever going to get a handle on actually preventing disease, not just taking care of those people who are living with it.
That's very interesting, and I for sure want to segue into one of your topics, which was coverage. You talked about that, and Carl, you have focused a lot of your work on ensuring private insurance cover prescription drugs, including preventive medications such as PrEP. How are insurance currently complying with the requirement to cover PrEP without cost sharing?
Yeah, so one of the benefits of the Affordable Care Act, and this is for people who have private insurance, is that preventive services, grade A and B recommended services from the U.S. Preventive Service Task Force are, private insurers must cover them and zero cost sharing to the patient. Excuse me. So that includes a number, I think there's around 50 different preventive services, but for today's conversation, HIV testing, hepatitis testing, and PrEP are covered. They all have a grade A from the U.S. Preventive Service Task Force, and therefore insurers should be covering these services without cost sharing. So in terms of PrEP, it's also, it's important to understand that it's not just the drug. It is, you need a provider visit first to, make sure you have an HIV test. You have to be test negative to be on PrEP. And so you need a prescription, you need a provider for that, you need a lab test as well. And so we want to make sure that not only the drug is covered, but all those associated services as well. And what we found is that even though it is the requirement, a lot of insurers are not living up to that requirement. The CDC did a study that found around 1/3 of all the insurers are still charging people for the labs. And you heard this a lot when colonoscopies got approved as well, that people were still being charged, not only for their colonoscopy, but for the anesthesia that was associated with it, or the provider visits as well. And then there was another study that was conducted that it showed around 1/3 of the people are being charged for their drugs, cost sharing. And this is a real deterrent. When people are being charged, they don't show up to their appointments. They don't pick up their drugs. So, and the interesting thing about this other study was that even for generic PrEP, the insurers were charging people for their drugs as well. So we need enforcement. It's great to have great policy, great laws and regulations, and we do have a very good regulation out of the federal government that said that all the current preventive drugs have to be covered without cost sharing and without prior authorization as well. But again, that hasn't been fully enforced, and then we have to make sure that the new PrEP drugs are also included in that.
Absolutely. Can I just add to that? Yeah. If you get a test, for example, in January, and it's negative, but now you engage in behavior that may do something that you now are worried about it, in some cases the insurance companies will not pay for the second drug test. Not drug test, the second HIV test. It's not just can you get it, it is do you need it and can you get it when you need it. The testing is the key. You do not go into PrEP unless you are HIV negative, and you need to get a test in order to prove that. So we need to stop pretending that if we just do the test once, that somehow covers you for the entirety of the year. This is not a flu shot. This is a blood test or a lab test to determine whether or not you have now been exposed to a virus. You have to do it in that context, and many people may start off with, I don't need this now, but I may need it later. And I think that's the concern that some of us have about how the policy needs to be amended, to Carl's point here.
Absolutely, and I love how we've covered coverage, one pillar, a second pillar of just treatment, care, but a third pillar that it's worthy of mentioning is the community engagement, the trusted messengers, and that's where Christian and your organization definitely come in. You work with the Us Helping Us organization, which is based here in DC, so it gives you a frontline opportunity to directly help our community, this community. Can you discuss the community engagement work you've done to support access to PrEP services? And what are some of those barriers to access, especially in communities with low PrEP uptake?
Yes, thank you. So I want to start by just highlighting a project that we have called Community-Based PrEP, or CB PrEP is what we call it around the office. It's actually funded by the DC CFAR, which is the Center for AIDS Research, the coalition of Howard University, Whitman Walker, Us Helping Us, about 9 institutions here in DC who collaborate for HIV prevention and treatment research. So CB PrEP, 2 phases to this research study. In the first phase, we conducted just a series of in-depth interviews with PrEP eligible people to gauge and build out the design for PrEP initiations on a mobile clinic. So a lot of times, you know, when we talk about different barriers, not just providers, but we're talking about people having to come in to see a provider, come into a brick and mortar clinic, and there's just, I mean, a slew of barriers that can prevent someone from getting into a clinic. So we wanted to design an intervention in which we bring PrEP to people in community on a mobile clinic. So phase 1 was just interviewing people, again, PrEP eligible folks, Black folks here in DC, to see where should we go, where should this mobile unit be parked, who should be staffed on it, what time should it be where, just sort of getting some community input in that. So that was phase 1, and now we're actually in phase 2, which is actually enrollment. So we're taking the mobile unit. I drive, you know, I'm safe, I promise. It's a big, you know, it's a mobile clinic, but we just drive it around Washington, D.C. in hotspot areas. So we sort of overlaid the hotspots that were identified in the interviews with what we know, to your point about geography, the zip codes with a high HIV prevalence rate in D.C. and PG County. And so we just overlap those areas, and we bring PrEP to people. So, you know, a lot of times it's a lot of PrEP education, right? People may not be ready to you know, a lot of times that interaction is folks' first time hearing about PrEP, because we're really in community-based settings, you know, we're not, you know. So that education piece happens there, but then we actually are involving people. They're like, actually, now that you explain it and describe it, I think I would be a great fit for me. And so, yeah, basically, so we just start folks off with a 7-day starter pack. We do the phlebotomy on the mobile unit, extensive counseling about PrEP and adherence and things like that, and people walk away with a PrEP prescription. So that's something that we're doing right now.
Thank you. And I hope the audience is also continuing to hear this theme of comprehensive care, holistic care, meeting folks where they are, right? And I want to get you on the spot, Dr. Rollins, and your thoughts on how to, as we continue to confront the challenges of providing comprehensive HIV prevention and care, especially under this current administration. One significant issue is the shrinking size of the HIV workforce, which you already alluded to that already. What strategies or recommendations do you have for expanding access to HIV services in these communities, and how can we address the workforce shortage in a way that meets those needs?
So I think we expand the workforce by stop pretending that only a handful of people do HIV prevention. A handful of people do HIV treatment, because there's some complexity, there's some nuances that go along with that. But from a prevention standpoint, there's several strategies that we have seen. Some of those have been community-based, like mobile programming. Some of the ones that I can refer to that have been incredibly successful has been pharmacy-based, as opposed to having to come into a medical facility. Everybody goes to the pharmacist. They will spend time there, shop there, in other kind of ways, providing PrEP in those kind of contexts. Student health programs have become another place. If I get one more person who tried to pretend to me that, well, the people who go to college, they don't engage in behavior that puts them at risk for HIV, I want to know, how long ago did you go to college? But the other part of this is that this is an issue that is now becoming important across every discipline in medicine. And I say this because we're doing an initiative, for example, now within the National Medical Association, in which we're talking about HIV, both treatment and prevention, not just for primary care providers or infectious disease docs, but cardiologists, urologists, those ED drugs, I remember again. I mean, so if you're gonna write a prescription for an ED drug, why is it you're not talking about PrEP? Obstetrician gynecologists, pediatricians, because pediatricians, we like to think of them as seeing only young, very, very young people. Many pediatricians see patients up into their 20s. In mental health facilities, the location is becoming less of the issue around the question of, are you getting a test in order to identify that you are negative, not positive, for whether or not it would be beneficial for you to get pre-exposure prophylaxis. The other part of that, I think, is that we have to begin to realize that the healthcare workforce issue is driven by the fact that we have made HIV care this sort of, it's not my problem. I'm gonna send you to someplace else. I don't need to address you because I don't do HIV. I have had literally physicians, nurses, administrators who say things like, well, it is HIV prevention, I don't do HIV. I'm like, good, this person doesn't have HIV. They're negative and we're trying to keep them that way. The one big concern that I have in terms of the workforce is something that this administration is doing that I think is going to be particularly detrimental. HIV is, right now, we see people living longer because we're managing to keep their virus under control for the people who are living with HIV. And in many ways, they're living long enough to have all the problems of being old. They're starting to have everything that happens as you start getting into your 50s, 60s, and 70s in terms of healthcare. But one of the problems is that if we interrupt treatment, which this administration is doing things that may indeed do that, there's a distinct possibility that the people who are currently having their virus controlled will lose that control to do what we refer to as becoming, to stop being non-detectable, which means their virus is so low that we can't find it and they don't transmit. The real concern for me is that if we do this on a scale that now we have a substantially larger number of people living with HIV in the US than we did in the 90s and the 80s, that as those people, if they lose viral control, they will be able to transmit, but there's also the high likelihood that these population may become resistant to the drugs that they're currently on. Their virus become resistant, which creates an entirely separate public health problem that we do not have the personnel, the expertise, or the manpower in order to begin to address. So this is a twofold process. We don't have enough people to do treatment now. We do not have them geographically dispersed in the way that the epidemic is. And we have the likelihood that given some of the current policy decisions that are being made, that we may interrupt the success of HIV treatment, which will exacerbate the problem of HIV prevention. And so those two things go together to me as to why this is important, why this is particularly an issue for those of you who are engaged in policy, because you don't want to be that state. You don't want to be that particular institution where you're now seeing those individuals that used to be controlled, who are suddenly uncontrolled, able to transmit, and theoretically also likely to develop viral resistance in a virus that we do not have drugs to manage this for.
Can I add something on the workforce? I'm not going to disagree with you, Keith, about the need to normalize, HIV treatment and prevention. But, and you were right that we don't have we have the Ryan White program that focuses on treatment, and we don't have the corresponding program that focuses on prevention. But there is no barrier for a HIV clinic or a Ryan White clinic to do the HIV prevention work. They just can't do it with Ryan White funding. But most of them also are community health centers. But I feel that the Ryan White clinics are the perfect place to do HIV prevention work. They are geographically centered in the areas where HIV already is, and they have the expertise. They have hopefully they're a welcoming environment to the community. So they are perfect. We do need more funding so they can do that work. Also, community health centers, I think, are a perfect place to do more HIV prevention and treatment work.
And I agree with you, Carl. My argument here is that okay, I'll let the audience tell me. How many of you have ever gone to a health department to get anything done? Raise your hand. Not that you work there for your medical care. How many of you have ever gone to do that? The vast majority of the population never goes to these places. You go to your private doctor or whoever you're seeing in terms of your health care. What I'm advocating for is that, yes, Ryan White is great for those people who need the treatment. I was a Ryan White provider since its inception. But what we need to do now is to get to the population that is never going to go there. They're not that they don't have access to healthcare, it's the healthcare they have access to isn't talking about this as an issue. And if you take away the stigma of I'm accusing you of something, or I'm saying something about you, or I'm attempting to make some social or other kind of demonstrative statement about if I ask you for an HIV test, the easier way to me is to simply say, you live here. The only reason I'm testing everybody who's in my practice in this geography because of this data. And since this is no longer requiring the expertise of all the things that we've known about HIV treatment, stop pretending from a healthcare provider standpoint that you identifying somebody who needs prevention is as complicated as somebody who needs treatment, which is the reason why people don't go to Ryan White clinics if they're negative, because only people who go to Ryan White clinics are HIV positive. Even if you're at FQHC, sometimes that skews how that gets approached. So this is to deal with the policy aspect of this, to say, if you can get healthcare providers across the board. So in the NMA, we're trying to get oncologists, OBGYNs, cardiologists, respiratory, GI, to just simply say, if I take care of you, I want to make sure, and I live in this particular area, I magnify and dramatically increase the workforce of who can identify the population who is negative, who lives here, and is then talking about prevention.
I think I just want to add that we are transitioning, I think, our service model from PrEP as a secondary option to if you test HIV negative, like PrEP is for you. PrEP is for you right now.
Yes.
I think routine testing, of course, is important, but I think that where we are with medication, it's almost ridiculous that every 3 to 6 months you're hoping for the best, or we expect people to come in and just, okay, you're negative today, great, we'll see you in 3 to 6 months, and we're going to hope that you're negative next time. That's craziness. So I think we're just transitioning into, okay, your HIV negative day, how can we get you onto PrEP as quickly as possible so that we keep you HIV negative, to your point earlier.
Absolutely, and I think
I want to actually come back to you, Carl, and we've tooted around this uncertainty, especially in the policy space, the funding uncertainties, et cetera, but the ACA coverage requirement of preventive services that you mentioned earlier, including PrEP, it's under attack. And we have to recognize that, and that's certainly being highlighted, as heard recently by the US Supreme Court. And can you tell us how these oral arguments have gone or is about to go, and what are the next steps expected? Paint the policy picture for us.
Yeah, so I'm pretty good at policy. I'm not a lawyer though, and but I'll do my best. So some religious conservative groups out of Texas challenged the ACA yet again. And this time they went after the coverage of preventive services with an eye on PrEP, and saying it promotes homosexual activity, promotes sex out of marriage, etc. So it's gone up to the Supreme Court, and the arguments were last week, and the mention of preventive services hardly came up. And only HIV came up once. One justice said, gave an example of providing AIDS drugs to people. But it really centered on the constitutionality, which is what the Supreme Court does focus on, of the appointments clause, of the power of the U.S. Preventive Service Task Force, and the body that makes these independent decisions and looking at the science of preventive services, and their power over to require insurers to cover them. And so it has to do with the appointments clause. And fortunately, the last administration sided with the constitutionality and said that of the coverage requirements. Surprisingly, pleasantly surprised, the Trump administration continued to side and protect the coverage of the ACA preventive services. We thought, given that it's the ACA, that they would not side with us. But they did, and they argued the case, and they said the Secretary does have power over the appointment of who's on the U.S. Preventive Service Task Force. The Secretary does have power to whether to accept them or not, and to make sure that insurers cover them or not. And so the oral arguments were not this past Friday, the Friday before, last Monday, a week ago, wow. And they seemed, I guess, to go pretty well, people thought. And that there were, as I said, the debate was not over coverage of preventive services. It was about the appointments clause and the constitutionality. So people thought it went well, and then on Friday there was a request of both parties to provide additional briefs on what by law is there a requirement that the Secretary can appoint the members of the U.S. Preventive Service Task Force, was the question. And so that kind of maybe murky up some things. It may bring the case back to the lower court, we don't know. But those briefs are due May 5th, and we expect a decision in June on this issue. So cross your fingers, and it may be remanded back to a lower court. But so far, even though this has gone through different rulings in different courts, it's still the law of the land. Insurers have to provide no-cost preventive services today and until we hear otherwise.
That's great to hear, and I'm sure we will be keeping up with all those things in the next couple of weeks. But just want to flag for the audience, we're close to transitioning to the Q&A portion, so please start thinking about those questions that you have for our wonderful panelists. And my last question is going to go out to all of you all. And as we look at advancing policy-driven solutions, what specific policy innovations do you believe are most critical to overcoming some of these barriers that we've talked today? And how can we ensure that these policies are implemented equitably across the different communities? And why don't we start with Christian?
Well, first, funding, of course, right? We need to keep our doors open. We need to keep being able to do outreach, to do testing, to bring PrEP to community and to do education. I mean, we can't do that if we don't have any funding. I'm sorry, can you repeat the first part of your question?
Yeah, so just like specific policy changes or innovations that you are seeing from your research hat and community engagement hat in order to overcome some of the barriers that we talked today.
Yeah, I also think about how some of those barriers are so intersectional. People are dealing with so many different things, so we'll need intersectional solutions as well. So I think about like my interactions with people who use injection drugs or people who are unhoused. When we explain what PrEP is, they're like, I think this is a great opportunity for me. I would love to do this, but I don't have a phone. So how am I going to know when my next appointment is? Or I'm not stably housed, so I don't know where I will be. I don't know if it'll be convenient for me to attend those medical visits and things like that. So I think the medication is not enough. I think you have to have policy solutions that address really people's unmet needs, right? Because if you're competing for needs, housing, food, daycare, you know, whatever, you know, it's just gonna fall down people's priority list. So we're gonna have to address all of those needs. Thank you.
Dr. Rollins?
So I would say three things to that. One, I would highly recommend that there be some changes at the state level about the availability of PrEP specifically within the context of pharmacies. That's a licensure issue, not a regulatory issue at the state level. The second one would be the ability to discern when you are trying to pick your insurance plan, whether or not this is something that the insurance company actually provides, which is obscure in many cases or not even stated at all, as a way that you, from a policy standpoint, can do this. And from an institutional standpoint, I learned a long time ago that if you want anything done, you should measure it. To know that you're actually accomplishing it. So whether or not this is in the context of Joint Commission or anything else that is doing the evaluatory component of institutions who provide health care, whether that's federally qualified health centers, hospitals, or other entities, that become a form of a measured and critical marker that becomes part of that particular evaluatory process. Those three things on a policy level, I would suggest would probably double, at the very least, the accessibility of PrEP in most institutions. Because if the provider knows that this is something they're going to be measured on, they'll do it. If the pharmacy is able to provide it, they can provide it. And if you are doing this in the context of being able to measure this, this is also going to be significantly important. I guess the last thing for me is my other big concern is we are breaking the infrastructure to measure how successful we are. The surveillance, the evaluation of what we're doing is being destroyed at both the federal and at the state and local level. So that even if we put all these things in place, we may be in a position where we can't tell if we're getting better, and we can just continue to have this argument in a vacuum.
I have a long list,
right.
but I'm going to agree with Christian. Funding is very, very important, and right now, you know, programs are being cut, and one of the and staff is being let go, and one of the real dangerous things is anything focused on DEI is, you know, cut. And so, and I think, Christian, you could attest to this, that us helping us, that they've been impacted. But anything, you know, that focuses on Black gay men who need PrEP, or any, you know, and of course, anything connected to trans community is gone. And so, you know, how are we going to focus on disparities in healthcare, and specifically in HIV, if you don't focus on the communities that are most impacted? Right. So we've got to win that fight. We also have to focus on the uninsured. And, you know, it's one thing to have payers for PrEP, but what about all those people who don't have insurance? And that's where we need the government to step in as well. And then, you know, on the people that do have insurance, to make sure that the U.S. Preventive Service Task Force recommendations, you know, that coverage requirement still stands, but also as we have new PrEP on the horizon, that insurers are required to cover that as well.
Absolutely. All right, so we'll officially move on to the Q&A portion. So there's 2 mics, one on each side of the room. So if you have a question, this is the time.
All right, we'll start right here to my right.
Hey folks, thank you so much for this discussion. It's been really helpful. My name is Simon. I work for the American Medical Association. I do have maybe a couple of quick context points to share with y'all before getting into it, but in general, my perception is that this current federal administration has been gutting the CDC, specifically offices for HIV prevention, and that programmatic funding is essentially dwindling. If grants haven't already received a stop order, it feels impending, right? My experience as a public health practitioner working at different health departments, jurisdictions, is that prevention really heavily relies upon this federal funding. I've specifically worked on a few CDC grants where we help these clinics keep their doors open, right? So I guess my question, and it's also informed by my experience as a consumer, is how much of the policy and advocacy agenda can pivot to focus on pharmaceutical and insurance industries, knowing that they still have a pretty sizable margin when it comes to HIV prevention drugs. You know, I think the health equity mindset that I have is that, you know, we do rely on feds a lot for funding for these programs, but how much can we push pharmaceutical companies, for example, to lower cost of HIV treatment and prevention? How much can we push insurance companies to provide more comprehensive coverage? I have pretty good health insurance, and in order to get injectable PrEP, I still get...
Just speak loud.
I still have a balance of $800 after insurance kicks in. So I guess my question is, how much leeway do we have to pressure pharma and insurance companies to fill the gap? To fill that gap.
So I'll take a shot at that one. I think that there are two sides to that equation. One is for the treatment side. That is mostly, I think, where your discussion is about where pharma comes into this conversation. As far as I'm aware, there are very few programs that actually pay for preventative drugs in the HIV space. That's not if anything, that's actually pharma sort of producing that. The fact that first of all, there are only 3 drugs currently approved in the world for HIV prevention. One of them is generic. The other 2 are still in a branded context, and they will likely, the other oral medication will go generic relatively soon, and then there's a long-acting injectable, and there's another long-acting injectable that's coming forward. That process is a different question around how do you deal with the issues of treatment, because that's a different scenario. The bigger one is, I think, in many ways, it's not to let pharma off the hook, but the bigger place is the insurance industry, of what they will cover as opposed to what they are willing to pay for in this context. Another portion of that may become a point in the not too distant future is that what used to be a program to help offset the cost of drugs that were very expensive, the federal 340B program has also now morphed into this thing that now stops focusing on just individuals who have reduced access and limited means into a way by which hospitals and other payers are able to charge more on the premise that if you have one entity that does this, that takes care of poor people, we'll apply it to everybody else. That's a different argument that we can talk about separately, but the ability to get it covered is still predicated on the idea that you first have to get tested. So you get none of these drugs if you don't have a test that justifies whether or not you should get treatment or prevention. So I think we should, pharma wants to know both of those questions now. It used to be they only cared if you were positive. Now they also care if you were negative. And I think that that's a different conversation about what you're describing.
So if you're being charged $800 for your long-acting PrEP, we need to talk, okay? Yeah. I'll help you. You shouldn't be.
Great, and we have 3 questions, so I want us to get them to all, so let's keep the question and the answer short, but go ahead, sir, here.
I'll be as brief as possible. Dr. Ray Serrano, Research and Policy Director with the League of United Latin American Citizens. We're the largest and oldest Latino civil rights organization, second only to NAACP. My question is, I guess on the issue, I heard a lot of discussion, and Latinos, we make up 19% of the population, but we make up 33% of the new infections. And I always think we couldn't have, the finding that we saw last year, the report of 33% new infections, couldn't have come at a worse time. Because we have this administration coming in, and I say the biggest victim in this 4 years is Latino trust in the system. When you talk about DHS collaborating with IRS on ITIN numbers, when you talk about raids in schools, raids in churches, canceling Cinco de Mayo festivals, canceling Easter celebrations because people are in fear of immigration, it just seems very frustrating, very dismal, and for a population that so badly needs it. That, given the fact that Latinos, we are 40 to 45% of the uninsured population in the U.S. When we have health fairs around the country, we have sometimes 8,000 to 10,000 people coming to our health fairs because they have nowhere else to get screened. We offer free haircuts for the kids and tell them to bring their aunts and uncles and everybody else, and we get them screened for diabetes or whatever, but that's the only time that they have access to a healthcare system. And I guess my question is, we know the federal government is just cutting programs, gutting the CDC. What else can we look at? I mean, we could say states, look at the states, but like Florida, I mean, what are they gonna do? What other non-federal, non-state, or at least non-red state actors can we look at to combat this rising tide for this very vulnerable population?
Well, I agree, and I feel yeah. It is a bad, time right now, and people are hurting, and they're going to continue to hurt. But we have to fight. We have to fight back. We have to speak up. But in the meantime, that's where you rely on other payers. People who have insurance. So whether it's Medicaid, Medicare, private insurance. But there's also, programs for the uninsured as well in this country, utilizing community health centers, and also the 340B program as well, that clinics can use that money and should be using that money to help the people who are uninsured.
Hello, I'm Valerie Rochester, and I'm the incoming Executive Director of the Women's Collective based here in Washington, D.C. I start on Monday, and I'm scared. I'm scared.
Yes.
The funding situation is something that is, of course, a concern for so many, especially as we thought that ending the HIV epidemic initiative was going to be protected because it was one of the previous Trump administration's priorities. And now we're seeing everything being gutted as we continue along this process. But I was wondering, I haven't heard any discussion about status neutral, and I'm just wondering if that is a viable strategy for some of the things that we've been talking about, that whole person approach and making sure that we address everything that's surrounding a person in their communities and making sure that they receive what they need. As far as adopting that as a standard of care for people living with HIV and actually for anyone really, is that a viable strategy as far as helping to address some of these things that we've been talking about or we've been hearing you talk about today?
Yeah, I can speak to that a bit. We're definitely incorporating status neutral in our approach to care. I think going back to everyone needs to take an HIV test. So if you test negative, we're trying to link you into PrEP care, and if you test positive, we're trying to immediately link you into antiretroviral therapy. I think it's critical. I think that the idea that only people who are living with HIV, need HIV services is outdated. So I think status neutral is critical to the fight against it, absolutely.
The one thing I would add to that is it is a misnomer, and it's actually flat out wrong, that the majority of the people living with HIV in the United States are poor. That's not true. It's never been true. Also, it's a misnomer to believe that it's mostly poor people who are getting PrEP. That's not true either. It also is the fact that even though Black and Hispanic individuals make up 70% of the new infections. Whites make up 25% of the new infections. The white population gets 70% of the PrEP care. This isn't about poverty. This isn't about lack of resources. This is also about who goes in and feels comfortable being able to have a conversation with their healthcare provider to actually get services. And I will argue that the group that is going to be the most impactful, I believe, around getting people into HIV care, in particularly the communities that we're talking about, are going to be those of us who are insured, because if we start asking the question about why aren't you doing, they will provide the services. The other one is that this is going to become, unfortunately, like a lot of things in the Black and brown community, this is going to fall mainly on women. Black women and brown women make up the preponderance of new infections amongst women in the United States, many of whom are insured. And what I've said in many cases, if you took all the insured women and start asking the question of why aren't you doing HIV testing in your practice, there's not a single provider in the country that is not going to start to wonder why they're not doing it, because if you leave and go someplace else, that's an economic hit to them. So I think that sometimes we get lost in the idea that this is only about people who don't have resources. It's about the behavior of those of us who do have resources and do have access to change the behavior of the systems in which we consume. If we can shut down Target because you don't like how much somebody's paying for whatever, you can sure as hell make an insurance company and or a provider pool decide about who they test if you stop this, if you say, I won't keep going to you.
Well, I definitely heard trust Black and brown women, but we're tired too. But the fight keeps on, and I have been giving the thumb, so we have to end the session. I'm so sorry for the remaining questions. Myself and the other panelists were here for the remainder of the day as well. As you see us, please come talk to us, and thank you all for your attention to this critical topic.
Thank you.
Thank you.
Thank you so much.
Lord have mercy. No,
Just
I think
look-
I might
just
need
look
to
into the
change
lights.
seats.
Should have bought my sunglasses.
I know, right?
Okay. Hello, everyone. My name is Derek Forney. I'm a research epidemiologist with Nmqf, and I will be serving as the moderator for today's session entitled Unlocking the Transformative Potential of Innovative Medicine and Expanding Access at the Community Level and Overcoming Barriers. So my esteemed panel here will introduce themselves. We'll start to my right here.
Sure. Hi, everyone. My name is Savine DaCosta, and I'm the Clinical Trial Diversity Site Lead at Biogen.
Good afternoon. My name is Angela Moore. I lead cell therapy sales and marketing for Bristol Myers Squibb.
Good afternoon. I'm Dr. Jeanne Epps. I'm the Senior Director of Reproductive Justice Initiatives for the Black Women's Health Imperative.
Good afternoon. I'm Brian Daly. I'm with the National Community Outreach Division of the Leukemia and Lymphoma Society.
All right, so we'll get right into it. So, Savine, talk to us about the importance of clinical trials and why clinical research is important.
Sure. Thank you for that question. After the panel that we just had, I just wanted to stress the fact that, we're dealing with some very complex and some highly controversial issues, and NMQF is doing an amazing job of bringing those issues to light. But to add one more chapter to the book that we're writing here at NMQF, clinical research becomes one more important factor that we have to talk about. And the reason is because it's actually the beginning of a lot of what we do. And without clinical research and without clinical trials, none of the drugs that we have would be possible. And to just bring it into fruition, how many people in here take any type of medication? Can you just raise your hand? Awesome. An aspirin, a Tylenol, all of those things would not be possible had it not begun with a clinical trial. And clinical trials would not be possible without patients. And all of us are patients. And we need to continue that guise and participate in clinical research. And the other thing is, when we think about clinical research, a lot of people want to say, I don't want to be a guinea pig. I don't want to participate. But the fact of the matter is, most of the drugs that we see on the market do not have us represented in it. We are the community. And most of the time when we ask the question, or at least when I'm asked the question, am I represented? I have to answer that in truth and say no. And the reason being is because we're not. But what we are trying to do now is we're deliberately, purposely trying to structure the trials in a way that when we look at the epidemiology of the study, say who is affected by these diseases and how can we get them represented in the trials. And in order to be able to come back and look at our communities and say, yes, you're represented, we have to build out the strategies to do that. And then we have to come to you and say, will you participate? And then we have to look at ourselves as a community and ask that question and say, will we participate? And answer yes in some way, shape, form, or fashion. And I just have a little story for you. My son was born at 1.5 pounds. He was a micropreemie. But guess what? He did his first trial at 2 pounds. I signed off on that because you know what? Someone did a trial before him to test medications so that he could be alive. And he's now 23 years old. And so the medicines that someone else tested enabled that to happen. And in order for us, we're talking a lot here today about what's wrong with the system, but unless we strategically plan for our future, in 2050, like Dr. Puckrin talked about, we're gonna be right back on this stage talking about what's wrong. So clinical research is a way for us to strategically plan for tomorrow and the drugs that we're gonna need. Because if not, we're not gonna have those drugs. We're gonna have no PrEP. We're gonna have no antibiotics. We're not gonna have vaccines. And we're not gonna have representation.
So that's why clinical research matter, clinical trials matter, we matter, and we have an opportunity today that we didn't have yesterday to be represented in those trials.
Oh, that's really good. That's really good. It's really good to see clinical research and innovative medicines in action. So, Angela, can you explain to us what CAR T-cell therapy is and kind of discuss the importance of expanding access to that therapy within our communities?
Sure. So CAR T-cell therapy is used to treat cancers. So I'll start with blood cancer as an example. All of our bodies naturally are able to fight cancer when our immune systems are working properly. But there are times when we have mutations and the system doesn't work properly. And the CAR T cell stands for chimeric antigen receptor T cell. So essentially what we do is we take the patient's cells out of their body, we put this protein on the cell, we put those same cells back into our body and activate the body's natural ability to fight cancer. So we are enhancing and personalizing medicine to each individual patient, and we do this so that patients can experience something that is not a chemotherapy. And that leads me to your second point. What we know now is only 2 in 10 patients, using a blood cancer called lymphoma as an example, only 2 in 10 patients are receiving this. And we know that the patients who are receiving this cutting-edge cellular therapy that it actually has curative potential are typically white, male, affluent, and typically in urban areas. Now, part of that is because where you can receive an innovative and cutting-edge cellular therapy is in an academic treatment center, oftentimes big cities, oftentimes not so easy to get to. And so when we talk about expanding to the local community, we believe that everyone should have access to something that could potentially cure them. Doesn't matter if they're in a rural area, it doesn't matter if they are affluent or not affluent, it doesn't matter what type of insurance they have, but we believe that they should have access to that treatment because no one should go without having a chance for a cure, particularly when we know that these medicines work for patients.
That's great. So it's good to see that a lot of these companies are focused on getting these treatments into the communities. Well, how does Biogen address the lack of representation in clinical trials, and what does it look like in these underrepresented communities?
Sure. When we think about representation in clinical trials, in the past, like I stated before, you didn't see it. Specifically, I'll talk about our lupus area. What we've been doing is, one of the things that you have to do is you have to build trust. But in order to build trust, you have to speak truths. So what we've been doing is we start very early, and we work in the community, and I think we talked about this in one of the earlier panels, is we build awareness in the community. And we build that by talking about the disease that we're working in, and we also talk about what clinical research is and what it's not, what it can and what it cannot do. So once you're doing that, the first time a person hears about a trial shouldn't be when you're asking them to participate. The first time they hear about a trial is when they're learning about what it is. And so we've been doing that work in the community. We actually work with the National Minority Quality Forum. We have a clinical trial learning community. We work with the barbers, we work with the hairstylists, we work with the churches, and we go in and we work with the community leaders and ask them, what is it that they need? What is it that they would like to hear? So it's a lot of listening, it's a lot of understanding, and then it's a lot of talking about what is this thing we call science, and how is it developing? What is it about clinical research? Again, am I a guinea pig? Like, what does that mean? And what is innovative medicine? And how do I become a part of it or not? And how does this impact my family? And that is the long game. And sometimes it takes a year for people to understand and hear it multiple times, and sometimes it takes 2 or 3 years. But it is a commitment. And then as we go along that journey with them, it's multi-channel. So we have the seminars, we have webinars. I actually have developed a webinar series for our lupus patients where they can actually tell their stories. We've been doing these webinars since 2022. We've done 24 of them, and we actually have over 570,000 views because it's become a safe space where patients can share their stories and interact with each other. And we just go out and we show our face in the communities so they see that pharma's not always the big bad person, but we're willing to work in community because that is what they ask of us. And then we actually, work to look at the epidemiology of lupus. There are over 5 million lupus patients in the world, and 1.5 million in the US. 90% of those patients are women. It disproportionately affects Black African American women and Hispanic Latin women. So we interact with those communities and we try and set goals for our studies so that they recruit in that way. So that when the medicine does hit the streets, if it does get approved, we know it works in the appropriate patient populations. And then we can look you in your face and say, yes, we included you in our trials and we know it works in you. And that's a powerful statement for our doctors to be able to say that. So that is the journey that we're on. That is what has been asked of us by our patients, by our people, by my community. And I am committed in this role at Biogen, and it is the only role that Biogen has as such that I can work from study startup all the way to the end of this study to make sure that I am pushing in every aspect of the company, as well as being out in the community to deliver on this promise that we've made and the commitment that we've made to the communities that we work with.
Awesome, awesome.
Derek, can I just jump in
Sure.
on that one? I wanted to just underscore the criticality of the work that you do early on because we're almost like partners. She does the clinical trial part, and one of the barriers that we're seeing to cellular therapy, and even more so we're studying also in lupus, is that some of that early work that you're doing now to build trust and help people understand the disease and the possible treatments in the clinical setting didn't happen with some of the cellular therapy that we see now in the cancer setting, and we're playing catch up a little bit. So it's so imperative that your work continues across the industry, because if you don't do this part, we're here standing with these amazing treatments that don't make it to everybody. So
the other part is the work that we're doing is not just Biogen's work.
Yes, it's for the whole.
It's for the whole community. It's for the whole disease. And that's the important part about it, because although we are committed and we do commit the funds to it, it's for people. And that's the beautiful part about this. If we are going to do this, we have to do it for people and for patients. It can't just be about my company and my company's profit margin. It has to be for the right reasons in order for it to be sustainable and scalable.
Very good, very good. So we talked about the importance of clinical trials and even some personal testimonies of their success. But I'm interested in talking about some of the barriers to access. So Brian, I'd like to start with you. What are some of the barriers preventing patients in Black and African American communities in the United States from gaining access from innovative medicines and clinical trials? And what are some of the solutions to those problems?
So I'm going to go through about 5 barriers which I've observed. And having been diagnosed with multiple myeloma back in 2018, I had the opportunity to be presented with a clinical trial. And I chose not to, for no other reason than I wanted to start with the first line of treatment, a standard line of treatment, and see how that went. However, number one, there's a historical mistrust in the medical system as a result of some very highlighted incidents, the Tuskegee syphilis study, as well as Henrietta Lacks, just to name 2 examples. And these are very deep-seated, deep-rooted traumatic events that have generational trauma attached to it. And so for that reason, many people who have the opportunity to be presented with a clinical trial choose not to. And the impact is this mistrust leads to hesitancy or outright refusal to participate. And the consequence is they get less effective treatment as a result. One of the solutions to that is community engagement and trust building, which is a model which a lot of farmers and other organizations have adopted to build alliances within the community, sort of meeting the community members where they are. and really building on trust that's already been established based on the reputation of partners. The other thing is education and awareness campaigns, where organizations develop educational materials such as LLS, and we talk about the value of safety and clinical trials tailored to Black and African American communities. The second thing I would say is a lack of representation in clinical trials itself. And the issue is that Black patients are significantly, as we know, underrepresented in clinical trials, often due to poor outreach and exclusionary trial design models. As a result, less data on how treatments affect this population, leading to treatments that may be less effective again. And also, another solution would be inclusive trial design and recruitment, where diversity goals are required in clinical trial recruitment, and design studies that reduce participation burdens are implemented. Third thing is socioeconomic barriers. So when you think about the cost of transportation to and from a treatment center, that's a cost burden that's taken on by the patient itself. Job inflexibility is another thing. If you're a hourly wage earner, chances are you're not going to have paid leave. So you're sacrificing income for healthcare. Policy and regulatory reforms. FDA and NIH can mandate diversity requirements, reporting for trials to reflect the demographics in the general population. And also, Medicaid can be expanded to include trial participation. That will likely not happen under this administration, but that's a thought. Number 4, provider bias and communication gaps. Implicit bias or lack of cultural competency among healthcare providers can lead to less information shared by that population. And the result is patients are less likely to be referred for trials or informed of new, innovative, or novel treatments. So the solution for that is to implement culturally competent care. Train healthcare providers on implicit bias and culturally respectful communication, and also encourage shared decision-making models to empower patients. And number 5, geographic disparities. Again, most of the major healthcare systems, including the NCI-designated cancer centers, are located in urban areas, and typically in more affluent areas. And so having to travel to and from those locations is a burden. Consequences that patients may not be aware of or have physical access to these facilities. Solution to that is to leverage technology. Digital access and telehealth is a game changer. You know, we've seen how that's evolved just over the past few years, and even Amazon has gotten into the game. So everyone has a mobile phone. Download the app. We can at least do some telehealth where people are. So,
May I?
Go ahead.
I just wanted to add something to what you were saying. Depending on the type of trial you're in, will depend on the strategy of what's included in the trial. So some of the things that you added as barriers are travel. You can also add elder care, pet care, child care to those things. I just want you to keep a few things in mind. A lot of the trials now have those things in them to help. Also, if there's something that you need for you to participate in the trial, speak up. They very well may be able to be added for you to participate in this study. You don't know unless you ask, you know that old adage?
Mm-hmm.
We don't know if we can give it to you unless you ask us for it. It doesn't hurt to ask. So sometimes, depending on the study, people travel across the state just to participate. So that's travel allowance. You know, so there are different components on how these studies are being built and what's allowed and what's not allowed. So we work with our study sites very closely with what they're allowed to do, but sometimes there are exceptions to every rule. So we always say, ask. And a lot of times people are unaware of what they can be a part of. So I always tell people from the gate, explore your opportunities. The last thing I'll say to that is, so often we from the gate say no because we're afraid. You know, and we often will not participate in a study unless we are just about dead. Now is an opportunity for us to open up that treatment paradigm. We hear Medicaid, Medicare may be going away. This is a great opportunity to look at clinical trials as a part of your treatment paradigm, as opposed to being sick, silent, and dying, and then all of a sudden hearing about a clinical trial as a way to maybe save our lives. Do it earlier in your treatment. It may be a great opportunity to get treatment sooner rather than later. You know, these are all different things that we have an opportunity to explore that we never thought of before. So where barriers can turn into opportunities, speak up.
Very good, very good. Thinking about areas of clinical trials that we, haven't really thought of before, I'm interested in how that can impact in maternity health. So, Dr. Epps, I was wondering, how does the reproductive justice framework specifically address the barriers that Black women face in accessing innovative healthcare treatments and clinical trials?
Yes. How many of you in this room have heard of the reproductive justice framework? Okay, great. I get to start at a good base. So the reproductive justice framework offers a critical lens for understanding the barriers that Black women and women of color face when they're trying to access care. And so the framework originated from reproductive health care, but we know that that could be applied to healthcare overall, right? Because the reproductive justice framework looks at those systemic barriers that limit your availability to access the treatments that you need, and also to have your lived experiences centered in navigating those systems. And so when we look at the reproductive justice framework and compare it to clinical research, we see that access to innovative treatments is not just about availability, it's also about ensuring that Black women and women of color are represented in the research, but not just at the end, right? So across the entire continuum. And I think at the Black Women's Health Imperative and just through my work using the reproductive justice framework, we see innovation as not just a scientific advancement, because that's important, but it also begs the question of equity, access, and autonomy. The reproductive justice framework is fundamentally about ensuring everyone has access to the resources that they need to make informed decisions about their health, their bodies, as well as their futures. And so when we look at that, too often Black women, girls, and also gender expansive people are often left out of that conversation, right? Because those systematic barriers are what impede their ability to make those informed choices about their health and how they access treatment, how they're involved. And the reproductive justice framework in this context allows us to look at clinical trials and clinical research from the lens of power, right? Who has the power in this, right? So it pushes us to ask, who has the power to access to those innovations? Who is centered in the research, right? Who's involved? Who's at the beginning of it all the way to the end? And who benefits? So closing those gaps isn't just about improving critical trial diversity. It's also about transforming trust, power, and opportunity at the community level. And so that's how I kind of use the reproductive justice framework to frame what we see now in clinical research and like what folks are looking for. Like, how is this addressing the systemic barriers? If I access these innovative treatments and I access this care, what else in my life is going to change, right? Are those things, are the systems around me going to change from my participation in this? And I think that's the question that a lot of people are asking, in which I, offer to the panel with that.
Good, good. So I kind of want to backtrack just a little bit and talk to you, Angela. You briefly talked about some various challenges and barriers to the CAR-T cell therapy in local communities. I wonder if you can go dive a little deeper into that, and how is your organization collaborating with stakeholders and to expedite the integration into our communities?
Great, thank you. I think the barriers were very beautifully highlighted by Brian. Many of the things related to awareness and education around the treatment, location of the treatments, particularly cancer treatments, provider biases around which patients would be able to endure a cutting-edge treatment like cellular therapy. So across the board, I think the barriers are pretty consistent, and what we're doing at Bristol Myers Squibb, although our work is just beginning and we do need the support of the community, is in a few key areas. First, in the area of financial burden, just like in the clinical trial setting, once the patient comes into what we call the commercial setting, we do offer travel and lodging and meals, and it's the same scenario. Some of these things you have to ask for due to the way these items are regulated. Now we do have, and I'm looking at a colleague in the audience, folks helping us work with advocacy and policymakers to make it such that we don't have to be asked the question. But right now, we offer the services we need you to ask. Is there a hotel voucher? Is there a food voucher? Is there a transportation voucher? One area that we're working with communities on is you need a caregiver or a care partner for receiving your treatment. So in certain parts of the country, we are partnering with institutions that reach out to the church and have church members take patients to and from the facilities. That's one. Another area that we work in is education of physicians in two areas. The physicians that are based in the local communities, so even if they can't give the CAR T cell therapy at their location, educate them about the fact that it exists, and if a patient presents with certain characteristics, please consider sending that patient to another, UAB, for example, in Alabama, that maybe is 3 hours north, but would be eligible. And we educate the physicians that are in the treatment centers getting at issues of biases and perceptions to make them think much more broadly about who should have access to this curative potential. It is not just the white male who can take off time from work and who has perhaps a care partner that can stay off of work. We have programs and resources available. Please offer it broadly. The third big area is educating patients directly. So we are actively engaged with partners such as Balm and Gilead, International Myeloma Foundation, and other community local partners on educating about both the disease as well as the treatments that are available. And then of course we educate with our own mechanisms, but back to the trust issue, not everybody wants to hear from Biogen or Bristol Myers Squibb, so we make sure that people have access to the patient information regardless of where they might seek to find information.
Good. Thank you for that. So building on this area of building that trust, Dr. Epps, in your experience, what are some of the most effective strategies for building trust and engaging equitable representation of Black women in clinical trials and in some of these emerging treatments?
Well, I think most of it has been said, right? Addressing those systemic things, so making sure people have access to transportation, childcare, all the things for them to actively participate. I think the other piece is the co-creation process of research, which Black women of color seem to always find their way at certain segments of it, but not across the process. And so I'll talk from the outputs of it, right? So when we think about clinical research and when it's done and we see the outputs into the community, that's really where people actually see what has happened, right? And so when we're out here in the community, we're talking about the great work, they want to say, well, how does this inform my life? I want to give an example about coalition spaces. I think coalition spaces is so important for this work, right? Because that's where people come that have the same likeness in terms of the issues that they care about and which they want to address. So this is a group of people, organizations, all like-minded that are together that are trying to find solutions. How many of you have heard of Opill, the first over-the-counter daily oral birth control pill that was approved by the FDA? Okay, right. Amazing, right? That's not as innovative, right? I mean, the ingredient has been existing for some time, but it's innovative in a way that now it's available over the counter, right? So clinical trials had to happen anyway for that to happen. Now, the work that I do, I work with young people on college campuses, and a lot of them had not heard about it, right? And so here I am with this great partnership. I think partnerships are so important for this work, but partnerships without true relationship building, trust, and community, you won't get the results that you need, and people won't feel like it's intentional. They'll feel like, oh, I'm just trying to check off, a grant deliverable. And so what we did was, before I said, okay, great, you want to work with us to make sure that Black women and women of color on college campuses have access to self-determine their lives around their reproductive health, considering the climate, right, of sexual and reproductive health. I said, well, let me talk to them first before I just come and create all of this thing for them to be engaged with. And so we did listening sessions. I think listening sessions are so important. They all have different terms, right? Community conversations, sit-ins, like all those great things, right? But always providing that space for folks to just have real honest conversations. Like, I had no clue about this. What does this mean to me? And I think starting there is so important with the listening sessions. We heard from them, like, would a partnership like this even work? Right? Is this something that you're interested in? Would you just like us to give you access to, this over-the-counter medicine, or would you like to truly be engaged? And so during the listening session, we heard from them. We said, what is it that you need from us to make sure that you can make informed decisions about your reproductive health? And what they said was, we want to know who all was in the room when this was even talked about and wanted to be available, right? Does anyone look like me that was a part of this? Does anyone look like me on the team that's doing this? The other piece is, how are my legitimate concerns around medical mistrust are being addressed through this, right? When I talk about the reproductive justice lens, I also have to think about historically what has happened to the Black body, especially the Black female body, right? How are we centering that in the conversations and our outreach and engagement through this work to make sure people have access to it? And they appreciated that because we took their real concerns, like, what are the side effects of this? Like, what does this mean? Like, are they just pushing this because it's a new drug? Like, how much does it cost? All the things which we knew would come, but we wanted to say that we still center their conversations. Then we went into the co-creation process, right? How do you want us to disseminate this information to you? What kind of information? How do you want the information to come to you so that way you can make an informed decision? It wasn't that, oh, through this partnership, we're going to provide you with this birth control. It was, okay, before we provide you with this birth control, what all do you need from us? And they trusted us in that process, and we were able to go across the country and go to different college campuses and introduce this to folks and be able to say, like, we really did talk to young Black women to access this. And so when I think about, like, what are those effective strategies, is that, right? Making sure that people are a part of the entire process, not just an afterthought. Co-creation is so important. And most of the time when people think about clinical research, they only see it after the fact, right? Like, what does it look like in my community? And when we start to have conversations about that, we need to start to bring people into this work. I know that's community-based participatory research, but it's still that process. It doesn't matter where it lands, like bringing people along. And we can't assume that everybody doesn't know, right? They may not know all the technical terms that some of us may know from, our degrees, our training, and all of that, but a lot of them do care about how that will impact their daily life. What does this mean for me? What about this is tangible for me? And when we start to center that for folks, then we can truly be effective in ensuring that folks are a part of the process from the very beginning, and we actually have the health outcomes that we need to ensure that people live longer. So, yeah.
And a big part of that co-creation is when we can't do something, explaining to people why. Because then they feel like we're just walking away. But when we explain the why behind it, and it could be regulatory, it could be financial, but when we really start to explain why and give them the reasons behind it, it seems to be more accepted in that way. And we just don't leave people hanging out there as to whatever. And part of also in clinical research, a lot of times people have not received their results from the study. So they feel like they contributed and then they don't hear back from us. So a big part of what we're doing now is being able to give people their results back from the study. And it seems like a really small thing, but it's a big thing. Or being able to say thank you. You would not believe the regulatory hoops we had to jump through just to be able to say thank you to people. And now we've worked on that, and to be able to say thank you for your part in all of this. You know, we also co-create. Our brochures were actually done with patients, caregivers, and advocates. All of our brochures, the language has their stamp of approval. And to see patients when we go out to events, some of them have participated in building these resources to say, I did that. I'm a part of that. And we make sure that when we put things out publicly, we thank them, because that's hard work that they participated in, and they deserve that, you know? So that's a part of the co-creation process as well.
Great, great. In the interest of time, I'll speed up a little bit here. So I want to give each of you a minute or two to give us like some closing thoughts, or like, what do you want your key message, key takeaway message to be for the audience today?
Want me to start?
Sure.
So for me, I didn't grow up in the clinical research space, but I'm glad I've landed here. It's not easy, but I like to say I am the community. I represent the community in the work that I do. I call myself a unicorn because I grew up in the hood, but I had an opportunity to do some things differently, but I can go back to my neighborhood and give back by creating that bridge between what we know, the generational faux pas that we know about science, and go back and teach and say, yes, we were affected by what happened, but I think we need to stand on the shoulders of giants for what we learned and what they went through, and explain the things that I've learned and what I now know. And yes, there are still barriers, of course there are, you know, but there are also opportunities. And I think because I represent community and I am community, I can go back in community and speak. And I never ask anybody to do anything but listen. I don't ask people to make decisions. I ask if they learn anything from what I show them, that they each one teach one, because we have opportunities to be innovative in this space that we are not taking. And I think we should, because we've earned that. And that's all I ask of people. And that's my message for today.
My ask of the group is to advocate for cutting-edge therapies, no matter where you sit, whether that's with your mom or your sister or your cousin and you're in the doctor's office. Ask about whether it's the clinical trial or the new latest transfer treatment. Ask and advocate if you have other positions of power and voice to ensure that patients have access to the cutting-edge treatments, to the ones that we know deliver cures for patients. Ask and advocate.
I think my closing message would be that access to innovative medicines, clinical trials, all these things should be a right. It's not a privilege. And when we center justice in our equity work, we can address those systemic barriers that impact people in their day-to-day. I think my closing message is to always think about, what does this mean for the everyday person in their daily life, and how can you uplift that wherever you are? And I also think about how can we build power for folks that are most marginalized every chance that we get, and through every process that exists for us to tackle those systemic barriers.
I would say my closing message is, if nothing else, find collaborators and partners. I think in terms of educating the community on ways to help move that needle, I've noticed it within our own organization that when you seek out trusted partners who are already embedded in the community, you have a better chance of meeting people where they are and gaining that trust. We work with organizations that have a national presence, but also have a local grassroots engagement, and that's made all the difference. We work with churches. However, if you work in a silo, that relationship may be transactional versus relational. You'll only have the opportunity to meet the congregation once or twice a year if they're having a health fair, or you can engage with a local partner and engage with them all year during a turkey giveaway or a health fair or a jazz festival at your church. It makes all the difference. So if you're doing any advocacy work, or if your organization is already partnering with other organizations, I think that's the key to moving the needle and closing the gap.
All right. I want to thank my panel here. We're going to open it up to the floor for any questions that you may have for my panel here. Yeah, okay. I can't really see.
There we go. Oh, there we are. Hi guys, great panel. Camille Campbell with Acclinate. Question about actual process of clinical trial participation and like the provision of vouchers and ways to get people, let's say, from their homes to the clinical trial site, travel and, you know, care for the children and all of those things. But sometimes even that can be burdensome because like you still got to take off work. You still have to get there. You still might live far from the actual clinical trial site. So particularly our industry partners, can you speak to maybe some of the innovative ways that you're bringing the trial process to people, maybe through decentralized methods or like mobile research units where it's coming to their home versus them even having to figure out, well, how do I use the travel voucher or resources that the company is providing me to get there?
Sure. It really is going to depend on the study and the complexity of the study on what we can and cannot do. Because decentralized trials is not going to work for every trial. For some, it's going to be a great option. For others, not so much. And it depends on the vendors we work with. So by asking some participants on what's going to work best for them, we have sometimes credit cards that we can work with. Sometimes we can reimburse upfront. You know, like we can have the vendor that we work with do the reimbursements. I don't want to get into all the details and the nitty-gritties, but it really is going to depend on the study that we're working on and the complexities of the study. And those are all very great options. And like I said, it really is going to depend. It's definitely more flexible than it used to be. It definitely is, but there are still can be some challenges in that in and of itself. So those are things that have to be worked out, sometimes on an individual basis. And that's why I always say ask, because depending on your personal situation, there can be some flexibility even in what we have.
Thank you.
Thank you.
Hello, my name is Chris Smith. I'm a scientist developing diagnostic tests and have some experience setting up trials with the help of a CRO. And one of the things we noticed is there can be some populations that are smaller and it's harder to recruit from those populations. And I was just wondering if in the pharmaceutical industry, if you run into the same problem, and do you have extra effort or money that you have to spend on the recruitment efforts? And with changes that have happened, like from the administration of the requirements that I know some were the FDA requirements that were on paper are no longer being enforced for diverse recruitment. Is that changing how you guys are doing things, or?
We are staying the course on what we're doing as it pertains to inclusion in clinical research, because that is what we committed to and that is the right thing to do. The inclusion in clinical research has nothing to do with human resource per se. It has to do with what's right and what's scientific. So as it pertains to recruitment in certain subgroups of patients, that's always going to be hard. And you have to figure out what is the strategy that you're going to use. So if it's going to be, sometimes people use advocacy groups to do that. So if it's ultra rare, then that may be the best way to go. So it really is going to depend on what that subgroup of patients that you're looking for, and go from there. But if it's really, really a rare subgroup, advocacy groups, who you know, how you network, what your recruiter's doing. But at the end of the day, it really is going to be up to the participant and the inclusion-exclusion criteria of the study.
And I could add, at least from the commercial side, outside of studies, we certainly run into the same challenges that you're describing and do have to invest extra. So as an example, in lung cancer, there are certain very small mutations of patients that we have to invest in extra testing, extra sort of exploration to figure out, do they have that particular mutation? And we've invested in what we call reflex testing for more of those specialized types so that it's a bit more automatic versus one-off to identify. And all of that, to your point, comes with additional, this side of the house, additional investment to make sure that we find those patients and or help those patients be found so that they can receive the treatments ultimately. So you're not alone in that journey there.
And also to your answer about the shifts, we are seeing that there are some situations with the NIH pulling out of certain funding, and we're just really starting to see some of the impact of that. And I'm sorry that light is shining right in my face. And starting to do some of the landscape analysis to see what the ultimate impact of that is going to be. So the NIH does do a lot of research funding, but then you have companies like ours that we do our own research, but that does have a downstream effect on the clinical trial sites that we use because they do multiple studies. Exactly. So we're just really starting to see what that impact is going to look like, and it's still early days for that.
Thank you.
Hi, this is Harsha Rajasimha. I'm the founder of Jiva Clinical Trials and also a rare dad and a patient advocate. So fantastic comments and perspectives shared. Thank you for that. Couple questions. One, where can technology and AI be part of the solution? It can also be a barrier. We have heard about the digital divide. And so which areas and which parts of the clinical trial recruitment and retention continuum where AI and technology is actually proven or making a real dent versus something to avoid, to minimize, making it a barrier. And the second question I had was around, is right thing happening by itself just because it's the right thing to do, or do we need a stick or a carrot, say a policy or a regulation for it to actually happen? And so where do you see things are already happening because that's the right thing to do, it's good science, and where actually we need a stick?
You take it. Yeah.
All of that. We've had policy, we have the DEPICT Act, we've had guidelines. This is not new. This has been happening for a really, really long time. I think you need both a stick and a carrot to move people. But at the end of the day, we know that this is the right thing to do. And as we're in this period of what do we do? How do we do it? We already started this ball rolling. Do we stop it? A lot of our companies already have infrastructure in place to move the ball. So do we stop it? We've decided, no, we're gonna keep moving, you know? And as far as AI, that's a loaded question because we're building trust and truth. And a lot of our populations that we're looking to work with, when you look at the statistics, 11% of the population still don't have internet. So asking them to understand what AI is and the implications on how we build this is kind of hard, you know? But also, from a process and operational perspective, it does have its place, but at what points do we use it? And some of us are using it in different points operationally, and then some are not. So it really does depend, again, on the study, on the team you're working with, and whether it's in the clinical trial space or in the commercial space or in their spaces, it really is going to depend. And it's going to depend on the validity of AI, because there's still a lot going on in that area and how we choose to use it and from a compliance perspective.
I'll add one place we have had some successes ties back to the ultra rare and sort of these very difficult to find populations. We have seen some small successes with using AI to at least screen reams of data to identify the patients with those particular genetic mutations. I harken back to lung cancer mutations. So there's been some successes there, but again, it's going to be a question of how accurate are they, but it's more very upstream to sort of where should we be recruiting for these ultra rare patients. And I think you need both the carrot and the stick across the spectrum.
And we have to be careful because some of our patients still have very high privacy concerns with that. And so you add AI and a lot of digital into the mix, and now you're talking about a whole nother concern.
Yeah.
I just want to say one thing about AI. I think the model's going to be only as good as the data that's put into it. And I just want to shout out to our partner, Acclinate, who's actually doing that. So just a quick endorsement.
I guess my only addition to that would be if we already have issues trusting other human beings, we're definitely going to have issues trusting the validity and of AI. And then we also have to think about, again, the biases that exist in technology, who's developing it, who's a part of the process, who's on the receiving end of it. I think those, again, are still the questions. Who has the power in it, right? Like, all those are still valid questions to ask when we think about AI technology and what we need to move us along.
And just because someone adds AI in something, it doesn't mean the same thing to everybody. So you have to question what they mean by AI.
That's true.
Thank you.
Hi, my name is George Franklin. I'm from NIH. And I appreciate everything you all are doing. And I did a lot of outreach and community engagement. And going around talking about clinical trials, the biggest problem I had was I don't trust it. I don't believe in it. You know, I have family members who thought about it, but, you know, it's always a negative, portion of it. And, but I had one young lady come up to me and said, and she started crying. She said, I thank you all for what you did. And I'm looking at her, for what? She said, y'all kept my sister alive for 10 years because of the clinical trials. And, we just have to be able to have people to believe in us that we're there to help them.
Yep.
And, I don't know what it's going to take, but I appreciate what you all are doing, and just keep doing what you're doing.
Thank you.
Thank you. We have one more question, one last question.
Yep, there's one. She's standing there. Hi.
The light.
Yeah.
Hi, everyone. Lisa Lewis, Director of Health Equity at Fast Secure at the Milken Institute. I'll echo everyone else. Kudos to you all for leading from commercial to trials to advocacy and research, especially at this time. A related question to something someone brought up earlier. In the midst of all, and I've asked this in different sessions, but I'd love to hear your insights. In the midst of all the changes that are happening, I try to use positive words. What are you all hearing, Brian particularly, Zanai, from the research and advocacy organizations that you all have leadership roles in, Angela and Savine in industry, your partners at community serving organizations, advocacy organizations? What are you hearing from people in terms of how their attitudes towards trials may be shifting, what their thoughts are? Is their trust being impacted by all the things that we know are impacting how trials and representation are approached in the current landscape?
I can go ahead and start. I think what we're hearing, obviously, is folks' lived experiences. And I know you hear lived experiences as like a buzzword, but I think it's important because people's lived experiences sometimes tend to be negative or positive. But I think folks are asking for transparency. And so sharing those lived experiences, yes, everything's not all, great, but also being transparent about that. I think that's what people appreciate. Like, what are those things that are impacting folks? And again, I'm going to keep saying this because this is what I hear. What does this mean for me when I wake up in the morning? What does this mean for me in my daily life? And I think that's so important. And that's what I'm hearing from folks. folks, even, you know, from young people on college campuses. They're thinking about like, how can I truly come into this field and have an impact where, you know, all these issues exist and my lived experience, right, is not being centered. Not everybody has a great, you know, experience with clinical trials or research. Not everybody completely understands what that means. And so I think for, at least for the Black Women's Health Imperative, we always try to uplift what those lived experiences are and just be transparent about it, right? Because everyone's experience is not the same. And while we uplift folks' lived experience, because again, you're the expert of your own life, we also say, well, that while that may be your experience, it may not be the same for others. And so as we look to support others who are navigating their healthcare journey, how can we still be in support? What are those learnings that we can get from those negative experiences to inform everybody else's experiences to ensure that they don't experience that? And so I think for us at this time, that's what we're trying to uplift, and just hearing from people. And they're really just like, what does this mean for me when I wake up in the morning? What does it mean for my daily life? And if you can't, and then also if you can't articulate that to them, right, to bring it all the way down and say this is the most basic thing that you need to know and how this impacts your life, you know, it will go in one ear out the other.
Yeah, I want to echo those thoughts. When I encounter patients, typically they tell me the first time they've ever heard of a clinical trial is after they were diagnosed. It's not something that ever comes to mind prior to that. And so they should expect a crash course and being educated on what that means, how that's going to impact their daily life. Because not only do they have to get over the trauma of knowing that they were just diagnosed with a malignancy, now they've got to learn what that means and how to prepare for it.
In the times of uncertainty, right now I'm hearing a lot of just questioning, like what you said. What does this mean? What impact is it going to have on me? Will I still be able to get my medicine? Am I going to be in this trial? Does this program that I'm on still exist? And unfortunately, we don't have all the answers in industry. At least my organization is still analyzing its position on some of this stuff. Some of this stuff is clear, some of it's not clear, and I'm just getting a lot of questions, and not just from patients, but people, right? Employees, workers, people that work in these fields, people that are out in the community advocating a lot of what does this mean, and then also when does it stop? I think that's the other, or does it stop is a lot of what I'm hearing.
We get the same thing. I always say that there's trust in truth, and sometimes in truth, it's not always positive, but it's not always negative either, and our actions speak louder than our words. And so we get the same thing. I was at a meeting and I presented some slides, and we had some of our clinical trial sites there, and when I presented some slides on inclusion, they actually got really happy because they thought we were going to drop our push forward to make sure we had inclusion in our trials because of everything that was going on. And a couple of people came up to me afterwards and said, well, we're really glad you're continuing to do this. And I'm like, me too, you know, why wouldn't we? But from the patient side of things, these webinars we do, they have an opportunity to put notes in for engagement. And they were like, oh, we're so happy to be here. We're so happy we're including the ability to share our stories. And so we have 4 more of those that we're doing as part of our series, because we do 5 in the series. So from our perspective, and my boss is here, our head of health equity is here, we have our policy person here, so we are committed to continuing the work that we're doing. We're here, we're doing the work, and we're just gonna continue as much as possible. And when asked, excuse me, that is what we say. And if we have to change course, excuse me, we'll communicate that as well. And that is the best that we can offer and have trust in truth, you know, and that's what we can offer to our community as well.
Thank you so much for your questions. Thank this amazing panel. I thank you for an amazing discussion today. I think they'll be available for some questions.
Thank our moderator.
Our moderator. Thank you very much, moderator.
I think they'll be available to have additional discussions afterwards, but I think that's going to wrap us up for today.
Thank you.
Thank you for coming.
Great.
I'll say my announcement and go to the video. All right. Hey, folks. Just have a housekeeping announcement for everybody. So, housekeeping announcement. All right. So tomorrow night's gala is a ticketed event. A lot of the organizations have tickets already for it and whatnot. But if you would like to attend the gala tomorrow evening, please sign up at the registration desk. We have a few extra seats for it. So if you do want to attend, please sign up. So that's all I had. If you want to attend, no call response, sign up. Man, a lot of commas behind names, but you know. All right, thank you, folks.
You'll get better when you're not blamed for a condition you can't control. You'll get better when your care doesn't depend on your income. You'll get better when your pain isn't minimized, dismissed, forgotten. We will never stop trying to get better. Because when medicine gets better, all of us can get better.
All right. Good afternoon, everybody.
Good afternoon.
Good afternoon.
Thank you for joining us. I really appreciate it since the weather is so nice, but you're in here, so thank you, thank you. My name is Eden Chafaro, and I'm Senior Vice President over at NVG, and today we're discussing eliminating barriers to obesity care. I have the pleasure moderating today's panel, which features leaders and experts from across the country on advocacy, medicine, and community health. As we all know, obesity is a complex chronic disease that disproportionately affects communities of color and women. Yet, despite advances in treatment, access to effective care remains limited, which we know is a reality that was just underscored by the Trump administration's recent decision not to expand Medicare coverage to include anti-obesity medications. Our panel today brings together Dr. Ray Serrano, National Director of Research and Policy over at the League of United Latin Citizens. We have Senior Director Mark Johnson with the American Diabetes Association. We have Melissa Gorham, CEO of the Alliance for Women's Health and Prevention. And we have with us Dr. Sylvia Gunson-Boley, a practicing obesity specialist doctor and researcher. Today we'll explore how cultural, clinical, social, and policy barriers intersect, and more importantly, how we can break those barriers. Thank you all again for being a part of this dialogue. Before we get started, I would love it if we could just go down and everyone can just introduce themselves a little bit. Okay.
Want me to start?
That would be great.
All right. Well, good afternoon, everyone, and welcome to my home city. Well, not my true home city. I'm from Atlanta originally, but this is where I live, so welcome to DC. My name is Dr. Sylvia Gunson-Boley. As she stated, I'm a dual board certified internal medicine, obesity medicine specialist, and I've been practicing that for over the past decade now. I particularly have an interest in culturally tailored obesity care with the biopsychosocial approach. I started a company that deals with that in this area. And then most recently, I serve as Executive Director, Clinical Research Physician at Eli Lilly and Company, where I work on phase 3 trials. So very excited about this discussion and always an honor to speak with a distinguished group of people and break those myths about obesity as a disease.
Great, thank you. Yeah, my name is Dr. Ray Serrano. I joke that I'm the residential nerd at the League of United Latin American Citizens, but my formal title is National Director of Research and Policy. I'm originally actually from Idaho, of all places. I'm the son of migrant farm workers. I was a migrant farm worker myself. My background is in public health. I got really interested in just looking at access to care, access to treatment. Ended up doing my master's in public health. After I did that, I worked for the World Health Organization. Before that, I worked with the United Nations Development Program overseas, and then I worked with the World Health Organization, and then got my doctorate in health services research and health economics. And eventually, I worked at CMS for a long time, and then eventually decided to kind of just follow my instincts in helping Latino community. So I switched over to the League of United Latin American Citizens. We are the largest and oldest Latino civil rights organization in the country. We are about 325,000 members across the country, so we are spread all over. But it's been a very interesting time, particularly on this issue of obesity and access to care for chronic disease. So I'm just happy to be here. Thank you.
Good afternoon, everyone. My name is Mark Johnson. I'm Director of Federal Government Affairs for the American Diabetes Association, and it's a pleasure to be here today. Part of my issue portfolio at ADA is food as medicine, health disparities, and also obesity policy. So again, it's a pleasure to be here today amongst esteemed colleagues, and I will pass it on to Millicent.
I am the magnificent, marvelous, magnanimous Millicent Gorham, CEO of the Alliance for Women's Health and Prevention, a policy-driven organization driven around women and girls' preventive healthcare services. I've served in this role for 2 years. I am the inaugural CEO. And prior to that, I was with the National Black Nurses Association as its executive director for 27 years. And lobbied on all your issues, from rural health to optometric to hospitals. I've lobbied on it all. So glad to be here with you all today.
Thank you so much, Melissa. As you can see, I'm just happy to be here with these amazing panelists. So, as I mentioned, the Trump administration did not move forward with the proposed rule set by the Biden administration to allow Medicare coverage of anti-obesity medications. This might not be a surprise for folks in the room, but definitely I know it is outside the room that there has been a long, just outright ban on coverage when it comes to anti-obesity medications. So to that end, I would like to kick us off by grounding this conversation in the bigger picture, which is obesity is often treated differently from other chronic diseases, both in perception and in policy. So I want to start with you, doctor. From your perspective as a provider, what are the biggest misconceptions that contribute to the barriers in obesity care? And then to that end, can you explain a little bit about what the disease is and what it isn't?
All right, well, thank you so much. Well, I think Eden has made me promise not to nerd out too much, so I will try to keep the conversation light. But I think the biggest misconception, both having experienced this disease, both as a physician and a clinician, but as a researcher, but also as a human being, is that it's a choice, right? That people have a choice, and it's a personal choice. It's a matter of willpower. They're not trying hard enough. But you know, if you've ever lived with anyone who struggles with the disease of obesity or excess weight, two people living in the same house could be eating the same food, doing the same exact things, and the other person be unable to get off that excess weight. And I think that is so important for us to remember that. And what it drives down to is that this is a complex biological disease. Yes, people may have behavior choices that contribute to it, but it's not those behavior choices alone. It is the actual biology. I like to say that we need fat. Fat is a good thing. It is a vital body organ. You know, your fat, it comforts you, it keeps you warm, it protects your vital organs, it secretes hormones, it does a lot of valuable things in your body. Now, so having fat is not a bad thing. It is when you have excess fat or dysfunctional fat, and that's when the disease of obesity actually starts. And what I would love for people to realize is that just because you can see a disease doesn't mean that people aren't trying with it. So when I think about the actual treatment of obesity, I liken it to asthma is how I actually really think about it. You know, if you had a race, if there was a race going on today, I'm a runner, I became one on my own fitness journey, but if you're at the starting line for a race and two people come up and one is wheezing, they're huffing and puffing, are you going to be like, try harder, run a little faster, you can do it, just push through that wheezing? We wouldn't do that, right? We would give them their albuterol, we would give them the necessary treatment, but unfortunately with obesity, because of the bias and the stigma that people just aren't trying hard enough, that's exactly what we say. It's like, you keep running, you keep trying harder, and we really have to stop them.
No, thank you for that. And I think it's so important that you just reiterated how it is a disease, because we're still battling that stigma that it isn't. It's something that is not a disease like asthma or cancer or Alzheimer's. And because of that, we're having policy that doesn't reflect that. I want to ask Mark, from your organization's perspective, with the American Diabetes Association and understanding chronic diseases, how are these misconceptions in relation to the work that you do, and how does it impact the organization?
Well, thank you, Eden, for that question. You know, to kind of piggyback on what the doctor said, you know, we go into the issue about personal responsibility and choice, and you know, you're not exercising enough, you're eating too many bad foods, you're lazy, all those terrible stereotypes, and it's far from the truth. This is an actual chronic disease with a complex etiology. You look into socioeconomic factors, you look into genetic factors. You know, there are personal, you know, or behavioral traits that come with it, but it is a complex disease that we need to acknowledge as a disease. And, you know, the CDC and major medical organizations, societies have recognized it as a disease. So it's still unfortunate that there's a significant amount of people out there, even some that are in the medical profession, that believe it is a disease. And so, you know, we look at the connection, you know, I'm from the American Diabetes Association, so what is the connection between diabetes and obesity? 70% of adults who are diagnosed with diabetes suffer from obesity. And so, you know, I often say that, you know, there's actually a term out there called diabesity. That's how closely related diabetes and obesity are. I think they're, you know, I say sometimes they're like peanut butter and jelly. I mean, there's 200 comorbidities that are associated with obesity, but diabetes is one that people often look at. And so, you know, ADA is here to address those type of issues. You know, if we effectively treat obesity, then we're essentially helping with diabetes and some of the other illnesses that come with it. And, you know, obesity has become such an important issue within the diabetes community that ADA recently started an association called the Obesity Association, which is specifically advocating on those causes, on those legislations or regulations dealing with obesity and its connection to diabetes. So it's important that, you know, we get rid of the stigmas, that we find those connections, that we educate people so we can stem the tide against obesity and diabetes.
Thank you. And then just to piggyback off that a little bit, I do want to go back to you, Dr. Gosamboli, about the phenomenon of when prescribing these anti-obesity medications, how oftentimes you have to wait till someone does have diabetes or other diseases before they can get coverage, even with commercial plans. Can you talk a little bit about maybe some of the experience of, you know, your patients have to get sicker before you can give them the right medicine for the disease that they have?
Yeah. So I'm speaking now as Dr. Sylvia Foley and not Eli Lilly. But yeah, so definitely there is this phenomenon of having to prove, right? And I think, again, it's rooted in this bias that it is a lifestyle choice and people have to show how much you're exercising, show, you know, that you've had a reduced calorie diet. All these things that we have now shown are not effective, right? 95% of diets fail within the first year. So, and especially for someone who actually has the disease of obesity, where it's not going to be effective if you have to lose 30% of your body weight or excess body fat to get that off. A diet or exercise plan that you may not even be able to do because of the physical limitations that are associated with carrying the excess weight can have. So definitely those can be unfair biases. The other bias we see is that because obesity is a chronic disease, like Mark said, is that it will require long-term treatment even after you hit that goal weight, so to speak, right? Because you will still, all the hormones that are getting your body to stay at that higher weight are kicked into gear. And people have probably experienced this, right? When you lose weight and then all of a sudden you hit it, you're in your beach body weight, and then you start to feel really hungry, and slowly the scale starts to climb back up. And that's because, again, your body is trying to reclaim that weight because it sees it as a helpful thing.
Yeah.
So I think that's the other thing that we need insurers to also know is that once someone hits that weight, they need to be able to maintain it. And the maintenance may require tools beyond just lifestyle interventions.
No, thank you for explaining that. And so we've been talking about the importance of having access to therapies and a continuum of care, and how, you know, we have these misconceptions that don't allow for that to happen. So to kind of dovetail into that, I want to talk a little bit about the cost of not implementing anything, as we've just seen, right? I think there's just a tremendous cost of just not doing nothing at all, in terms of societal, financial cost, of just delaying any sort of meaningful action when it comes to treating this disease. And so I want to ask this question to everybody, but I'll toss it first to the self-proclaimed resident nerd here, Dr. Serrano, and that is, what do you see as the true cost of inaction when it comes to eliminating barriers to obesity care, both for individuals, our whole healthcare system, and in Black and brown communities?
Yeah, so I think I'll take you back to something more personal for me, because I think it's easy to, in public health, you get really involved with numbers and stats and so forth. I just feel like sometimes it's better to humanize the issue. As I mentioned, I was a migrant farm worker's family, single parent mom. I tell the story of my mom because she was the hardest working person I know. She worked 2 jobs. Every morning she woke up at 4:30, like clockwork. House would smell like fried eggs, and then by 5:30 she'd be out in the fields, heading to the fields, working from 6 in the morning till 2 p.m. Come back home, shower, go to the French fry company, Idaho, to go from 3 to 11 p.m. Every day, 16-hour days, day after day after day after day. Mom, this is what life was like for her. This was like for many of people in my community. But Mom's health got worse and worse and worse. It was obesity. It started out with, first it was 250, then it was 275, then 300. And eventually by the age of, like my mom was about 59, 60 years old, she was about 525 pounds. Very, very severely obese. To that point, she could no longer work. The 16-hour days had to come to an end. And with that, I constantly use the phrase, my mom became the $1 million patient. And what I mean by that, my mom basically, the congestive heart failure, the sleep apnea, the total knee replacements, you name it, she had it all. hypertension, all of it. Every morning it was a cocktail of pills. Pills from here, pills from there, everything she could possibly take because of the chronic, but at the heart of it was weight. Again, we lived in Idaho. Not a lot of Latino doctors there, not a lot of minority doctors there. So the doctor would refer to a dietitian, Maria, you need to eat more kale. What's kale? Guess kale. Guess eso. Like, what is? She'd ask us, like, we don't know what kale is. We don't know any of this stuff. And so the differences between, like, just it was like they could have spoke German to us. We had no clue. My mom's family comes from a pretty decent, I guess genetically we're pretty good. My great grandmother died at 102. Mom's mom died at 109. Pretty long genes. Mom died at 73. And when I think of the cost of inaction, I think of that. 35 years. It made no sense. Great grandma and grandma were born in a rancho, in a village in Mexico. No running water, no electricity. So how does mom, who's born in the US, is largely raised in the US, dies 35 years less? Something changed. Something happened. And so that got me thinking a lot about what could it happen. So when Ozempic and Mounjaro and the GLP-1s came on the market, it really was a game changer. 47% of Latino adults are obese. About a third of Latino kids are obese. We're about to pass the 50% mark of obesity for our community. And what changes? They're cutting the SNAP benefits. In Maryland, neighboring Maryland, it was $6 to $8 a day for SNAP benefits. If you go down the street here, if you go to the Subway, the cheapest 6-inch sandwich you can find is $6.75. If you could use food stamps to buy it, but you can't. But you couldn't even. That would basically be your whole food allowance for the day for SNAP benefits. Now that's going to get cut back. So your access to fresh fruits and vegetables are being cut back. So you have very limited supply. So how much choice do you really have in this situation? So then you have this incident of this crazy epidemic of obesity that is super expensive. And again, so what we're seeing now at the federal level, there's cost cutting. And I always think in my public health background, I always say, you don't cut costs, you shift the costs. Someone's gonna have to eat it. Either the employer eats it, the health insurance company eats it, or it's you. And in the case of my family's case, it was mom. And it was us. We lost our mom 35 years less than I would love to have her around now. I would love to have her sit in this panel and tell her story of how she could lose weight. But she can't, because there was no access to medications, there was no access to GLP-1s at the time. And even then, the question was always like, how did you get here? It was never, even though it was a disease by the American Medical Association since 2013, it was never treated as a disease. It was treated as some kind of lifestyle choice, as if somebody really wanted to just give up their life and just live this way. So the cost of inaction for me, I always think of it like, when we think of the interventions or the non-interventions, we thought, I painfully listened to one of the secretaries that has a voice like mine, probably worse, this weekend on CBS News, and he's going through this 30-minute interview, and they ask him about GLP-1s, and he says, well, you know, we have to be, I can't imitate his voice, but we have to.
You can, it's a safe space here.
He's like, well, we have to be careful because we don't want insurance companies to be paying more. I'm like, dude, like they're going to be paying more either way. Like, again, you don't treat the obesity, you're going to be treating the sleep apnea, you're going to be treating the hypertension, you're going to be treating the other stuff. Well, we have to be careful. Well, maybe we should do, and then he said something about we should do maybe glucose monitors. Okay, great. I have a glucose monitor here, but yes, it tells me my blood sugar is high. But is that really going to encourage me to change my diet? Maybe it could. But again, that's not rooted in science. What we do know that there's certain interventions that do work. And again, when you have a population, we're not talking 10% of the population. We're talking about 47% of Latino adults. This is a huge population. 19% of the population of the U.S. Again, there is no way that we can get to an equitable, healthy society if we don't deal with chronic disease, and if we focus so much on the cost of the interventions and not the cost of the inaction of those interventions. Because somebody's going to have to eat those costs. And the reason why I tell my story is that it's very real for some of our families. I would never even dream 5 years ago to even tell this story. That's how much the stigma was even within me as a public health guy. Um, but it's very much alive, so.
Eden, could I say
Of
something?
course.
Yeah. Well, thank you so much for sharing your story. And I think it highlighted something that's really important because you asked about misconceptions at
Yeah.
the beginning. And to me, one of the greatest misconceptions is when we just talk about weight loss and not talk about health. Because what I heard from what you were saying is just how this devastated your mom's health. Like she, I'm sure, was a beautiful woman at whatever size, right? Like whether she was like this or like this, you know, she was beautiful. And I think a lot of times when we have these conversations, it shifts quickly to a cosmetic issue. But you just highlighted that there are over 200 diseases associated with obesity, and this has a devastating effect. So when we're having these conversations, it really needs to be rooted in the health impact on it and not anything cosmetic.
Yeah. Eden, I would say, you know, I've been in meetings actually with Ray where we've talked about coverage of GLP-1s and behavioral and dietary treatments. And, you know, generally, policymakers agree with what, you know, what these medications are doing. It always comes to cost. And what I've said in meetings is, you'll pay a lot now. You'll pay a whole lot more down the road. It's almost if you have a car and the light comes on saying you need a repair and you just kind of ignore it because, hey, it may cost $300, you don't have it. But then if you keep going with that, you know, engine, you know, light on, next thing you know, you take it to the shop finally, it's gonna be $900. So, you know, better to take care of it now than when it gets worse and worse, when all those diseases progress and all those comorbidities progress later on.
No, thank you for that, Mark, and thank you, Dr. Serrano, for saying that story. I know I joked that you're a public health nerd, but I think humanizing that is something that we all in this room know all too well. And I think it's important that we talk about our stories in order to just break through this misconception that obesity, you know, is a disease and should be treated as such. With that, I want to dovetail a little bit into, you know, entities that care about the cost, which is insurers. With that, I want to talk to you, Millicent, given the communities that you serve and your focus on women's health. How does limited insurance and lack of Medicare coverage for obesity treatments impact the work that you do and the communities that you serve?
Thank you so much, Eden, for that. But I'm going to segue over to Dr. Ray. Okay? And the reason why I want to segue over to Dr. Ray is because the Alliance for Women's Health and Prevention is about women. And his beautiful mom suffered through something that she did not have to suffer through. Listen, let's put it all right down where the rubber meets the road. Obesity is a chronic disease. Let's get over that. Let's accept that fact. Obesity impacts women more than it does men. 1/3 of adult women in this country are living with obesity. 57% of African American women and 44% of Latino women are living with obesity. So when you look at it from that standpoint, obesity is clearly a woman's health issue. So let's go a little bit deeper. So when you talk about the kinds of things that Dr. Ray's mother went through, there are other issues relating to specifically women's health that we need to acknowledge and recognize. Obesity has a direct impact on, you mentioned, Mark, 200 conditions. So what are some of those conditions? Fertility, breast cancer, ovarian cancer. Those are some of those issues. Mental health, depression. So if you care about maternal health, if you care about breast cancer, if you care about diabetes, then you're going to care about obesity as a women's health issue. And that's where the rubber meets the road. So what the Alliance for Women's Health and Prevention did, starting last February 2024, we decided to venture out on this obesity landscape and developed a program called Everybody Covered campaign. And with the Everybody Covered campaign, we curated a stakeholder women's-based group of over 60,000 women. And what we decided to do with these women is to get stories like your mom's, stories that are on our website, to get the word out about what women are dealing with, how they're living with obesity. Not only the women, but also their caretakers as well, and in some cases, their partners as well, so that everyone will understand what it really looks like to live with obesity. We're talking about diabetes, we're talking about high blood pressure, we're talking about all different kinds of cancers. Those are the kinds of things that women are living with. And when we're talking about younger women, fertility issues, endometriosis, not being able to have kids, those are the kinds of things that they're living with when they're living with obesity. And so when from our Everybody Covered campaign, what we were able to do, we were talking about the CMS proposed rule, we were able to activate those 60,000 women around the CMS proposed rule and get letters to their members of Congress. We're asking for them to sign a pledge that says, we're going to do something about our living with obesity. We're going to let everybody else know that there are other things that they can help us get the information out to CMS, to HHS, to the employers that we're working for, to talk about and to better understand about living with obesity. So one of the things that we did, we put a full-page ad in the Wall Street Journal to address an open letter to employers, asking them to consider, one, that obesity is a chronic disease. We need for you all to understand that. And then number two, look at your health benefits and consider providing comprehensive obesity care for your employees. And then three, look at your company culture. Look at it from the CEO all the way down in terms of bias, in terms of making sure that the company culture looks at making sure that everyone is addressing employees who are living with obesity with kindness and with empathy. And that's what we're trying to do.
You're doing a lot, Millicent. 60,000 women to mobilize. That's fantastic.
60,000 women.
I wish that didn't need to be the case, but it's so important that you're doing that work and taking out that ad just to call everybody out. I love it. And I think that is so important too that you put the through line there that not only is obesity a disease, but that employers have a place to play there, right, in fighting these misconceptions.
Could I?
Yeah.
So one thing I would say the November 26th rule, because it was announced when the Biden administration announced it was the day before Thanksgiving, so I never forgot that one. But it was November 26th when they announced that, and I was like, wow, this is such a game changer, because Medicaid and Medicare could potentially cover it, and it would be a catalyst to getting a lot of states that didn't have anti-obesity medications. Think about it, it's a toolkit. Like, you can't address you have a disease, and you're limiting to certain things that they're like, well, you can do bariatric treatment, which is the idea that bariatric treatment is less invasive than anti-obesity medications is just bizarre to me, because like, who's going to be able to take off a week from work or 2 weeks off of work to get their stomach cut and then to like take off? It's just not feasible at least for a lot of working class folks. Like, and then so when that rule was pronounced, I was like, wow, this is great. And then on, I think it was April 4th.
Yeah.
When April 4th, when they rescinded that, and then you started seeing even the progressive states, right? Connecticut, Pennsylvania, I guess Virginia, what used to be somewhat progressive, but Virginia, a lot of these states started pulling back further. Or like my PhD in public health colleague, Dr. Glenn Youngkin, decided that he was going to increase to be eligible for anti-obesity medications in Virginia, you had to have BMI, not by clinical standards, but by 40. You're going to set it up much higher than, and just arbitrarily, just completely just say, well, we're going to set a BMI 40. There we go. Pennsylvania, same way. Connecticut, same, like, so the governor's budgets in state after state after state are pulling back at it. And again, we're seeing the ripple effect from what didn't happen at the federal level, now even at the state level, even states like California and Massachusetts are even thinking about twice about covering it. And I'm like, this is not good. This is horrible. Again, at the end of the day, it's those working class folks, those folks who have no other choice. They were born with the wrong gene in the wrong place at the wrong time. And that's, for me, is extremely tragic. So.
No, I totally agree, Dr. Serrano. Tragic and I think immoral, right? I think we have a moral imperative to provide this kind of access given the folks that suffer from this disease. And that's a great point that you highlighted, that all the many reasons that this was so terrible that this administration rescinded the rule. And then going back to Millicent, your point is that when they do rescind this rule, other states do not cover it or kind of backtrack.
Or
and
the commercial entities.
That was literally where I was going to go to. Go ahead, Millicent. That was literally what I was going to say.
No, you go ahead and ask your question.
I'm not marvelous and magnificent. You got to go. I didn't mobilize 60,000 women. I'm just here with the portfolio, Millicent.
Listen, we just want to get comprehensive obesity care and treatment, right? So, Dr. Ray, you're talking about bariatric surgery. That's just one tool in the tool chest. You know, medical nutrition is another tool in the tool chest. Intensive behavioral therapy is another tool in the tool chest. And clearly, having obesity medications is another tool. We want all of that to be a part of that tool chest. We want employers, the Alliance for Women's Health and Prevention, want employers to better understand that if you have all of these tools in the tool chest, and you can activate that for your employees, then when we're talking about lessening diabetes and lessening high blood pressure and lessening all the other cancers that you will eventually have to pay for if you forego providing the obesity care. If you forego providing the obesity care, then all of those, that's one disease. Here, 200 perhaps more diseases in one person.
Yeah.
10 more diseases in one person that you're going to eventually have to pay for if you forego taking care of obesity care and treatment.
Mark, you were going to say something?
Yeah, you know, to what Millicent was talking about, employers' buy-in. I have a cousin, very successful businessman, and one time I was talking to him, and I said, you know, what is the most important aspect of an employee that makes a successful company? You know, is it degrees? Is it, you know, business acumen? He said health.
Yeah.
Being, you know, having a profitable company, when you have healthy employees, you have a productive employee. And when you have a productive employee, you have a profitable company. Grant you, it's not about profits, it's always about life and have a quality of life. But if you're talking about an employer and buy-in, just say, hey, it is good for your company to cover these because the employees are going to be in the office working to help you provide whatever service you provide.
You know, that's such an important fact. And I just want to just pivot just a little bit, given time. Something that we've seen in the news and kind of like an emerging risk that you all might be familiar with is just the emergence of counterfeit products and counterfeit anti-obesity medications. Given that there hasn't been any access to these kinds of medications, folks are turning to unsafe and unregulated options. I wanted to turn this over to you, Doctor, to talk a little about, with the rise of these counterfeit medications entering the market, what additional risks do patients face, and how can we better protect these vulnerable patients?
Thank you. Well, thank you everyone for all the comments so far. I mean, it's been a phenomenal conversation. I do want to say one thing, because when we talk about tools, right, I think people always pit these different treatments against one another. And just like when you're building a house or you're building something and you have a toolkit, you wouldn't say, oh, because I have a screwdriver, I don't need a wrench, right? You need all of them because they serve different functions. They're treating different parts of the pathophysiology in the body and the treatment of obesity. So we need the entire toolkit, and so just reminding them of that. So to counterfeit medications, this is something that I'm passionate about. Sure, yes, Lily has a stance on it and has done a lot of work against both compounding and counterfeit medications. But because I do a lot of work in the Black community, I can understand why we gravitate towards it, because it's affordable, right? But I think the most important thing is to understand that just because it costs less doesn't mean that it's the best. And the savings that you're having for this counterfeit medication actually can be costing you in other ways as well. So a lot of times these products are cut with unregulated materials, or they're diluted, or they come from out of the country. They are formulated by people who don't have the right amount of training. So I think it's really important, especially for us, that people are aware of that. And that is why access is so important, and why we need to make sure that the medications that have gone through rigorous clinical trials, and in the previous session, we're talking about the importance and the role of us being in the trials. But that is why it's important that we have access to those medications that have been well tested, and bringing down the cost as well, which is something that I'm grateful that Lily is working towards doing by even changing the mode of pens and the way that the medications can be administered, so we can drive down some of those costs in addition to getting the federal funding.
No, that's a great point, and
Go ahead.
Let me
yeah.
just add to that. Like, so about 1 in 6 Latinos don't have health insurance. So if you look at, and in certain areas like San Antonio, you look at like some major cities have big Latino populations. It's a really high percentage of Latinos don't have health insurance. They still need access to certain medications, and so it was a reporter that came to us and asked a question about, like, in Florida, mifepristone, and that she was interested in seeing, is it possible to get mifepristone over the counter in certain, like, bodegas, like little corner stores in Latino neighborhoods? So we turned to our councils LULAC has like about 535 councils across the country. So we turned to our councils in Florida and say, hey, can you help this reporter and just an informal study, just to see if you can find mifepristone? And they could, in 2 places. They just went around asking for it, and it was just as easy as just not going to the store and saying, do you have this type of medication? They're like, yep, we have it right here. Now, we don't know if it's real. It could be from Brazil, it could be from India, it could be one of these, it could be counterfeit, whatever. But to the point where last year in June, the World Health Organization had issued guidance to basically say there's a lot of fake Ozempic on the market, a lot of fake Mounjaro on the market. There was companies that were kind of labeled as being based in Denver, Colorado, but really based in China, selling like kind of bootleg, like Ozempic and Mounjaro, that was basically insulin or something else. And again, a population of Latinos are so desperate because, again, the default is just slipping into that $1 million patient category with the 200 diseases. And they're so desperate for something that they'll even go to that bootleg market, to the bodega on the corner store, and some guy says, hey, I got some Ozempic here, I got some Mounjaro here, I'll give it to you for this price, and they'll pay for it out of pocket, and it's fake, and it's sad. And I think, but there's a definite need. I know for the Latino community, a definite need for more vigilance in that area.
No, thank you for that, Ray. There's always going to be a black market for this product, given, to your point, the desperate need for it, right? So I think it's up to us, and you all are doing such a great work to just advocate for that access, because people will get hurt, as Dr. Gosamboli just discussed about what these counterfeit medicines will do to people's health. I think we have time for one final question before we wrap up and get into Q&A. So I want to leave everybody with a sense of action and possibility. To that end, I would love to ask you all, what can we do right now to move the needle, to break down some of the barriers that we talked about? And what would you all like to see done, if you could just wave a magic wand?
Well, I'll start. You know, I've adopted kind of a advocacy philosophy that I have when I talk to congressional offices or training advocates, and it's the E3 formula. Empathy. That's the starting point. You have to really know the people that you're advocating for. And especially with a disease like obesity. I mean, sometimes people are not comfortable talking about it. They've been stigmatized about it. So, you know, really getting inside and knowing what they feel, or try to know what they feel, is important. Education. We need to know what obesity is. We've sat there and talked, and we've constantly repeated, it is a chronic disease. It is a chronic disease. It is a chronic disease. So, you know, educate ourselves about what obesity is and what obesity isn't. And the third thing is, once you have the empathy, once you have the education, engage. Engage policymakers, engage regulators who are responsible for whether being pricing or how these things are made, so we don't have any counterfeit medications. And so doing all those things can help stem the tide of obesity, thus stemming the tide of all the other diseases associated with obesity.
I'm hoping that we'll be able to get the Treat and Reduce Obesity Act reintroduced in Congress this term, and hopefully when we're moving towards reconciliation, that it will either be a piece of reconciliation that will be approved.
And Milton, can you explain a little bit about that bill that just changes the rule within Medicare to allow for anti-obesity medications, right?
Well, yes, it will allow for anti-obesity medications through the Medicare and Medicaid program, absolutely. And hopefully giving the states that push that they also need to make sure that they will be able to fund their end of it for obesity medications.
And even hopefully commercial plans as well.
Absolutely.
I think for me, like, so my background was actually in HIV when I first got into health. And I always look at obesity. You don't normally think of HIV and obesity being similar. But the way I see it, it seems very similar. The question for HIV was always like, how did you get it? Surely you must have done something wrong. Why should we be paying for your poor choices? It sounds very similar to what you hear about obesity, right? How did you get it? Surely you must have been overeating and doing horrible things with your body. You were neglecting your body. Surely, why should we be paying for your poor choices? If you stick with that parallel, one thing the HIV community did right was that the people who were most affected by it ended up becoming their best advocates for it. You look at ACT UP, you look at these organizations that came up to say, we demand treatment. We're not just asking a charity case, we demand treatment. We demand that the FDA start a fast track program for drugs. We demand certain things. They started pushing, it was an advocacy driven by the people who were most affected by it. That's what we're trying to do at LULAC. We're trying to do that model, kind of an ACT UP model for obesity and chronic disease. To have people not just be living in the shadows and say, well, yeah, I'm 400 pounds, I don't know how I got like this. No. Go out and speak about it. Look, it's hard to be 400 pounds. It's hard to be 500 pounds. This is what comes with it. But if I had access to treatment, if we could have access to treatment, we could change up things. When I was 300 pounds, 200 pounds, this is what I could do. Now I can't do that now. If we could do this, let's make a change now. You can make, pulse. So we're trying to drive that from the most grassroots level in a kind of an ACT UP model. and try to push that forward so that we could pass TROA, right? So that we can pass the Treat and Reduce Obesity Act. So that when the OMB decides they're going to just magically on April 4th change, no, we're not going to do this rule change. There will be consequences for it. We will be out there. So that's the hope.
So you asked about magic wand, right?
Yeah, anything.
Okay, good. Yeah, and you know, I may be a physician and maybe a scientist, but I'm a dreamer by thing. So if I could, I would say that statistics are not stagnant, and that we can actually change them, right? Each and every person sitting in this room, why make time, this is not my day job, why make time to come here and to talk to you all is because each and every one in this room has the potential to make meaningful change. People say, well, why did you leave what you were doing and join Lilly? I said I was tired of trying to change the world on my own. And with a disease state as vast as obesity, where we have 75% of the US population with overweight or obesity, where we have $933 billion of healthcare costs associated with obesity, it's going to take each and every one of us working in our sphere of influence individually, but collectively to make impactful change. So I would hope that after leaving here that you've each taken away one thing that you can utilize in your sphere to help to change those statistics so that we actually reverse those numbers and continue to bring them down.
Y'all hear that, folks? Y'all got to get to work.
We have to.
We, not, oh yeah, including me. Yes, you're right, doctor. I'm getting to work. So we have about some time here to do some questions and answers. Do we have anybody?
Hello, my name is Rachel. I'm ACP, the American Association of Colleges of Pharmacy. And I'm coming also from like a personal perspective where I'm 5'1", Dominican. All the women in my family are thicker. Nobody's thin. Oh, sorry. Nobody's super thin, but nobody is out of shape either. We're a pretty active family. We do hikes, we can bike. But I went to go see my doctor, and since I'm 5'1", 130, he almost kind of tailed along the line of like, hey, like if you want to be a little healthier, maybe you need to drop 5 pounds. For reference, I work out 5 to 6 days a week. I think I look good. I think I'm in shape. I can go up 6 flights of stairs with both of my dogs in my hands without a problem. That's an exaggeration, but I'm fit. I'm fit enough to, you know, feel like I'm healthy. I shouldn't be on a track where I go visit my doctor and what's recommended is weight loss. From kind of like to build that patient-provider relationship when it comes to obesity and just health and fitness and wellness, how do we bridge that gap where all providers can be culturally competent and understand that there will be differences of what healthy looks like, especially in Black and Latino communities and in Black and Latino women specifically. So I don't know if you have any thoughts or comments, or that was kind of my question, wanted commentary on.
Oh yeah, I got a whole lot of thoughts. we don't have enough time for all my thoughts, but so I will summarize it. Well, first of all, thank you for sharing that. And unfortunately, what you're saying is not uncommon, right? Because to many of the things that have been shared here, like obesity wasn't recognized as a disease until 2013. So I went to George Washington University right here. We didn't even learn about that. I graduated 2010. And so it hasn't been recognized as a disease. And then also the way of measuring it using the body mass index, which you all are probably familiar with, right? Which is your weight divided by your height in meters squared, is using a standardized chart that was not built for the Black body, right? Or for the Latino body. So there needs to be mass education amongst healthcare clinicians and providers about using the right tools. So Dr. Fatima Cody Stanford actually proposed a adjusted body mass index chart that is based on race, ethnicity, metabolic health disease status, and it actually shows that for Black women in particular, the starting body mass index at which you might have obesity is higher than that 30. And so, and then the other misconception, because we started by talking about misconceptions, is that, you know, you can just look at a chart and pick a number on that chart and decide that someone is healthy or not. It really has to be individualized to very much the things you said. So are you active? Are you able to, do you have any metabolic health diseases? And again, since this is a disease of excess body fat, the BMI does not tell us about body fat, right? It's someone who's very muscular could have the same BMI as someone who has excess fat. So you need to actually measure the fat, measure where the fat is located, and then put it into that context. And then I always say too, like you mentioned, we, especially as women, I will say, like, looks and health are so interchangeable. So let's take the happy weight off the table. Like, that is important. But when we are seeing your clinician, that the discussion is about health specifically and healthy weight, and that is more than that number on that chart, that BMI chart. So I would borrow one of Mark's E's, is the empathy. And, you know, honestly, some people may not be able to empathize because they can't put themselves in your shoes, but at least the listening part of it, the ears, maybe we change that empathy to ears, right?
There you go.
And like
The four
listening
E's.
to, yeah, exactly.
4 E's, yeah.
And listen to it, but then education, 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 and that's one of the things here in Montgomery County in the Black Black Healthcare Providers Network, is that we do is like send out culturally tailored care about obesity and making sure that every provider or clinician knows about this body mass index chart for the Black and brown body is so important. All right, I'll stop there. How many minutes did I do? Okay.
Any other questions?
Hello.
So as I think about this, and I think about just some anecdotal experiences traveling to Europe, traveling to South America, I'm curious all of your thoughts on public infrastructure as its relation to this issue. I live in Texas. I think about the fact that I have to get into a car to drive anywhere, whether it's a grocery store, whether it's, I mean, to get anything. And the lack of walkability, the lack of public transportation, and the difference between how America structures our public infrastructure and public transportation versus other countries around the world. And just curious your thoughts on that.
I can speak briefly on that. You know, it's very important. I think oftentimes when we have discussions about disparities, we tend to put it more in the context of race, but there is geographical disparities that are just as important. I grew up not too far from here in Loudoun County, Virginia, but I grew up there before it became what it is now, when it was pretty much, I grew up when it was country.
When it was rural.
Yeah, when it was rural, when there was only one hospital in the county and there wasn't as many doctors' offices. So it is very important. And then you go into other rural communities, you may have, you know, just have one hospital, but then as far as food, basis of food, you may have just the Dollar General to get good food, as opposed to, you know, the grocery stores. And so we do need to address infrastructure in a big way with regards to rural communities, but also now, if you're talking about, you know, excluding roads and everything, telehealth has become important in those communities, but they can only work if you have broadband antennas and that kind of infrastructure. So that needs to be addressed when we talk about those geographical disparities that you're talking about. And again, of course, you know, there's bills also that have been introduced to incentivize doctors to practice in rural areas. So, you know, just like we're talking about with obesity being a multifaceted type of disease, it's going to take multifaceted solutions to deal with these problems and to solve these problems.
If I could say, I'm a huge fan of health impact assessments. I'm going to speak basically January 19th, because now I think it like health impact assessments are basically modeled after the economic or environmental impact assessment. So when you want to build something, what is going to be the impact on the environment? Is it going to cause, you know, water drainage issues or whatever? Like all these things that would happen to the environment, but in the context of health. And then the reason why I think those health impact assessments could be very good tools, if you look at the communities that suffer the most, it's usually the poor communities, Black and brown, poor, inner city, rural. Those folks are not going to planning and zoning commissions meetings. the commission meetings, sometimes I have them at 3 in the afternoon. Who's gonna take time out at 3 in the afternoon to go to a meeting like that? Nobody got time for that. Like, they're not gonna do that. So like, this population is gonna have these decisions that's gonna put the next fast food swamp or the next food desert in their area, and they have no choice about it. Well, in theory, they did have a choice because they could have taken the day off to go testify or find out what the whole, Planning and Zoning Commission actually does. Or you could have a health impact assessment. And a requirement is that if whatever you're gonna build or how you build, what is the impact on health? Because at the end of the day, it goes back to this idea that we all have to pay for it. Someone's gonna have to eat that cost. It's not going away. The federal government, state government, employer, the individual, someone's gonna have to pay for it. And so maybe we should be more conscious about like how when we accept that somebody's gonna have to pay for it, then we start thinking about maybe we should be guiding how we're gonna plan.
Yeah. Can I add one thing to that too? Because I love that you brought that up about the health impact score. And then one of the things that Lily is partnering with the economists on is an obesity readiness index. So looking at 46 countries across the world and looking at the infrastructure, both in terms of the lived environment, in terms of the healthcare system, in terms of food access, all of those what we call social determinants of health and how they intersect with obesity. Because you're right, it can't just happen in a vacuum. All of these things need to interplay as well.
Hello, hopefully what will be a quick question. I see Brandon walking around. So my name is Witza Saeed. I'm a pediatrician and I work with the Department of Health and Human Services. And so question for me as I think about kind of like, us talking about obesity as a disease and always thinking back to kind of like the aspect as far as where words matter. I was just thinking a little bit about sort of like the reason being why we sort of consider some of the drugs that you've talked about as far as anti-obesity medications versus obesity treatment. And although that seems like a very small nuance when it comes to education and sort of like perception, I wonder how you guys might think that might change maybe the narrative or if that's come up at all.
Absolutely. I detest that term. I really do. I think that, we don't, because it can come off as offensive, and that's one of the things we're working to change. So the new term or the preferred term is OMS, or obesity management medications, is the new term that's preferred. Because you're right, it's already stigmatizing, and then to add anti in front of that word can be really disheartening for a lot of people, because it can feel like you're against them. So there is a move to change that term.
Thank you, I just learned that.
I like that.
Yeah.
Do we have any more? No more questions? Okay.
Everyone's scared of Brandon.
He's walking around?
Yeah.
Yeah. Well, I want to thank the panelists for the time. This was such an amazing conversation. You all brought so much expertise and nuance to this issue, which I think is just so needed. So I just want to thank you all, and please everyone give them a round of applause.
Thank you.
Thank you. Thank you.
That's infected.
Right now, you can see frustrated about healthcare on free cancer screening president of the event. Right now, you can see
The report shows there may be a reason behind why minority communities are dealing with higher environmental risks for cancer. More than 56% of the people in minority communities live in toxic environments. Those alarming numbers come from research done by the National Minority Quality Forum and several partner agencies. The findings?
Chemical facilities along that stretch of river, where the EPA has repeatedly found that residents are exposed to more than 10 times the level of health
Cancer
risk.
rates here in his hometown of Flint are soaring. The disease taking the lives of his loved ones.
Very concerning. My aunt passed away. She had 5 different cancers. My cousin passed away. She had 3 different cancers.
What is happening here in Genesee County, and is this cancer crisis connected to the water switch? Newly released data from the health department reveals cancer rates here significantly higher than anywhere else in the state of Michigan.
A documentary telling the story of creosote contamination from a Union Pacific Railroad yard in 5th Ward premiered at the Deluxe Theater today. The railroad yard has long been said to be the cause of the cancer cluster in 5th Ward. The documentary aims to educate the community about the possible dangers still lurking in the area and to get community members to sign up for free cancer screening.
To sign up for the screenings.
Okay.
And so these screenings will have a long life for years.
Actually looking at the shifting stages of cancer in someone's body. And so because we know that there's been exposure here in the 5th Ward for such a long period of time, unfortunately, we believe that some of these environmental toxins are changing the molecules and what is happening in people's bodies.
Part of a program that we've launched called Cancer Stage Shifting Initiative. And the idea is to move us from late stage diagnosis of cancer to early stage diagnosis of cancer.
Well, today, an early cancer detection program is set to launch to help families get access to care and the continued efforts to address cancer rates in Houston's 5th Ward.
A new enrollment initiative, and this is truly aimed at trying to help residents in the area. We're talking about everything from screenings, different health screenings, as well as getting access to care. And so people will be able to do that here tonight as well. We've also learned one of Houston City Council members is going to be one of the first patients to enroll role in this particular program.
Officials with the National Minority Equality Forum told us they hope the study leads to proactive changes to cancer health care.
We can go back to members of Congress, to the state legislators and say, so here's what quality cancer care actually costs. And our sense is that if we get it at that pre-cancer stage, the cost will come down dramatically.
Get rid of petrochemical plants. We're getting rid of it right now. That's my fight.
Good afternoon. I want to, before I introduce our panelists, say just a quick word about the Cancer Stage Shifting Initiative that the National Minority Equality Forum has launched. So what you should gather from the film is that there are communities around the country that have been exposed to environmental toxins. These environmental toxins have raised their risk for cancer. Fifth Ward in Houston, Texas, Flint, Michigan, Cancer Alley in Louisiana, Rubbertown in Kentucky. These spots are all over the country. And it's not just that they've been exposed to environmental toxins, they've also not had access to best modern care. There are no clinical trials. They get diagnosed late for cancer. The cancer has metastasized, and their mortality rates are high. So in the Cancer Stage Shifting Initiative program that Nmqf has launched, we want to shift them from late stage diagnosis of cancer to early stage diagnosis of cancer, taking advantage of these new early detection screenings that are becoming available. In our partnership, and we're going to hear from Quest Diagnostic in just a minute, we are working with Quest and MD Anderson to really what we think of as surveil the population through these new screenings. So the sense is that changes in blood chemistry signal the onset of cancer about a year or maybe 2 years before the cancer is actually stage 1. And if we can diagnose cancer at that early stage, then the presumption is that we can treat them and obviously reduce the risk for the higher mortality. This is what writing that last chapter on the war and cancer looks like. And we want to make sure that that chapter gets written in these underserved communities. And the very fact that we call them underserved should be an anathema to all of us, right? Because it's saying that we have deliberately left these communities where they are. We're not just collecting clinical data, we're also collecting the financial data because we want to be able to come back to members of Congress and state legislators and cities and say, here's what it costs to actually take care of cancer in these communities. I'm really excited by this panel. Most of them have been with us. We've worked in community together, and we're going about the business of changing healthcare. And I would just add this one thing, which is this is a demonstration project for how we need to deal with healthcare disparities in diabetes and cardiovascular disease, because what we're doing is we're collecting the data, understanding how the disease is presenting at the population level for the community, and then allow researchers and others to come in and learn how to treat these communities more effectively, and also to collect the financial data. So we offer this up as an example, and we'll talk a lot about how we're actually implementing this program in these communities. So let me start off by introducing Julia Larson from Quest Diagnostic, Arthur Woodson from Flint, Michigan, Sharon Levine from Louisiana, Mary's Parish in Louisiana, and a deep friend, Councilwoman Letitia Plummer from Houston, Texas. So we're going to, Councilwoman Plummer and myself, and she's a doctor too, but Councilwoman Plummer and myself will do a little tag team and co-moderate this session, because we want to hear from the practitioners like Julia, who's doing things in community, as well as from Arthur and Sharon about their experiences in the community. So let me start off with Arthur. And ask him to talk a little bit about the experiences of the community in Flint with cancer.
Well, my name is Arthur Woodson from Flint, Michigan. You all know about the Flint water crisis. Back in 2016, a friend of mine, Pastella, was diagnosed with multiple myeloma, rare blood disease, cancer. So I started speaking with her, and she told me that some other people had multiple myeloma. So being a veteran, I was helping veterans with their benefits. At Count Lejeune, they had TTHM, contaminated water from 1957 to 1985. And multiple myeloma and leukemia is two of the presumptive illnesses from that TTHM. So Flint Water had TTHMs from 2014, April 2014 to October 2015, November 2015. And the advisory letter that EPA sends out is if you consume, bathe, cook, shower with TTHM 30 days, you stand a risk of having cancer. So when she told me that she had multiple myeloma and she said her friend had it, I went and knocked on doors in that area. And just in that one block radius, in that one block, I found 6 to 8 multiple myeloma, which is supposed to be rare. So if it's rare, why am I finding this group of cancer in this one area? So then I started really listening, and I started hearing leukemia, I started hearing T-cell, I started hearing different rare blood diseases that's rare. So I went to the state and asked them could they look into it. They really didn't want to look into it because we already have a lawsuit for the water. The doctors are afraid to even say that it was exacerbated, your illness or the cancer or whatever illness you have was caused by the water because they working with the elected officials in the state and the city. So I formed a personal relationship with Vice President Harris, and when she got in office, she told me that she would promise that she would come back to Flint and help me with the cancer study. So when she got in office, she sent me over to the White House, which was the cancer moonshot, Dr. Congresswoman. And Dr. Congresswoman put me in touch with National Minority Equality Forum. It started off kind of rocky at first, but Dr. Puckrin came through and said, this is what we can do for you. And being that we wanted to, I was asking for a cancer cluster study, and when we started working together, CDC called me down and started asking me questions about the community, different things like that, so we changed the guidelines for cancer cluster study to unusual pattern. Dr. Puckrin brought a whole lot of resources into the community, and that was one of the main things that we were looking for. I was especially looking for it because if I'm out asking you, do you have cancer? I don't just want to hear you say, yes, I have cancer, and then I don't have anything to offer you. I can't send you to somebody for assistance. So we wanted resources at the same time that we are asking people, do they have cancer? And being rare blood disease, Dr. Puckrin also came with some new information because you can't early detect rare blood disease or rare blood cancers, and he found out something new as far as trying to help, early detection because our cancer was so aggressive. If you diagnosed in January with stage 1, you were either terminal ill or you died in June within 6 months. And that's how this cancer is there. So just one example, an 80-year-old lady named Miss Taylor had cancer. Her doctor couldn't find a treatment that was compatible with her body, I guess. So she called me, and by Dr. Puckrin introducing me to Gentech, I met Yvette Dinkins and Nancy Reed from Gentech. I called them, and they had doctors, and they said, well, then find out if her doctor is willing to work with our doctors. And I called him, he said yes. They found a treatment for her, that was compatible, and now she's cancer-free. A lot of people don't have those type of resources, but if we can, in Flint, lead by example and show people, hey, this is how it should be done, we can spread it out to other areas and bring resources into communities that is less fortunate and have the health disparities that Flint has. Because we have the resources, we have the money, but the money just not getting to the people who should have it. So thank you for giving me that time, Dr. Clark.
Sharon, you want to talk a little bit about Louisiana?
Yes, I'm from Louisiana, but it's called Cancer Alley where I'm from. And it's an 85-mile stretch between New Orleans and Baton Rouge. In 2016, I was diagnosed with autoimmune hepatitis. And I don't have cancer, thank God, but a lot of my friends died right there in my community. And I joined an organization in 2015, and I sat there and listened to the people talk about all the industries that's coming in. I live in the 5th district in St. James Parish. We have 7 districts. My district have 12 industries within a 10-mile radius. I didn't know that when I found out in 2018 that we had 12. These chemical plants emit so much carcinogens. People are dying. I've been to the White House telling everybody we need help in Louisiana, especially in Cancer Alley. People are dying, and we're talking to some doctors right now that's trying to help us with early detection, men with prostate cancer. We have, my friend Jean just died with liver cancer. My other friend died with breast cancer. One died with lung cancer. And poor Albert, he's fighting for his life. He has pancreatic cancer. I have 2 brothers with prostate cancer. My sister-in-law died with breast cancer. My sister died with breast cancer. It's all around us, and we need help. I know the problem. We have to get to the root of the problem that's causing these things. In my community, it's the industries. That's why we formed an organization, and we called it Rise St. James. Because we see where the problem lies, and we see where the root of the problem is. Our parish president said Cancer Alley is a myth. He's inviting more industry to come in, and we're trying to keep them out. So far, we stopped 3 from coming into the 5th district, where we have 12 already, and they want to put 3 more, that'll be 15. So we blocked those 3. And our councilman is fighting against us, knowing that the pollution is causing us to be sick. Our air is toxic. Go outside, you can't breathe the air. Your children cannot go outside for a long period of time because they'll come back in the house with rashes. Our soil is polluted. If we plant a garden, the soil has arsenic in it and lead in it. The air is so polluted. We have particulate matter 2.5, particulate matter 10. They come in, we did a health study. We're doing a health study right now. I know that in the 5th district, I think the national average is 40% higher in St. James than the national average. And in our neighboring parish, St. John the Baptist Parish, those people are dying like flies. The whites sold their homes to the blacks. Blacks are stuck there with Dinka DuPont. And I know y'all heard about that. It was on MSNBC. And we are fighting Formosa Plastics. Our councilman that we have right now, he wants to reaffirm Formosa Plastics. Formosa Plastics cannot get the funding to build this $12 billion industry. We started off at 9.5 in 2018. We held it down. Now he wants to bring it back in, and we're about to vote him out of office. The one before him, he was on our side. He would come to our meetings. He said he didn't want any more industry in St. James Parish, especially in the 5th district. He was behind my back talking to the representatives of Formosa Plastics. He voted for Formosa to come in. Even after he talked with us, we thought he was with us, so we voted him out. He's gone. He can't come back. But we are fighting for our lives. It's a life and death situation. The chemicals are killing us. We have benzene in our drinking water. I've been drinking benzene for all these years. I didn't know we had benzene in our drinking water. That's why the people are dying. We didn't know. I didn't know. I found out when somebody worked at the plant told me that how much gallons of benzene was accidentally dumped into the river. And that's our water supply that we drink. And sometimes our body itch when you take a shower. And I didn't know. But knowledge is power. When I started to learn, that's when I started to fight. And I can't stop. I quit teaching because I couldn't teach for 8 hours a day, then come home and work on my organization. But God led me to do what I'm doing. And I know the answer. Get rid of all these polluters that's killing us. And when we talk about it, they tell us, be careful. I can't be careful. My people are dying. I can't be careful. I have to speak it and tell it. The problem is the industry. If you got an industry and they want to come into your community and they're going to get an air monitor, they will pollute you. Trust me. We have one right now. It's called GG Fuse. He said he's not going to pollute. My daughter asked him if he's going to get an air permit. He said yes, but I'm not going to emit too much. A little bit is too much because we already have 12. You put all those together, that's too much. So we told him no. You know that he's still trying to come in. I said no. Sorry, you're not coming to St. James. You might come, but you're not coming to St. James. And I told Formosa, you don't know who you're playing with. You're not coming to St. James. We're already overburdened with industry. Now they want to bring Hyundai in. We have information on Hyundai that's right down the street from us. Maybe about a 10-minute ride from my house. I spoke yesterday at a meeting. I was at a meeting yesterday speaking about this, and I'll be at a meeting tomorrow night speaking about this, and I'll be speaking again Thursday. The community called us to ask us to come to their community to speak about all this industry that's trying to come in. It's poor Black communities that's begging for help. They're crying out for help. Some of them want to sell their homes, but they're not going to give them enough to rebuild. If they move them out, because it happened already to another community. They came in and bought the people out. The people had to start all over with a house note. I'm not about to start over. My house is already paid for. I'm not about to start over. And my community, I will not leave them there. I can leave right now if I want to, but my family's there. My community's there. He would frown on me if I leave my people there. Poor Albert is dying. He said, Levine, I can't come to your meeting because I'm hurting. He said, I have to stay close to the bathroom because the chemo, whatever they're giving him, is making him sick. They help one part of your body, then the other part, it's really bad. Y'all need to come and see where I live. It's really bad. Thank you.
Councilwoman Plummer, you want to talk a little bit about the Fifth Ward so people understand that, and then the program that we've been working on together.
Yes, no, thank you so much for allowing me to be here. So in 2019, the Fifth Ward community was designated by the Texas Department of Health and Human Services as a cancer cluster. And that's one piece I would love to have more conversations with both of you. I believe that was really helpful for us because when the state comes in and makes that designation, it really kind of creates some credence in terms of what the complaints of the community has. Union Pacific was using creosote, which is a wood preserving agent, since the 1940s. And that creosote had gotten to groundwater, into the soil, et cetera, and many people in this community have cancer. And so fast forward now, lots of work has been done, challenges not only politically, but with the state as well, because in the state of Texas, and I'm not sure how Louisiana is, but in the state of Texas, and Houston specifically, we don't have the authority to give a permit to a facility that is building something that could be potentially toxic. The city of Houston doesn't have that authority, and so the state does. And so if your state doesn't respect the fact that the cumulative effects of bringing all of these industries in one specific small area, then the city has a hard time fighting it. And that's one of the main reasons why Houston's had such a difficult time. Fast forward, UP we was asked by the EPA to do additional testing. We just got results recently, and they found that the soil was not toxic enough.
Oh my God.
And so now this community is living in an area where they really can't move because it's not toxic enough to live in that community. And let me just give you a little bit of background about what creosote is. Creosote, as the vapors are released into the ground over time, the creosote gets heavier and heavier, and it's almost like peanut butter. So it kind of keeps on falling deeper and deeper into the earth. And so in the 1940s, the numbers obviously were much higher, right? The vapors were much higher. But now if you go in and test that area, it's not as high as it was before. And so what our challenge has been is, number one, creating the correlation. But number two is, from an environmental justice perspective, what do we do? So now we're at this crossroads, and Nmqf comes in. And that's why I'm so in Quest. And so I'm so grateful, and Acclinate for telling the stories. I'm so grateful for that, because even though people feel as though they don't have any other resources, and they don't or can't move, now they have an opportunity to do early detection cancer screenings with our cancer shifting initiative, stage shifting initiative, to determine early on where they are in the process. And so, because of the support of Nmqf and Quest and many of the other partners that are here, we have been able to look at the boundaries of what the EPA has designated as a cancer cluster, which is about 200 people, and put them into a screening process, an early detection screening process, and be able to track them for 4 years. It's life-changing for this community. A lot of them want reparations. Unfortunately, we can't do that. But what we can do is we can help them live and be grandmothers to their grandchildren, parents see their kids graduate from college, et cetera. And the other piece, the political piece of it, we continue to work on. But now at least there's access. And so we are also supported by Harris Health. So if people are, if they do find a signal, we do have that continuum of care to make sure that they're not left behind and they have the access that they need to be able to ensure that they get the treatment that they need. And so that's what we're doing in Houston. And I'm just so incredibly grateful. Our community is happy and excited. They just feel as if for decades they've been lied to and not been heard. And now they finally feel like they've been heard.
So Julia, talk a little bit about Quest and the role it's played in the Fifth Ward, because I think it's very instructive, so please.
Sure, so thank you for inviting me. So we're very excited to partner with Nmqf on this project as well as in the future with some of your cities as well. So we've been kind of working in the background with Nmqf to come up with what would be the appropriate kind of testing to do with these people and these communities, and work on how we're going to do that. So I've heard a lot over the day about the challenge of getting into communities. And fortunately, part of Quest has a part of our company called Exam One, which that is what they do. They typically go into people's homes to draw blood or get other kind of specimens. So we were able to coordinate having our Exam One group of phlebotomists and managers come into the area in the Fifth Ward at a local clinic. But we also can do group kinds of events, at churches or barbershops or, things like that as well. So I think we have a mechanism to bring the ability to do this screening into communities rather than people having to travel outside and get into those other areas where there's academic centers typically that are doing their clinical research.
So Quest has done so much. In Grace Clinic, didn't have a phlebotomy chair, and they brought in a phlebotomy chair. They helped them tie into Quantum, the network that Quest has to deliver the trial, the information about lab results, and has really helped bring that practice up so that it can actually do clinical trials. And so Nmqf trained the staff at Grace Clinic to do clinical trials. We took them through a whole process. Our staff has worked with them. Councilwoman Plummer has been deeply engaged. I got to ask you to talk a little bit about the door knocking that you did, which was a brilliant idea. But if you could talk a little bit about that.
Absolutely. I think that one thing, we've been having this conversation probably close to 2 years, maybe a year and a half now. But one thing that I was very cautious of was this community's been just, the distrust, the levels of distrust in these communities is insane. And so we wanted to make sure, number one, they knew who was coming. We wanted to make sure that they knew we vetted who was coming, but we needed to touch them where they were. Many people don't have the opportunity to come to a town hall, or they can't come to a city council meeting, so what we decided to do is we decided to knock on their door 4 rounds. And so many volunteers, we had about 10 volunteers, 2 of my team members on my staff at the city council, all day, 8 hours. They literally knocked on doors over and over and over again and let them know this is happening. They brought the QR code to the door. Do you want more information? How can we educate you? How can we explain to you what's going on? And when you do that, when you touch their door and you come to their door and actually have a one-on-one conversation, because healthcare is so personal, but when you have that conversation, and because NMQF trained our volunteers as well, we had a full training of what to say, what not to say, what to commit to, what not to commit to, and where to drive their questions to make sure we get the proper answers. It really made a difference. And so far, we have 200 slots. I think we've got 100 people have gone through the screening process. Maybe not, about 120 people have gone through the screening process. I think 100 people are either slated to get blood draws. So we're really close. And there's that space of people that have done the screening but haven't gotten consent, have not gotten consented yet. And then there's a number of people that have gotten consented but haven't quite made their appointment yet. Those groups of people I will meet with one-on-one or in a small group setting to explain and educate them a bit more. That one-on-one attention is really important in these spaces because of the level of distress that we're dealing with. And so that's kind of where we are right now, but the project is seamless. It's just really going well. I don't know. I'm just so grateful.
And for those of you who know clinical trials, you need to know that we're talking 30 days since we launched the study and enrolled over 100 people in the study. So that gives you a sense of the community's response to it. Arthur, you've been on a tremendous journey in terms of getting good cancer care in your community. Can you talk a little bit about the access issues and things that people have experienced? So they've got cancer now, and now they need good quality care. Can you talk a little bit about what's going on there?
Oh, man. My aunt and my cousin, her daughter, my aunt's daughter, they lived in the same house, and both died from cancer. One had 5 different types of cancer, you heard me speak on in that clip, and the other one had 3. The care is like at 0. Everywhere is different, and Flint is tremendously different. Being that we were poisoned, 98,000 people was poisoned by the water, and it was elected officials that poisoned us, along with the administration. We have a Flint water crisis lawsuit going on, $650 million that was approved back in August of 2020, and no one has seen a dime of it yet. You have people dying every day. I found an 8-year-old that has breast cancer, and no one seems to be able to help the people in the city of Flint. The politics and the different pastors and cliques and different things on how you have to navigate the community is like chess. You got to know who you can talk to, at what time you can talk to them. hospitals, which you all know, especially McLaren Hospital. I didn't even know about 340B until Dr. Puckman called and spoke to me about it. And McLaren and Hurley and Genesis, it was money that was supposed to be used in the community to help the patients. And they was using it to pay CEOs and making profit off of it. No charity work, none whatsoever. In our communities, I said to myself that, you know, we've been marching since 1968, singing "We Shall Overcome," and we haven't overcame anything. And I vowed that my grandkids would not have to march for health care in Flint for something that we could have handled before it even got to them. The fight is real, and it's trying to get people to come together to help. You might not like a delivery, like a lot of people don't like my delivery, but I'm just speaking the truth. And sometimes the truth hurts. And a lot of people that's in a position of CEO, doctors, researchers, you haven't seen what I have seen or what I have dealt with. And when we come to you, it's people just like now. I had to fight with my cancer study because people tried to take what it is that I'm trying to do and make it their own. And they start adding things, and then they gotta have a meeting because "the" was in the wrong place. And we're gonna have a meeting on putting "the" in the right place. And then the other two people who is in the meeting don't like where "the" is, so we gotta have another meeting. And before you know it, you have about 100 people dead from cancer because they fighting because "the" is in the wrong place. So it's all about, I'm an activist. I don't work for elected officials. I don't work for anybody but the people. And you know, I promise God that if he put me in a position to help the people in the city of Flint or help anyone, I'm gonna, you know, do my assignment and work with the resources that I have. And so far, God has directed me in the right way. He has shown me Nmqf. He has shown me different doctors, different hospitals, just been placed people in my path that where there's obstacles, he done brought somebody. I might get mad, I might get upset, I might get frustrated, I might want to give up, but God has took me through something before that storm. So when that storm hit, I'm able to weather that storm and keep it moving. But back in the day, I wasn't able to do that. So I'm a work in progress, but I'm still learning. And I'm glad that I have Nmqf and the resources that they have, because I'm able to call them. They might get mad at me because I'm mad. But me and Dr. Puckman, we done talked a lot. And he know me, he'll listen to me and say it's gonna be all right. And you know, he bring his resources, health fairs, and different things like that. And that's what we need. And we need hospitals, we need oncologists, we need doctors, we need quests, we need, in those communities, we need everything, because so many years they said black people are prone to have cancer more than whites, but I never really understood it until I came to a summit here at Nmqf, and they had a panel. And I asked them, I said, can environmental injustices change the DNA or the makeup and make it look like it's passed down generational and make it look like we are just prone to cancer, not telling us the other part, that the environment played a major role in black people being more prone to having cancer than whites. So, and he said, yeah. So I've just been learning every year with Nmqf and different things in the community. And I thank Nmqf, and I thank everyone that works with NMQF for helping us here, there in Flint. Thank you so much.
Yeah, please.
I have a question.
Please.
So this will go to both of you. Let's speak this into existence. NMQF is going to come in, Quest is going to partner in. We're going to be able to have a clinic there. What do you believe the barriers will be, if any, to get your residents to believe in what we're doing and to come and agree to be a part of the screening process? Do you think that they would be excited to see that, or do you feel like there's too much mistrust still? And what do you think the barriers would be?
I think it would be our parish president and our elected officials, because they will try to convince the residents that cancer is a myth. And some of the people, maybe half of our community, would think that the politicians are right. But we have to continue to still fight to bring them the information, to educate them. The more we educate, the more come over to our side and say, you know, I see what you're talking about now. Education is the first thing. But to get through our parish president, you will not be successful. And our politicians either. So you have to go through the citizens.
Being that since 2016 I've been speaking about cancer, and in Flint, like I said, the water crisis, we have self-taught ourselves, you know, for certain wording, TTHM, PFAS, lead, benzene, vinyl chloride. We know all these. We are self-scientists. So it's certain wording. If you say we're coming in for clinical trials, it can't be anybody new. It has to be somebody who they actually trust. And that's where a lot of people have messed up at. And you get them in the city, that grassroots, that person, that the boots on the ground get you inside that city, and then you throw them to the side, then you start working with the people who the people in that city is against. And once you start working with them, that's when the people say, hey, you know what? Y'all full of mess. We're not participating. We're not going to work with you because we saw how you just did the person that I trust. Then you have the people that's already in that city that's stealing, corrupt, or taking the money. You have them, they don't want you in that city because you get ready to take the money that they should be getting. So they're going to buck you, they're going to fight you, they're going to say, hey, you got to go because you get ready to start tapping into funding that we have. So if you don't have that, it's basically like protection. A lot of people think that the money is the power, the people is the power. Before you come into any city, you have to have the people. If you got people that have the people backing them, that they trust, everything is great. We gave a health fair, what was that? January 2023. 2023.
Well,
and I think we had about 500-700 people at that health fair, and we did it in like 2 weeks because the commissioner died, who was going to open up the event and everything. He passed away right before Christmas. So Ajwa and myself, and I forgot the other young lady that worked for Nmqf at the time, we had from January the 3rd until January the 16th, Martin Luther King's birthday. Being that they trusted me, I was able to really speak to them, and people actually showed up. It's about operating with people that the people trust. But you do that, you know, everything is okay. But if you come in there thinking that, you know, we're gonna do it a certain way, we're gonna do it my way, and that's it, you're gonna have some serious issues.
No, I totally agree. I think having trusted partners and trusted voices in the community is paramount.
Julia, you know, I'm sorry, I didn't ask you this question earlier, but I just assume everybody knows Quest Diagnostics, so can you tell a little bit about Quest Diagnostics and the great work that it's done?
So there's two major laboratories in the United States, Quest Diagnostics and LabCorp, so you've probably heard of one or the other. We test blood every day on about half the Americans in the country. We have 2,200 what we call patient service centers around the country, and that's typically in communities where patients can go and get their blood drawn there. We have several different labs around the country and the regions that perform all the testing. I happen to be associated with the one in California and Southern California that does a lot of esoteric testing. So even if all tests are not performed at a particular region of the country, we have a fleet of planes that'll get that blood sample from one place to the other to get the testing done, especially if it's specialized testing. So we're just excited to be able to partner with you all, especially with the Exam One. I think that's really what makes this work, is that we do have this access to hundreds of phlebotomists across the country that can go where the need is, and we have been involved in health fairs many times. So I think that's what's really unique about this, is that we have the ability to be flexible on where we go and when, and meet the needs of whatever the situation is.
And Quest also has a tremendous scientific group that has helped us as we've been looking at, so what data should we be collecting? Mm-hmm. What tube should that data be collected in? It turns out to be a very important question, how that blood gets processed. So Quest has been incredibly important, helping to design the study and making sure that as we're collecting those blood samples, that they're actually valuable, that we can actually use them in a scientific way. And besides the lab data that we're collecting, we're also collecting genomic data and electronic health data, and Quest has been just absolutely fabulous. As any of you who've done clinical trials know, there's a lot of hand-holding and a lot of very particular things, because we also have an IRB board, and if we violate anything, we've got to report it to the IRB, and we don't want to do that. And so we've been very, very careful as we've been putting all of this work together. And in just a second, I'm going to open up the mics and allow you folks here to ask some questions. But here's what I want you to understand as you start to move forward to ask questions. The reason why we wanted to do this panel with you, because there are communities around the country that need your help. And one of the things that confounds me every day is that we are a civil society. We help our neighbors. We don't allow them to live in carcinogens, and we don't turn our backs on them as they die from cancer. That's unconscionable. How can you call yourself a civil society when you don't even, and some of these industries are literally across the street. They literally across the street, right? And they haven't opened their doors to come out and say, how can we help? What can we do? And so what we're trying to do here, besides the work that we're doing in these cities around the country, is to create a demonstration model to say, so if we're really serious about eliminating healthcare inequities, it's a process. It's a process that we need to understand and follow. And Dr. Plummer, I keep calling him Dr. Plummer, said to us, we should write all this up. And I said, oh, that's a brilliant idea. An implementation study to help folks understand how to do this. And so our team is working with Dr. Plummer to do just that, to begin to put this down on a piece of paper. Because again, by 2050, we don't want to deal with this anymore. We got to put a stake in the ground someplace, right? And we could say by 2050, we can read about Cancer Alley in a textbook, in a history book, but it's not going to be the practical living experience as long as God gives breath in these bodies to make it work. And so that's our deep commitment. So please, if you've got some questions, please step forward and ask, and we'll try to get the answer.
If I could say one thing, I'm going to make my ask as well. One of the reasons why Houston, there's so many reasons why Houston has been successful thus far, but one of them is partners like everyone in this room. It gives us validity. When they see Quest logo at the bottom, or when they see Nmqf, they know, or if they know that this is an IRB certified, and this is something that we have vetted and we have done the right way, and when we explain what that means, it's another level of trust that we're able to give to community. And so having you all as a partner, we're just touching the surface here. But what if someone gets a signal? What if we get a positive signal on one of our residents? What do we do with them next? If they're, if they're an African American, is anyone in this room, do you have a clinical trial that our resident can now get inside of and get into? Can we make sure that the fees are nominal? Can you support that? These are the next steps. This is why everyone in this room is so critical to be a part of this conversation. And in that way, by 2050, we can definitely say that we've done our job and that we've accomplished this.
Right. Please.
Thank you. Carla Alvarado with the AAMC Center for Health Justice. And I had a question for each of the speakers. So for Julia, is there a population-based database that Quest has, given that it has the diagnostic data for an amplitude of chronic disease and acute and contagious disease? And then for Letitia is, what prompted you to pursue representing the people? Because we need more people who are trained in health to take political action. And then to the two speakers, Mr. Woodson and Ms. Levine, can you tell us a little bit about how you convince people to share data with you, to share their life, just because trust is going to be so important moving forward when we talk about data collection efforts, especially since they're being suppressed across the nation. So thank you.
So I guess I'll answer first. So yes, we definitely do population health studies. Of course, we can use our database as long as everything's de-identified, but certainly for any particular areas of interest, we certainly have the mechanism to do those kinds of analyses. One thing I forgot to mention too is for those of you that are in clinical research, we also have experience drawing samples that we may not test, but we're drawing them for you, for your research purposes. So just know that that's another service that we can offer if that's something of interest to you.
Dr. Plummer?
So I'm an a large member for the city of Houston, which means I am actually like a mini mayor. I mean, I cover the entire city, just under 3 million people. Honestly, I believe because I've got that medical background, all of my initiatives have been quality of life issues. The cancer cluster in 5th Ward, my dad grew up in 5th Ward, and so it's something that I've heard about since I was a child. And so I think that all the stars aligned in a way that I'm really not a politician. I'm a doctor, dentist, that's a politician. So I always come from that first position of first do no harm, and that oath that I took. And so I think that I'm probably a unicorn in a lot of ways. I think that it inspires, though, my colleagues on council now understand the importance of it and why it's important to do this work and to look at healthcare and not think that just because you're an elected official doesn't mean that you can't touch healthcare. And so I think we just have to start the conversation. But that's a little bit about why I feel like it's incredibly important. And I think as politicians, we kind of fall in this box sometimes, but as a scientist, I'm always looking for a solution. It's kind of how our brains work, right? And so what I'm hoping to do is just get more elected officials to understand there's not a money bag at the end of the rainbow here. There's no financial resource here. We take an oath to do the best for our communities, and that's what we're supposed to do. And it's our job to reach out and find partners in different places that may not that have the solution for a problem that we see.
Sharon?
I wish I could say the same thing for St. James. We don't have that. Our politicians are in the pockets of industry. We have to do the work. We have Columbia University that's funding us with finances to do urine samples. And so we're getting ready to start that in May. And just like I said, we have the doctors from New Orleans. They happened to see us when President Biden came to New Orleans to Tulane for the Hot Shot, whatever it was called. And they saw us and they asked us if they can help us and get the community together and talk to them about doing blood samples. And they're the one that's getting it started, and we are presented to the community. But our politicians, not one help us, not one. And the ministers don't help us either. We have one named Father Vincent Dufresne. He came, we went to meet with him, and he's on our side. He's helping us. We have one minister that comes to our meeting, Reverend Samuel Jones. The rest of them, they're in the pockets of industry. They don't care. They don't care if we die. They don't care. They want more industry to come in so they can fill their pockets. The people is nothing to them. Their families are nothing to them. So we have to do it ourselves. So when the people that's sick, they come to us and tell us their problems, and they ask us for help. And we're doing the best that we can. Thank you.
Arthur?
I have fun doing what I do because I get to make politicians mad. I make a lot of people mad, man. It makes my day. That's why I was a telemarketer, because I got to call people early in the morning and make them mad. My fault, I'm sorry. But no, I seriously have fun doing it because, you know, people in our community is suffering and they are not having good days. So every day that I can make one of them mad, I mean, I smile with joy. I learned their game. Their game is documentation, not emotions. And when I learned their game, I started using Republicans against Democrats, Democrats against Republicans, because that's what they do with us. And if it doesn't work, they use the nuclear bomb, which is the race issue. So I went and got the militia and the Nation of Islam to come together, and I took both of them down to the state capitol with me. So all these people are on my Facebook page, and the state trooper, she was the post commander, and she said, "All right, I hate your Facebook page." I said, "Why, LT?" She said, "Because you make people mad." And I said, "Well, do what I ask, and you won't have to worry about it."
That's right.
So they fear my Facebook page. So when I found that out, I started, you know, doing things on Facebook, like sending subliminal messages to them. So Nmqf was a pot of gold to me. I mean, because they got a lot of stuff, especially data. So not only cancer do we have a problem or issue with cancer, we have a problem with kidneys and cardiovascular, because they use orthophosphates to recoat our pipes from where the lead was leaching. ATSDR found out that orthophosphate, excessive amount, which we have in our food, drinks, and everything else, can cause kidney disease and cardiovascular disease. Our numbers are 3 times higher than the state, and 2, I think, higher than the nation. So what I did, since everybody likes to be data-driven, I called Nmqf, Caroline, and I said, "Caroline, you in data for Nmqf, I know you can get this information. I need numbers for kidney disease in Flint." Man, he did it so quick, I was like, "Oh man, that's great." So I had a meeting with MDHHS directors. I went down to Lansing with this data that Caroline had given me. They looked at it, they got to whispering and looking and doing all kinds of stuff. "Oh, all right, we're gonna have your information. We're gonna have," they had American Kidney Society. They had the CEO to call me, and we all did a Zoom with MDHHS. Everybody's wondering, man, how are you able to get these directors and all these different politicians to move? Things has changed. The fight has changed. It's no more sitting down at the table where you used to could shake hands and things was done that way. But now you really have to actually fight for what it is that you need. And I'm not the type, if you call me in, that means that you done already went to the table and tried to compromise and you done tried to talk. And I'm more of the bulldog that's gonna come in and just take everything because we didn't already tried to talk to you. And that's how what you were saying, the elected officials, the pastors, they're looking for campaign contributions when we're looking for help. And I got a chemical company shut down with EPA just, 2 years ago, that was contaminating our water when we was on Flint River water. So now they going to court right now because he has 20 to 30 something charges for contaminating the Flint River. Things can be done, but it's a certain way of doing it, and using data and fighting their way, their game is how you do it.
That's right.
I believe there's a question over here.
Yes, thank you. Camille Campbell from Acclinate. Thank you all for this great panel, and thank y'all so much for sharing your stories in Flint and in St. James Parish. My question is for the entire panel, but maybe more so for Dr. Puckrin and for Councilwoman Plummer. So in our current environment, those people at agencies like the EPA or the CDC who would suss out these clusters where they haven't been identified already have been fired, terminated, let go. A lot of resources at that level are being taken away because they focus on environmental justice and, DEI and things that have been weaponized. And so I'm curious, what are your recommendations for us in the room, besides the way we're, currently partnering, but how can we mitigate that, for the clusters and whatnot that haven't been identified already, and there's not enough staff to go out and do the work to identify them? What do we do?
So just quickly, can you talk a little bit about what Acclinate did in Houston, and we'll get the link out so folks can see. But why don't you tell a little bit about your film?
Sure. So, Acclinate, we have a community engagement platform called Now Included, and through that platform, what we did is we partnered with Nmqf and Councilwoman Plummer and those in the Fifth Ward to allow the patients and the community members who are experiencing this to share their stories. And we created a documentary. It's about an hour long, and we have some QR codes if you like to scan and watch, but it's very powerful. But we know the power behind patient stories and people being able to speak what they have experienced and show how they're willing to fight for what they feel they need to fight for themselves and for their communities, and we gave a platform for them to be able to do that. So,
please.
Yeah, no, thank you. You all doing that documentary for us, I'm telling you stories, and just what you've heard here, you have to know someone in your life that has that experience. It just makes the conversation relatable. And so telling those stories, it was healing for those folks in that community, honestly. So thank you so much to Acclinate for doing that for us. In terms of the federal government, it's time to get local. It's time to get real local. And making sure that your elected, your county officials, in our situation, the state is not even really on our side. It's really the city of Houston. And in our program, I want to be really clear, our program is city supported, but it's not really city driven. I mean, I am a council member, but this didn't have to go to a vote. It didn't have to go to council to be supported on. This is something that we just bogarted this thing. I mean, we just said, listen, we don't need to have pastors involved, not saying badly about pastors, but we don't need to have all the local officials involved. We don't need the mayor involved. This is about people, and it's people driven. And so I think that's one of the reasons why this has been so successful, is just because we didn't have to get permission from anyone. And I was always very public about that, even to the community. I am your council member, but I'm here as your neighbor. And I think that was also something that kind of allowed them to trust us a bit more. But it's time to get very, very local. And when people in your elected positions are not doing what they're supposed to do, then you get them unelected. It's really, it's really, really true when we say that. And so congratulations on that piece. But I know it's challenging politically because everyone's looking for financial support. But find elected officials also that have a job. Like, I have another job. Like, this is a hobby for me. And so when I don't have to take $30,000 or $15,000 or get a kickback from an industrial company, it allows me to be a lot more authentic and autonomous in terms of the decisions that I make. And so I would say, elect people that have their own resources and their own funding when you're looking to hire business people. They're really good doctors, and I'm not lawyers, y'all, but but hire people that really are not connected and don't need a kickback. And I think that's another piece of the conversation. But keeping it really hyper-local in this space, and finding nonprofits and amazing partners like Quest, and then our community that come out and tell stories like they did on the documentary. I mean, this is multifaceted. And then all of you in the room that I know are going to jump in and help us out with the last pieces of this puzzle. I know that's a long answer to that question, but it's definitely multifaceted, but takes everyone. But start at the ground, your city and your local government, because those are the people you can go to the door and you can knock on the door, or you can come to a council meeting, or you can make an appointment with them and have conversations. And then obviously also your nonprofit advocacy groups. So like Air Alliance is a huge partner of ours. Environmental Justice, a huge partner of ours. We've got those local COCO, another partner of ours. Those local groups that are on the ground, that are doing the work, that can that get the funding from grant funding, et cetera, that can allow us to give the data that we need, and then we go to an Nmqf, and then now we're talking, so it just kind of keeps on building each other. But right now, we can't worry about the federal government. We've got to take ownership of this thing, and we've got to take it by the reins, or the horns. I'm from Texas, by the horns, and we have to do what we need to do to take care of our communities.
That's right.
So we're about to end, but I want to add just a little bit more context to the story. So there have been a number of other companies that have supported this as well. So when Nmqf goes into a community, we just don't show up when they say we're doing a clinical trial. We go in and we listen and we become part of the community. Because one of the things that constantly gets asked is, are you going to be here for a long time? Are you going to go away? And we have to say, no, we're not going anywhere. We're going to be part of the community. We don't actually live in the community, but we can listen and strengthen the collaborations and the partnerships in the community. So we've had a number of folks and companies that have supported us, and I want to certainly acknowledge Exact Science, Bayer, AstraZeneca, Genentech, Gilead, because when we go into those communities, we do mini clinics and fairs and town hall meetings well before we ever get to any clinical trial or anything like that. And so what we say to them is, we want you to partner with the community. We just don't want you to come in and go away. So they support the local vendors, right? They themselves become integrated in the community. And the reason behind that, and this is the historian in me, and I'll end with one historical story for you. During World War II, one of the things that the American military learned, that at the point of attack, you had to bring your Army, your Navy, your Marine, and your Air Force. And you use that combined energy to overwhelm the problem. And that's what we're saying here. We have to bring combined forces. There's Quest Diagnostic, but there's Exact Science, there's Grail, there's Bayer, there are a lot of capacity with lots of different skill sets. Each of them, we're not saying come out of your comfort zone, we're saying do what you do, but do it in this community, because for God's sake, the people are dying of cancer every day. When you sit and you listen to these stories about people who lost generations to cancer, you have to do something. And so that's the message I would leave you with here. We're going into other places. We're going into Flint. We're going into Louisiana. We're going into Selma. We're going into North Carolina. there's an opportunity for you to make one hell of a difference. And I'm going to tell you, you're going to feel so good about it. And probably to me, and I'll end here, the most amazing thing about it all, the people don't even know you did that for them. They don't even know, and it doesn't matter.
That's right.
But you know what you did. You transformed and saved lives so that parents get to see their child grow, that children end up with grandparents, that we set up the next generation so that they don't have to deal with these problems. I think that's what you're in the business of doing. If you're in the business of healthcare, that's the job. And so I want to thank the panelists. I know that Arthur and Sharon, they're your vanguard. They're on the front line dealing with this every day, listening to those stories. And certainly, Quest Diagnostic has been a fabulous partner. Couldn't ask for anything. They were there not just blood, but helping us understand how we need to go about this and do it in the right way, so that when we come out of this, we actually have a set of data and information that can actually use. And for Dr. Plummer, oh, she is a state of art. I'm telling you, I've learned so much working with her. If every politician was like her, America would be a very, very different place. And so please join me in thanking the panel. Okay, great. I believe it's time for drinks. Brandon has given me the sign, the bar is now open.